Happy morning to all participants, all faculties, or panelists to International Digital Dentistry Congress in a day two, that is on Sunday, 3rd of August. We have one or two participants, paper presenter is there in our Zoom room, and we have two distinguished jury panelists, Dr. Rohit Agarwal and Dr. Aparna, with us. We are waiting for another, say, 4 5 minutes and let other participants as well as panelists join, and then we'll start the session for today. So we'll from 10 to 11:30, half past 11, we have 10 presentations, five from students category and five from faculties. So they're gonna present, and then we'll start with the 11:30 with our first speaker, Dr. Shanin Farista. She will speak on laser and dentistry. So we are just waiting for another, say, 2 3 minutes. Let the people join in and settle in, and then we'll start. Thank you. नीचे क्यों हो रहा है? ऊपर। काम करना। Happy morning to all participants of International Digital Dentistry Congress. This is Dr. Nurul, the organizing chairman and your host for the day two. And it is now 10:06. So we have three distinguished jury. Our judge is in the waiting room, rather in a Zoom room, and we have the participants as well. So without wasting much time, because we have back-to-back sessions now onwards, so we'll start with the sessions with the paper presentation session. So I'll first formally introduce our. Uh, right now we have three. Panelists, three jury with us, Dr. Travel Pereira, Dr. Rohit, and Dr. Parna Dave. So let me introduce uh, uh, them formally, and then we'll start our session. First, I'm just giving you the brief introduction of Dr. Travel Pereira. Dr. Pereira completed his graduation from Nair Dental Hospital Dental College and went on to the post graduation from the Government Dental College in the subject of oral and maxillofacial pathology. He is about 3 decades of experience, clinical experience, and he has guided many undergraduates, PGs, PhD students. He has about 150 publication in national and international journals. He has, contributed, written 5 books, which has co-authored. He has reviewer of numerous journals in a pathology, oral and maxillofacial pathology. He is also an executive committee member of the Indian Association of Oral and Maxillofacial Pathologists. He is presently working as a vice dean and professor and head Department of Oral and Maxillofacial Pathology at DY Patil University School of Dentistry, Nerul, Navi, Mumbai. Dr. Pereira, could you please unmute? Are you there? No? Yes, you are there. So our next, uh, uh,
Yes, I'm there. I'm there.
yeah, yeah.
Thank you so much for the introduction.
Thanks, thanks. Then we have the next jury with us, Dr. Rohit Agarwal. He is having 15 year of clinical experience, and he is known in the name of dental implantology. He would be coming as a speaker in this program again. And he's the head of the department of Agarwal Hospital Research Institute, Gwalior. He is a professor at Maharana Pratap College of Dentistry, Gwalior. And he trained in implant dentistry across USA, Brazil, Dubai, and several other countries. He is the first dentist in Gwalior to initiate dental implant workshop, and he's conducted numerous national and international implant workshop, attended 50 national and international conferences, and he has more than 10 scientific papers in reputed journals, and he's a recognized mentor and leader in promoting modern technique in dentistry in India. Then we have our distinguished jury, Judge Dr. Aparna Dave. She's a professor. She has spoken yesterday on digital pathology. She's a professor and head the Department of Oral Pathology and having over 21 years of experience in teaching and research. A graduate and postgraduate from the prestigious Government Dental College and Hospital, Nagpur, and specializing in potentially malignant disorders of head and neck region. Dr. Dave has contributed to several national and international publications and guided numerous research projects, including undergraduate and postgraduate dissertation. She is actively involved in academic and activities at the Faculty of Dental Science and university level and regularly participating in national and international conference. Then we have two panelists or jurists. Let them join, then I'll take few moments to introduce them as well. So let them join first. So we are going with our first participant, We have the Dr. Bhavna Lenka. She's supposed to speak, but right now we have Dr. Vritti V. Sangvi. Dr. Vritti, are you there?
Yes, I'm there. Can you hear me?
Yes. So, please give your brief introduction and share your slide. We have three jury with us, Dr. Travel Pereira, Dr. Aparna, and Dr. Rohit. They would be judging you, giving you the marks 0 to 10 scale, and it will be published when later we have that who is first, second, third, and all. So over to you. You can share your slide, give your brief introduction, and you can start your presentation. Yeah, over to you, Dr. Vritti V. Sangvi.
Thank you so much, sir. I have sent a request to be able to share my slide.
Just just
Dr. Anwar, make a host, co-host,
yeah. I'm just making it.
Dr.
Okay.
Vitti.
Yes.
Can you see my slide?
Yeah, your slides are visible. Yeah, reviving live prints. Yeah.
Can you see?
Yeah, it's a visible reviving lip prints, a journey
Yes,
into
yes.
AI driven silent
Okay.
face recognition. Yeah.
1 second. It's not visible here. I'll just check. Yeah, much better. Can you see? Can you hear me?
Yeah. You are visible,
Okay.
you are audible, your slides are visible.
Okay. Can I start?
Yeah, you can start. Yeah.
Okay. Good morning, respected jury, all my fellow delegates. I am Vriti Sangvi, a third year BDS student, is thrilled to take you on an exciting journey of reviving lip prints, a journey into AI-driven stereoscopic regeneration. Artificial intelligence, it's the buzzword of the century, isn't it? We live in a time where machines learn, evolve, and sometimes even surprise us. Well, but let's talk about this technological marvel wherein the artificial intelligence intersects with the art of stereoscopy, which is basically study of lip prints. Imagine this. You are at a crime scene. No fingerprints, no hair samples. But wait, there is a smudge of lip print on that coffee cup. This is where AI steps in as the hero of our story. AI can bring its superpowers to the table, making it possible to regenerate, analyze, and even match the incomplete lip prints with an outstanding accuracy. Think of it as a digital phoenix rising from the ashes of the partial data. Coming to what is stereoscopy? Stereoscopy could be a new word for many. It's basically just like fingerprints. Lip prints are unique to every individual and can be used for identification on the lips. In 1974, Suzuki and Toshihashi came up with a six lip print classification, which is, as you can see, type 1, type 1 dash, type 2, type 3, type 4, and type 5. What are the application of stereoscopy in dentistry? Or in just overall worldwide, what can be the application? It is used as a forensic tool for investigation and identification purposes, biometric application, security, access control, and personal identification. Medical diagnostic can be related to genetic disorders, and the last one is anthropological research. Lip prints can also be used for human evolution and population differences. Coming to the next slide, what is the history of lip prints and how did we think that lip prints can be used as a identification technique? Well, in 1930s, Edmond Locard, a French criminologist, was the first person to identify lip print analysis. From 1960s to 1970s, Dr. Martin's lip print characteristic identification and Dr. Suzuki and Dr. Toshihashi's lip print classification were done, and it established the potential of lip print as a reliable source for identification. In 1961, Compton, in his book of forensic, said that lip print is one of the special techniques which can be used as forensic personal identification. And in today's generation, lip prints has become an accepted forensic technique alongside DNA and fingerprints. Coming to artificial intelligence, the definition is on the screen. It's very long, but if I were to break it down into simpler words, AI is a complication of human frameworks ready to perform assignments which typically require human insights. It is basically divided into three things: machine learning, deep learning, and convoluted neural networks. Machine learning basically teaches the computers to think the same way that the humans do. Deep learning is related to the structure and the function of the brain, and CNN is a type of deep learning. Coming to, let's see how exactly an AI and a stereoscopy can work together over the generation. In 2004, Jim O'Kim came up with a multi-resolution approach wherein he used CCD cameras for lip print recognition. In 2008, there was Adobe Photoshop 7 which was used. In 2011, a brute force algorithm of accuracy was used, which gave an accuracy of 89.5%. Uh, Next one was 2013, wherein Smacky came up with a technique to analyze lip prints with a fast normalized cross correlation technique. But this was distorted because it did not take into consideration blurred and distorted images. In 2013, again, Verbal came up with a section comparison of each lip print segment. And 2022, a lip print recognition network was made, which gave up an accuracy of more than 98.9%. Now, let's exactly see how exactly will an artificial intelligence software help us restore a lip print. Well, the step one, like how exactly can we restore a lip print if we have a half lip print? The step one is data collection and preparation. The high quality images are collected, pre-processed to enhance the quality and remove the noise and standardize each specific image. Step two is feature extraction. Features of lip prints like papillary lines, edge contours, size, shape, differences between two wrinkles, the dimension, the angles, the curvatures, the fissures. All of this is very unique to every individual, and every little detail adds up a piece to a bigger puzzle. The third is AI algorithms. For an example of GCN networks and GAN can analyze complex images. Step 4 is training process. Step 5 is application. Where exactly can we use it? It is used in medical reconstructive surgeries, and it can also be used at a crime scene. If in case we have a half lip print on a coffee cup or on a patient's mark, if we just have a half lip print, we can regenerate them. But what are the challenges that we usually face when we are considering AI and cilioscopy? The quality of lip print matters. The complexity of the dentition and the surrounding tissues. Factors like shaft lips, swollen lips, dry lips, sex and ethnicity play a very major role in the databases. Registration and analysis of the lip print can alter due to the mobility of the lips. And last, what do we think can be the future of cilioscopy and AI? The field of artificial intelligence is not yet fully explored in this area of cilioscopy, but if it does, it can enhance the accuracy, efficiency, accessibility of AI-powered tools. It may include the development of more sophisticated algorithms like GCN network and GAN network, and developing such an algorithm which identifies, classifies, and regenerates the lip print at the same time can facilitate faster and more accurate identification, especially during the disaster victim identification cases wherein we have a larger number of database. This is my references. And finally, so here's to the future of forensic odontology and forensic identification, where a simple lip print can unlock mysteries and bring us closer to the truth and justice. Thank you.
Thanks, Vriti. Over to our jury. Please ask questions. What you feel, and then she is from category B. That is students. We have, I think, three or four or five students, and followed by the faculty would be coming later on. So on sequence wise, first to fifth are the students, and then the faculty. So this she's from a student category, and please mark accordingly. Yeah. Okay. Over to our judges.
So I would
Yes.
like to ask
Hello,
you.
Vritti.
Okay.
Yes, ma'am.
Okay, sir, please go ahead, sir. Please
No,
go
ma'am.
ahead.
Ma'am, you ask. After that, I'll ask. You please go ahead.
That's okay. Vritti, you had explained that there are limitations as far as chiloscopy is concerned, right? So these limitations we face even if we are doing in a normal way.
Yes, ma'am.
So how does AI has an added advantage that we are able to overcome these disadvantages or the limitations, or the limitations are going to be same even if we are doing in a routine manner or by AI? Does
So
it make any difference in the outcome?
Ma'am, since these are the things which lip print, even if we do it a manual way, they are gonna be there. These are the some of the limitations which we face. But if in case we are doing it a manual way, there are things like not just these challenges, but even the challenges like our a human error comes into the picture. But if it's an AI, since we have already trained the entire algorithm that if it's going to be a blurred out image, you're supposed to enhance that image and then consider the classification. I think that is where AI can come forward and we can at least reduce the human errors what we usually make. But the complexity of the dentition and the surrounding tissues, all of that is still going to be the same. But the only thing which AI changes is going to be the way we calculate and way we classify, and the human error is the one which usually gets reduced.
Okay. Thank you.
Thank you, ma'am.
Okay, Vritti, I have to ask you one thing, that since we have this artificial intelligence is basically a software, am I right? So
Yes, sir.
what is this? Who is going to develop this software? Has the software been developed or is it still in progress?
Sir, so the regenerative software hasn't been developed yet, but currently me and my staff from my college are currently developing the software along with two of the engineering students. So the software is into making. We are planning our hardest. We have collected databases we have collected around 200 lip prints currently from our premises, college premises, and we are developing that software which actually can enhance, classify, and regenerate the lip print.
So are you going to come up with a new classification or are you going to stick to the same classification?
So since this is the classification which has been going on and it's universally accepted, this is the classification which we will be going, and the only thing which we'll be adding is we are going to regenerate the lip print along with just the classification.
So on the other hand, why don't you try to put in more inputs into the classification and try to see whether from your side as a student you can develop something as a new classification. Now this classification is an age old classification, so that was during that era. So now if you have developed any more dimensions which are there on the lips which can probably help you in reclassifying it, that would be a better status, because you're going to feed that into the AI, and then the
Yes, sir.
AI will decide whether it is right or wrong, right? So that error will always be there, but it always is going to be a hard work on your side if you're going to be able to develop something better. Okay, yeah,
Yes, sir. Thank
thank
you
you.
so much, sir.
Dr. Nurul, if there is no other questions to be asked, I think it's better that we move to the next candidate rather than just the screen being on by the same person.
Dr. Hatwar, are you there? Could you please share your slide?
Yes, I am there.
Yeah, yeah. You give your brief introduction and you start your slide. I have made you co-host, so you can easily share your slide.
So can you see?
No, it's not visible yet. I'm just waiting. Are you are you able to share the slide,
So just a
Dr.
second.
Hatwar? Yeah.
Just a second, sir.
Otherwise, we'll take the next participant. I'll take you after her.
Sir, it's showing that I have to leave the meeting and then again I have to share it.
You do one thing, you just leave and join again. By the time I am just inviting the next participant. Dr. Srishti Sen. Dr. Srishti, are you there?
Yes, sir.
Srishti? Yeah.
Am I audible?
Yeah, you are audible.
Okay. So I'll start with my presentation now.
Yeah, sir. Yes. You share your slide, give your brief introduction, and you start your.
Is my presentation visible?
Just wait.
Mm,
Yes. It's
Yes,
visible.
yes.
Yes, sir. Should I continue?
Yes, continue.
Okay. So a very good morning to one and all present here. Let us dive into the world of digital dentistry. The topic for today's presentation is Precision Redefined. This is a case series on the application of digital dentistry and surgical guide in the field of modern endodontics. What is guided endodontics? Guided endodontics is a modern technique in root canal treatment that uses digital planning and 3D guidance to access and treat complex root canals with greater accuracy and safety, especially in complex cases. So, what are the indications? The different indications are like the calcified canal and the complex access opening cases. And it is a game changer when it comes to endodontic microsurgeries. It is not only accurate, precise, less time taking, but it is also less complicated and makes the post op even easier. So we have been talking a lot about surgical guides. So what are surgical guides or templates? Surgical guide is a patient-specific, custom-made tool that assists the dental professionals in conducting precise surgical procedures. It guides the surgeon's instruments during the procedures. So let us talk a little about the technical aspects. So first we do the CBCT scan of the patient, from where we get the DICOM files. Then from the intraoral scan of the patient to assess the soft tissue, we get it in the form of STL files. Then by merging the DICOM and the STL files, that is the hard tissue and the soft tissue, we get the digital scan of the patient. Then we 3D print it using a 3D printer. So now that we are clear with the technical concepts of the how to digitalize our oral cavity, we'll move forward with the first case. So starting with the first case, this was a 13-year-old female who came with the chief complaint of discolored teeth in her upper front teeth region since last 2 years. There was a yellowish discoloration seen with respect to 2-1. Pain on percussion was positive. There was Ellis class 1 fracture and the electric pulp testing did not reveal any response. We advise the patient for radiographs such as IOPA and CBCT, where in the CBCT we can appreciate both in the axial and the sagittal section that there is calcification of the canal. So we started with our digital planning. So first we took the surface scan of the patient. We already had the CBCT scans, surface scan using an intraoral scanner to get the STL files. And then we superimposed the DICOM and the STL file to get her virtual jaw. And then we started with the drill planning for the calcified canal. The depth of the drill was kept around 17 mm till the middle third, from where we could see the patency of the canal, and the diameter was kept at 1 mm according to the burr that we chose. This was the presentation of the final drill, where the guide tube's angulation was adjusted in all the 3 planes of the CBCT, axial, coronal, and sagittal, and the guide tube was placed and the guide markings were made. This is the final guide that was fabricated, and in all the sections the surgical guide was checked once again. This was the 3D printed guide that we got. This was the endo burr that we used, that is endo burr number 2. This is the placement intraoral pictures when we place the guide on the patient's dentition and when we started drilling into it. The working length was determined, and as we can appreciate here that a straight line axis was there. Then GP fit was confirmed and obturation was done. These are the pre-op, the post-op, and the follow-up radiographs of the patient, where we can appreciate how beautifully it has healed and how we have managed to make the canal patent. Then these are the clinical pictures after the composite restoration and the bleaching. Now let us see the other magic of the digital dentistry with our second case. In the second case, this 36-year-old female came with a chief complaint of pain in the lower left back region of jaw. These are her clinical pictures. We advised for a preoperative IOPA. The intraoral photograph showed that she had a separated instrument in her 3-6 with in the apical region. Then we advise the patient for CBCT for a more clearer view. Here in the CBCT scan, we can appreciate that there is a radio opaque material present at the apical third, which is very evident in both axial and the sagittal sections, which was approximately 4.5 mm in length. Then we started with our digital planning, and volume rendering was done to achieve the surface of the tooth. Then we started with the digital planning for the file retrieval and the apicectomy. The guide tube was positioned according to the location, that is the apical third, and we also measured the diameter and accordingly made the guide tube. The positioning was done and the surgical marking along with the windows to avoid the undercuts were made. Then it was 3D printed again using a 3D printer. So as given in the literature, first of all, the root canal treatment should be done before proceeding to the apicectomy, and this was performed by a trained endodontist in our institute. These are the post-endo radiograph of the post-endo restoration. Then we started with the surgical procedure. After pre-surgical evaluation, incision was given and flap was raised. And then we placed, as we can see here, our guide. And then we drilled a hole using the trephine burr and osteotomy was performed. And root resection was done. And this is the file that we retrieved from the osteotomy from which was planned digitally, and then suturing flap was again confirmed and raised again, and suturing was done. These are the post-operative radiograph, and this is the post-operative follow-up radiograph, where we can appreciate that the separated instrument has been removed, and also that apicectomy has been very beautifully done. So these are a few similar cases that I have done, and this was again a case where this boy was having trauma in his anterior teeth. This time we saw that not just one but two of his 1 and 2 of his teeth were calcified. Again, a virtual guide was made, a virtual jaw was created, and digital planning was done for both the access openings. The guide was again fabricated using the same method. These are the intraoral pictures. This case is still under follow-up, but the straight line access was achieved, and we are hoping that this will also give us good results. So clearly the thing that is transforming is not the technology, it's the technology that is transforming us. Thank you, everyone.
Thanks, History. Over to our judge, yeah.
Yeah, so I have just one question that the third case which you showed, which showed that the canals was calcified.
Yes, sir.
Later on, when you did a radiograph there, we could see the canal very clearly. When you did the used the diagnostic, the canal was very, very clearly visible. I
Sir,
can't, or the canal was created. You created a canal.
yes, sir.
Okay, so the canal was not visible.
So it was completely calcified,
Uh-huh.
as we can appreciate here in the sagittal sections of the CBCT, as we can see here, that in both in 2-1 and 2-2, we cannot appreciate the canal at all. This is a case of complete calcification.
Correct, correct. So this
So
is the y'all created a canal and then
yes,
finally
yes,
obturated the tooth.
yes, sir.
I think all the three cases are very wonderfully done. And
Thank you, sir.
what I want to only understand is, if this is a procedure that you have used artificial intelligence and you're used basically a CT scan, what was the expense for any one of the case which would be incurred for the patient? Was it done in your hospital or
Yes,
was it
sir.
done in a private clinic?
No, no, sir. Sir, I am still a junior resident. So
Okay.
this was done in our hospital and this was done along with the Department of Endodontics. And I am from oral and maxillofacial radiology.
Okay.
So we did this together and the cost of the patient was very minimal. Just the printing cost was given to the patient. That was around 500 to 800. Just that.
Okay, ठीक है. Thank you so much. Very
Thank,
wonderful cases presented.
thank you so much, sir.
Yeah.
Hello. So, any more question, Dr. Nishan? Could you want to ask any question to Dr. Srishti, Dr. Aparna? Would you like to ask any question before we are moving to the next?
No questions.
Okay. So
Thank
No
you.
before
question, Dr. Anwar.
yeah, so before
Please
Thank
go
I
you.
ahead.
move forward, let me introduce Dr. Nishant. He just joined in. He is facing some technical issue in joining the program. So Dr. Nishant Kumar is a professor and head of the Department of Oral Medicine and Radiology. He has completed his graduation from SJM Dental College, Chitraguda, Chitradurga, Karnataka in 2008 and post-graduation from Raja Muthiah Dental College and Hospital, Annamalai University, Tamil Nadu, in 2014. He has been trained in CBCT from Manipal University in 2017 and working as a consultant radiologist. He has published various papers in national and international journals. So, with this introduction, I am moving to our next presenter, Dr. Smruti Hatwar. Dr. Hatwar, are you there? Can you able to share your slide now? Last time,
Yes, sir.
yeah, please try to share your slide. Yeah. I have made you a co-host, so I think this time you won't have any. Yes.
Sir, can you see it now?
Yeah, it's good. You introduce yourself and then go to your representation. Yeah.
Good morning, everyone. Today, myself, Dr. Samruddhi Bandhu Hatwa, we are going to present. My topic is Artificial Intelligence in Oromaxillofacial Surgery, a comparative study for the diagnosis and the treatment planning capacity with clinical expertise. So, as we know, diagnosis is very important for any treatment plan, and curative for the patient well-being. So for the diagnosis, the first step towards the cure is to know what is diagnosis. For diagnosis, the three major important things are history, physical examination, and investigation. Collecting all these, we go and conclude for the diagnosis for the patient. As we know, facial trauma is the most common and complex challenge in oromaxillofacial surgery, often involve fracture of ZMC, orbital, mandible, and precise diagnosis can help in functional and aesthetic restoration of the patient. As we know, patient aesthetic and facial functional is very important in terms of looks and everything. As far diagnosis, we do the proper diagnosis, proper treatment, the earlier well-being of the patient can be done. There is some bone articulated respect to ZMC. I will like to explain. From the upper side, there is a frontal bone. From the anterior side, there is a maxillary bone. From the posterior side, there is a temporal bone. And from the superior side, there is a sphenoidal bone. What is the objective? To compare AI assisted diagnosis treatment plan with the clinical expertise. As we know that AI has been so much impact into day-to-day life. As we need anything, we just have to click one button in your phone, your light, your camera, your AC can be on. Nowadays in the car also AI assisted devices has been input where you can do auto parking, auto driving. If you are just craving for the food or anything, you just have to go AI assisted machines and you just have to click some buttons or instruct that button, and within some minutes the food has been ready. AI has been impact so much into day-to-day life. Do that AI can impact in the medical field? Yeah, many where the input of data or getting data, recordings and everything has been included in the AI in the medical field. But do this AI can assist or help in the treatment planning or in the surgery planning, where the clinical expertise, we are going to compare that in this presentation to assist the accuracy and effectiveness of AI system in oromaxillofacial surgery, to evaluate the clinical expertise with the AI in the decision making. What is the methodology in my presentation? Today, there is a comparison analysis group and testing group. The device which I am going to use, the latest ChatGPT 4.0. The parameters which I am going to take is the diagnosis, treatment planning, and outcome of the patient. As we know, the rise of the artificial intelligence, the most modern, the latest which I am going to use is ChatGPT 4.0 in this study. I have assisted the AI with the real patient of 37 years old male patient who has been trauma in the right side of his face, which has been fall down from the height. Clinically findings, we have find 3.5 centimeter laceration, periorbital hematoma, step deformity, of the orbital rim, and preserve the ocular and sensory function. This all information I have assessed to the AI and also given some clinical photos. According to that, what AI has given me, the ChatGPT has given the provisional diagnosis and differential diagnosis. The provisional diagnosis, they have given right size orbital and ZMC fracture associated with soft tissue injury and periorbital hematoma, and differential diagnosis ZMC complex fracture, orbital floor fracture, nasofracture, mandibular fracture, and soft tissue injury with no underlying bone injury. What was the final diagnosis? For final diagnosis, I have provided the radiographic of the patient. With the help of all the radiographic features, the final diagnosis was given right side ZMC fracture with orbital 4 rim involvement and mandibular fracture. After that, the ChatGPT, what he has given me the surgical planning. They have given me 3 incisions should be taken to this patient. Transconjunctival approach for infraorbital rim and in orbital floor axis. Then lateral bow approach for zygoma frontal suture exposing, and intraoral vestibule incision for the buttresses. Okay. After that, the reduction, they have since the displaced the zygoma bone which has been undisplaced. We have to make it proper by reduction forceps, and normal anatomical contour and alignment has to be restored. After that fixation, they have tell 3-point fixation. Zygoma buttress fixation, orbital rim fixation, and frontal suture fixation. And for the orbital for reconstruction, they have advised for the mesh or the implant if any muscle deformity is or deficiency is present. But according to the clinical expertise, what our clinician says, they have given the similar provisional diagnosis and the final diagnosis. So I'm not going to repeat it. So I'm not going to repeat it again. It's the similar what AI has also said. Final diagnosis, the different only is that they have just given the mandibular fracture, but clinical expertise has gone more detail where they have explained it is a condyle plus ramus fracture involvement. And what the clinical expertise has done is the 4-point fixation, whereas AI suggests for the 3-point fixation. And the incision which the clinical expertise has gone for the lacerated wound, they have just exposed the lacerated wound and figure it out the reduction of the fragment. For the sphenozygoma and frontozygoma, the fixation of the frontozygoma suture was done by the 4-point and 4-point gap mini plate. After that, the reduction of infraorbital rim, they have gone for the infraorbital incision, and the reduction of the infraorbital rim and fixation was done, whereas the AI suggests some other kind of incision to be taken. After that, the reduction of the body and the arch was done from the same lacerated wound, and the fixation was done. And for the buttresses, they have gone for the vestibule incision, and where the L plate was been placed for the reduction. This is the final look of my patient after all the reduction was been done. 2.2 layer suturing was done, and this is the post of OPG and water view of my patient. Comparison. Comparison. This is a case comparison where AI clinician expertise. So basically, the case was ZMC complex fracture, where AI suggests you the 3-point fixation in infraorbitally rim placement or the titanium mesh placement, whereas clinical expertise has got for 4-point fixation with the infraorbital incision and intraoral approaches. Outcome, it has given almost similar post-operative result if we compare, but with the timing, AI has given a reduced timeline, whereas the clinician has given more time. Result, diagnosis accuracy, AI has given 92%, clinical is 95%, time, AI has given 15 minutes, clinician it is given 40 minutes. Agree with the treatment plan was 80%, clinical confirm with AI was moderate to high. Discussion. As we know, artificial intelligence AI in the oromaxillofacial surgery has been very powerful impact tool used in the modern clinical practice. It helps doctor in the quick analysis of X-ray, RVGs, CT scan, patient history, which make diagnosis faster in the facial trauma condition and easier also. AI is also associated with the treatment planning, which provide where we have provided a large amount of previous case detail. It also help in reducing the human error and save time by automatically writing the report writing or providing the conclusion. In the complicated case such as trauma, tumor, reconstructions, it give a valuable support to the given, give extra and valuable support to the surgeon. But However, AI cannot replace the doctor. It is the lack ability to understand individual emotion, complex medical background, or sudden change during the surgery. The real-time treatment, real-time decisions to be need judged by the skilled clinician, while AI can improve and can help you in suggesting or can help in making more clear, but it can also make mistake if the information is unclear. Therefore, AI should always use as a supporting tool, not a substitute for the human expertise. Last conclusion I would like to say, AI is a valuable agent in oromaxillofacial surgery for diagnosis and treatment planning. Further, integrity and training can improve the reliability. Collaboration decision making remains the key for optimal outcomes. These are my references. Thank you everyone for giving your time and listening my presentation.
Thanks, Dr. Hatwar. Over to our judges for the questions.
This is a very good case presentation, but I just want to understand that with such a deep crush injury also, you all were able to achieve both similar results with artificial intelligence as well as with the doctor's diagnostic approach, which was quite similar, but with so much of damage. What was the result outcome? How much did the patient benefit from all this? I need to just want to know that.
Sir, actually, the study was about the diagnosis and the treatment planning, what AI gives and what the human expertise does. Yeah, the final result was almost the similar only, but the approaches was different. They have given 3 different kind of incision, which was not needed in my patient. Whereas I could have just used the lacerated wound and I would have gone easily and exposed the fragment. Uh, Final diagnosis almost was the same to restore the contour and anatomical position of the patient. For further more investigation, we will going to need CT scan and compare the right side ZMC and left side ZMC, how much the contour has been come to its normal position, what is the difference, because the mala prominent will be the similar at the both left and right side. The which further investigation and all we will need, sir.
Okay, thank you so much.
Yeah. Hello.
Yes, ma'am.
See, I wanted to ask, as far as the treatment plan is concerned, I'm not into that much, but I would like to ask you, uh, do you use ChatGPT to decide your treatment plan?
No, ma'am. We don't use ChatGPT to decide the treatment plan. But nowadays, ma'am, as you can see, for implant also, people are using ChatGPT or the devices like for implant associating device or digital implant also. And in the orthodontic surgery also, a lot of people are using ChatGPT or the digital orthodontic surgery planning and everything, where just they plan according to the digital and everything, and they can get the outcome in digital way only. But when we are doing the surgery, it's not how they have been planning in the digital form. Maybe there may be some
No,
complication.
but when you are asking for a plan, are you going to follow the plan which has been given by AI, or you're going to take a decision on the table like this would be the right way?
We will take the decision on the table, ma'am. We are not going to fully depending on the AI, as AI has been everywhere, but we are not going to, because the
Yeah,
thing.
if you are not put, your inputs are incorrect, or probably your pictures are not taken properly and have not been uploaded, the right magnification is not there, it's going to affect the treatment plan.
Yes, ma'am. It might change the treatment plan, but for the medical field, AI is still not developed. They are seen in training forces. Small things like fractures or small fracture fragment, they have still not been studied so much. So we will need to improve AI such that it can get equal to a clinical expertise.
And how many cases you have done using AI as a supportive tool?
Pilot study still not going on. Till 20 cases I have done comparison.
Okay. Okay,
According
thank
to
you.
that, I have given the accuracy and time.
Okay.
Any question from Dr. Nishant or Dr. Rohit? Otherwise, we'll move to the next presenter. Dr. Nishant, would you like to ask any question?
Hello.
Yes,
Yes,
Dr. Nishant.
sir.
Yeah, I would like to ask regarding how much is the sensitivity and specificity of this AI in
Uh,
diagnosing oral conditions?
Oral conditions.
Yes,
Uh, so we have not. It's still a study going on.
you're not aware of that?
No, sir.
Okay, right. Okay.
Okay, nice presentation, Dr. Hatwar. We are moving to our next presenter, Dr. Shruti Saryam. Shruti, could you please share your slide and unmute yourself? Give your brief introduction and start your presentation.
Am I audible to everyone?
Yeah, you are audible.
Yeah, I'm sharing my screen.
She is last but not the least in a student category. Then we'll start with the this faculty one.
Is it visible?
It's a visible.
Yeah. Good morning, everyone. Let's dive into the digital dentistry of today's world. Today's my topic of case report is transplanting the wisdom. So, to introduce, tooth extraction is one of the most widely performed procedure in dentistry. It has been historically well documented that this procedure may induce significant dimensional changes of the alveolar ridge. Dental implants are a popular treatment option for patients who have missing teeth. Nonetheless, several less extensive and invasive treatment options that involve saving the natural tooth are available and have a good prognosis and success rate. So, what are the uses of saving a natural tooth? It can act as a shock absorber. It also reduces the treatment cost of implants. It reduces the future implant related complications. It maintains the proprioceptions and it gives the pivot movement to the jaw. Then, coming to our first case, where 18-year male who is resident of Nagpur came with the chief complaint of pain in his lower right back tooth region since 6 months. On telling his story, patient was apparently all right 6 months ago. Then he started noticing decaying of a tooth in lower right back region of jaw. Along with this, he was also experiencing a pain while chewing food. It was dull and intermittent in nature and gets aggravated while chewing food and relieves at home. Patient did not seek any treatment for same and continued chewing with that carious tooth. There is no history of swelling, pus discharge, burning sensation, or any ulceration or abnormality with the carious tooth. So his medical, dental, and family history contributory. Coming to the region of interest or inspection, there is a complete destruction of buccal, occlusal, mesial, and distal wall of a tooth. There is also exposure to torsion, and overlying skin color was normal. No ulceration or intraoral sinus drainage seen. On palpation, there was pain on percussion positive with respect to forceps. So this is the preoperative radiograph where the white was showing no response with electric and the cold pulp testing. With this clinical finding, the provisional diagnosis of acute exacerbation of the chronic periapitis, that is the phoenic abscess, was given. So what was our treatment plan? We have decided to go for the extract of 4/6 and 4/8 and auto transplantation of 4/8 into the socket of a 4/6. So patient was consulted for the auto transplantation. So we have done the IUPA, OPG and the CBCT of this patient. This is the preoperative IOP of the patient where we can see the caries was reaching up to the pulpal floor and is try to expose the pulpal floor. There is also the periapical radiolucency with the mesial root of the 4/6, and this is the preoperative photograph of a patient. This is the preoperative OPG where we can see the marked radiolucency seen with the mesial root of 4/6. Now coming to the CBCT section, this is the donor tool. For auto transplantation, we have to always make sure that we have to take the dimension. What is the purpose of this CBCT? That whenever we are planning for the auto transplant, what is the benefit of that? We want to reduce the extraoral time of the donor tooth so that we can get the faster result and there should be the lesser complication with the surgery. So we will take the dimension, that is the vertical and the horizontal dimension of the donor tooth, and the deceased tooth also we have to took the dimension. Now coming to the sagittal section, we have to also make sure that the inferior alveolar canal, there should be the minimum more than 2 mm distance between the donor tooth and the inferior alveolar canal for the traumatic extraction and avoid the post-operative complication. Then comes the AI. Then we have used the third party software to to fabricate the prototype. So this is the interface of a AI, that is third party software. Now we have to mark the arch to get the desired tooth. Then we have to segment the tooth in each section. Now we are in the axial section, so we will segment the tooth. Now this is in the sagittal coronal section. Now we are in the sagittal section, and this is the cross section that we have to make sure that in each section we have to segment the tooth in each of the corner. Now this is the complete segmented tooth where we can see the segmentation was done completely. This is the volume render prototype which we can see in the left side of the PPT, which we have to convert in the STL file. Now on the right side, that is the 3D printable STL file. So this is the complete STL file where we can see the each and every corner of the tooth has been segmented completely. Now for 3D printing, we will require a 3D printing machine and the curing unit. And this is the final 3D printed model of a desired tooth. So now coming to the surgical aspect of the 3D prototype, incision and flap reflection was done. Then extraction of the 4/7 was done. Then modified ward 1 incision given for the 4/8 and trying of the 3D prototype into the 4/6, where we can see the in 4/6 there is the prototype and the 4/8 was exposed. Then traumatic extraction of the third molar was done. Then in this case we have used the PRF for the faster healing of the donor tooth. Then placement of a PRF into a socket. Then this is the insertion of a 4/8 into extraction socket of a 4/6, and the adjustment was done. And this is the suturing was also done. Splinting was given to stabilize that tooth. Then this is the immediate post-operative radiograph which we have took. Then this is the pre-operative photograph where we can see the caries, and this is the post-operative photograph where we can see the successful transplant of a donor tooth. Then coming to the case 2, this is the similar case where the 7 was carried and 4/8 was replaced in place of the 4/7. Again, the dimension was taken of the donor tooth and this is tooth both. That is the vertical and the horizontal dimensions were taken. Then distance from the nerve was taken, that is 4.94 mm. Then this is the 3D printed prototype. Then again the automatic extraction of a third molar, tooth transplantation and suturing and splinting was done. This is the pre-operative and post-operative photograph. This is the pre-operative radiograph, and this is the 1 month follow-up radiograph, where we can see the mixed radiolucent and radio opacity seen with the donor tooth. That means it is showing that the healing was started. Then this is the 3 month follow-up radiograph. There we can see the complete healing, or we can say the 90% healing was done. So at last, auto transplantation is a very predictable treatment modality that can serve as a viable option to replace a missing tooth, especially in a young patient. Proper planning and careful execution of the procedure are important to achieve the optimal long-term results. Thank you.
Thanks, Shruti. Over to our
Yeah,
Pratik for
Shruti,
question.
Yes, ma'am.
how long you have followed up this case? Like, how are the results, and how many cases you have done for as an auto transplant?
Ma'am, we like in first case, it was 3 month follow-up was done, and in second case, ma'am, also 3 month follow-up. That total 6 month follow-up was done for two patients, ma'am.
Okay, so it more than a year you have not followed up any case.
No, no, ma'am. The patients are still under follow-up, ma'am, because root was also not
Okay.
completed in that patients.
Okay, can I ask one question that you have not followed up this case and there is no
Huh.
root completion that is there? Is this tooth
Huh.
vital or not non-vital?
Sir, vitality was checked. Like in follow-up, we have checked the vitality, and we in second case we have got the vitality, sir. The tooth were vital.
So you mean to say that the apical foramen is still open, or is the apical foramen closed?
Regarding vitality, sir.
No, just now you have followed up in 3 months. Like
Huh.
after
Yes,
that
sir. Yes, sir.
post-op, did you find in the post-op, because we cannot see the 3 month post-op photograph, right? So we don't know
Huh.
if the apex has the apex of the root is open apex, closed apex, or whether the tooth is functional or non-functional. Did you keep the tooth in functional contact?
Initially it was not, sir. It is under occlusion we have kept the tooth.
So it is in function.
No, sir, it is not in function. The occlusion was not initially we have not maintained. We have
So you
done
need,
the under occlusion,
you need
sir.
to follow up, because otherwise these cases mostly the
Yes,
pulse
sir.
will get non-vital. No, when there is no blood supply, from where will there this you have auto transplanted? Ideally you should have
Ha.
done a root canal. Am I right if I understand that you have done a transplant, auto transplantation?
Hmm.
uh,
Yes,
won't the
sir.
pulp get non-vital?
Sir, the healing is still continued, sir, but we have checked the vitality after 3 months. So there is the tooth is still vital, sir.
Okay, all right.
Yes, sir. Thank you, sir.
Any question from Dr. Nishant?
No
Otherwise, we'll move to the
question.
yeah next speaker, next presenter. Okay, now we are moving our next category, that is category A, that is for speakers. We have five faculties who would be participating in their case presentation. I would like to call Dr. Arun Kumar first. Dr. Arun, are you there? Could you please share your slide, give your brief introduction, and you can start your presentation. Dr. Arun, I think I'm seeing you are there in the meeting room among participants. If you have any issue, we are moving to the next. Dr. Jasleen Ann, Dr. Jasmine Mary or Dr. Jasleen, they are
Yes,
the
sir. Here.
co-presenters. Yeah. Could you please give your brief introduction and share your slide and start your presentation? Yeah. So for judges, we have started our faculties presentation now. So accordingly, you can mark. 0 to 10 actually. Yeah. Okay.
Good morning.
Your slides are visible, Dr. Jesli.
Good morning. I am going to talk about how VR meets dentistry, a new era in preclinical training. This is taken from the Rodriguez et al. He did conducted a study and it was published in the year 2023 in Scientific Reports. We know how important as teachers we find pre-clinical training to be, but with the help of virtual reality, how is it our students in our daily clinical work and how the skills are going to improve based on their precise hand movements is what we are going to see. So, virtual reality refers to the technology that codes and compiles computer generated multisensory data to be perceived by the users as an alternative reality. This allows them to interact with simulated tasks, events, and scenarios wearing the head mounted displays. Now, haptics is a scientific discipline that studies the application of touch and control with the interaction with computers. So we have various benefits of virtual reality. They enhance the visualization, they improve the education qualities. We have collaborative learning, improving the global outreach. We have better student appraisal and it improves the research. So the advantages of virtual realities is the student can go in for a number of repetition. The
Dr.
sense
Jasmine, I think your slides are not moving. We are stuck on the slide one. It's not in a slideshow mode as well. Could you please make it a slideshow mode?
so right now.
Yeah, we are on the slide concept. Identify is a simulator, but it's not in a slideshow mode. Slides are moving, but it's not in a slideshow mode.
So right now.
No, we are not. Uh, it's not in a presentation mode actually. Slideshow mode.
So
On the bottom, no, there is a option of slide. So yeah, so your interaction is visible, but it's not. You can continue without wasting time. Yeah, yeah, continue, please.
So, is it going into the next component slide?
It's interaction slide is visible to us.
So, shall I continue like
It's the
this?
components one, yeah.
Okay. In the study, we have various components which included the visual, the haptic pen, the auditory components, the apparatus and the software, the 3D image data which was collected, a simulation environment, and the system metrics and the task assessment. So, 20 participants who voluntarily involved, basically the third year students were selected. There were three tasks that was given to them, and one was the free experimentation. The second was a task, and the third one included the feedback or guided interview. So the tasks was basically doing a class 1 cavity and a class 2 cavity. It was a class 1 cavity on an individual tooth and both on the individual tooth and a tooth inside the arch. And the feedback was collected. So we could find out that the drill time from 2 to 4 seconds was decreased with the increase in the use of the haptics. So the findings where the children got faster with the more practice, they had more hands-on model experience, and in the feedback we could understand that they felt that the Dentify improved their hand skills and force control with the manual dexterity, and they had interest towards the subject. So, to conclude, Identify helps in the especially in the preclinical students. They help to improve their skill, reduce their mistakes, and making their results more consistent. However, we have to use them at the right time in the dental education. And the newer Identify includes a virtual mirror for indirect vision, a full and a single tooth practice, and a feedback to track their progress. Thank you.
I have no questions. Thank you.
Dr. Jasmine,
Yes, ma'am.
you were talking about training the undergraduates. at what stage of the curriculum would you like to introduce it? And second is, what is the cost factor involved in it?
Ma'am, at what stages they have to at least pass the second year, or they have to get the anatomy, and after the first year, sir. Basically,
But they
they have
start their basic work from cavity cutting from second year itself.
it would be best if they have touched the typhos and then go in for the 3D sensation before going in for the patients, ma'am. But not before the second year. Well,
Okay.
it was found that those students who were aware of the tooth had better results, ma'am.
Okay, and any idea about the cost factor involved? Like, suppose the colleges would like to introduce it.
So far, no, ma'am, but it is in the high cost. It is costly, ma'am.
It's pretty expensive. I know that. Yeah. Okay. Okay, then.
Okay. So, Dr. Arun, would you like to present now? You are there
Yeah,
again.
yeah. Yes, sir. Good morning.
Very good morning. Your slides are visible, Dr. Arun.
Oh, thank you. Good morning, respected judges. Topic of my presentation is I am Dr. Arun Kumar Tiwari. I am a MDS in prosthodontics and currently working as associate professor in BBD Dental College, Lucknow. I am presenting the topic that is a current trend in surface modifications for dental implants. So throughout time, various methods were proposed for teeth replacement, like dental implants, or tooth supportive bridges, removal dentures, fillipers. But among them, dental implants was found to be most effective solution. So the first dental implant were made of metal, such as titanium and its alloys, stainless steel, gold, tantalum, cobalt, chromium alloys. Despite being the gold standard for dental implants, titanium and its alloy continue to raise concern over its toxicity, immunostimulatory potential due to the release of the titanium ion into the surrounding tissues, and the aesthetics. So as a result, research efforts were concentrated on creating a new material that have the potential to replace the titanium in dental implants. So ceramic and polymers offers a viable substitute, but ceramic works well in the terms of osseointegration and tissue regeneration because their inert nature. Ceramic is very inert in nature, so their main flaw is that they don't have sufficient mechanical qualities such as brittleness, low fracture toughness, and ductility. Moreover, study shows that the polyether ether ketone, that is the PEEK, could represent a promising option for patient that has intolerant to titanium. But the main disadvantage of PEEK is that it is associated with polymeric implants, which is higher cost production and possibility to generate foreign body reactions. So considering this fact, the general conclusion is that the best option for producing highly performant and cost-effective dental implant is to maintain the titanium as a main material and applying various surface modifications technique to overcome the disadvantage that is mentioned above. So in response to these, throughout time, several types of surface modifications were proposed. And
Dr.
according
Arun,
to
your slides are not moving, I think. Yeah, please.
now it's moving.
No, we are on the stuck on the slide 1 only. Yes, introduction now.
Now it's moving.
Yeah, it's moving. We are on the introduction. Go ahead for the next. Yeah. Yes, yeah.
Oh.
Okay.
So in response to these issues, throughout time, several types of studies on surface modification was proposed, and according to level of their complexity, they were divided into 5 generations. So the first generation is the mechanical, second is the morphological, third generation is the physicochemical, fourth generation is the biochemical, and fifth generation is the biological modification. So now we are in the fourth and the fifth generation, that is the biochemical and the biological modifications. So these are the generation according to the trends of surface modification. So it has found that the implant failure rate of titanium varies between 5 to 11% depend on the implant composition. And the main cause of the phenomena are the mechanical, that is the implant overload or fracture, or it may be biological nature, that is the infection or the associated surgical trauma which impair the osseointegration, and peri-implantitis is also the main reason for the failure of the implants. So these are the surface modification which are implants that are present in the market, that we can see that the sandblasted and the acid, that is the acid etching implant, has 11.4% in the market, and in the market the acid etching implant which comes in 15.6%. So major component of the nowadays is the sandblasted and the acid etching technique. But now when the biochemical and the chemical surface modifications comes, that imparts the at disadvantage of the acid etching or the sandblasting coated implants. So what are the potential failures of the titanium-based dental implants that we see in is the osseointegration is targeted outcome following implantation. But despite the well-documented biocompatibility of the titanium-based implant to other tissue responses were observed during clinical application. So the two type of tissue changes or tissue response we can see in our clinical application is that the first is the inflammatory response by implant surface, wear and chemical corrosion, which release tiny titanium particle into the oral tissues around the dental implant. And the second is the called a foreign body reaction that occurs when a fibrous capsule forms between the host tissue and the implant. So these fibrous tissue layer is common cause of the implant failure because it prevents the implant from being biomechanically fixed adequately. So these are the images that show the fibrous tissue all over the surface of the implant base that may lead to the poor stability. So surface hydrophilicity and the roughness are the two or more targeted
Dr. Alan,
characteristics.
again, we are not, as per your, presentation, the slides are not matching. Yes.
Now it's moving.
Yeah, it's moving on. Surface modification technique for improving the performance of titanium-based dental implants is the slide visible to us.
Okay, thank you. So the surface modification and the roughness are the two and most targeted characteristics when it comes to dental implant surface modification. So the first, as I mentioned earlier, that there are 5 generations now comes in the market which has surface coated the implant. So the first generation and the second generation. First generation is the machine grinding and second generation is the plasma spraying or the grit blasting, acid etching, anodizing techniques. So that modification that involves mechanical morphological alteration of the implant surfaces. So in order to improve the osseointegration and provide antibacterial qualities, the third generation of modification technique focused on the coating of the implant surface with diverse material. So metal implants now can be coated using a variety of techniques, including electrophoretic deposition, sputter deposition, sol gel coating, plasma spraying, biomimetic precipitation. So in clinical practice, however, a titanium dental implant were only treated with the plasma spraying technique. So now it is still we are using the plasma spray technique in our clinical practice. So these are the various images that shows that titanium implant surface modification was subjected to various types of surface roughening. So that includes the plasma spraying, SLS, anodization, grinding, double acid etching techniques. So these are the surface modification that we see from the microscope after placing the implants. So the progression in the biological, which is my main focus, that the progress in the molecular biology and genetical engineering gave rise to the fourth and the fifth generation of surface modification techniques. So these consist in enhancing the implant surface with specific molecules, which is recognized by osteoblasts, such as amino acid sequences, osteogenic proteins, vitronectin, or growth factors. So stem cells or even fully developed tissues, nowadays we can coat them with the implant for the better integration of the implant in the oral cavity. So these are the material composition and morphological attributes of the cortical screws, which is coated with nanocrystalline diamond. So in figure A, it shows that the coated screw photo, which has a bright field optical microscope image and Raman spectrum displaying that disinfecting properties of the nanocrystalline diamonds. So in conclusion, throughout time, the surface modification technique evolved from basic mechanical processing to physicochemical and biological modification that not only increase the average roughness but also provides an osteoconductive and antibacterial character to the metallic surface, thus favoring the osseointegration and prevent the development of microorganisms. So we have to prevent the development of microorganisms around the implant also. So additive manufacturing or 3D printing technology is another trend in increasing the popularity in dental implantology and tissue regeneration technique. So this method generates customized implant with high precision and reproducibility based on the precise 3D model of the patient's teeth and the gum. So bioactive agents such as proteins, cells, or growth factors can incorporated into the printing ink and the final result being implant tailored according for the patient's need. Thank you.
No questions from my side.
I also have no questions because your slides didn't move only. Arun, your slides were only now the final thank you has come. We haven't been able to view any of your slides.
I'm
Just
so sorry, sir. I don't know what the matter is, but maybe it is just technical glitch. I'm so sorry for that.
it's okay, no questions. Thank you.
Thank you, sir.
Dr. Nishant?
Yeah, please go ahead. No questions.
Yeah, Dr. Rohit. So we are moving to the next presenter. Dr. Mrunal. Dr. Mrunal, are you there?
Yes, I'm here.
Yeah, please do share your slide, give your brief introduction.
Sure.
Yeah.
Are my slides visible?
No, it's not yet visible, but we are just waiting for that. Dr. Minlal, if you're facing any problem, should we move to the next speaker and
Yes,
then
sir. Sure,
I'll
sir.
take
I'll
you?
just get it fixed.
Yeah, please. Dr.
Yeah,
Rucha,
thank
are
you.
you there? Dr. Rucha?
Yes, sir, I'm there.
Yeah, please do share your slide, give your brief introduction, and start your presentation. Yes, your slides are visible, Dr. Rucha.
Okay.
Please make it in a slideshow mode. Yes, no, it's in slideshow mode. Yes, okay.
So very good morning to everyone. I'm Dr. Rucha Pandey, and I'll be presenting my research paper. The title of my paper is Assessment of Alveolar Bone Thickness and Bone Densities around Maxillary Central Incisors of Different Inclination, or CBCT study. So as we all know that alveolar bone is a specialized part of maxillary and mandibular bone that forms the primary supporting structures of our teeth. So maxillary anterior teeth are the most aesthetic region of our face. So this aesthetics depends upon the proper inclination of maxillary incisors. The thickness of alveolar bone around the teeth is one of the major factor that determines the amount of movements that can be carried out within physiologic limits. So, during orthodontic treatment, the excessive tooth movements in a limited space can cause various problems such as fenestrations, dehiscence, root resorption, and gingival recession. Therefore, planning any orthodontic treatment, the knowledge of alveolar bone thickness is necessary. So various methods for measuring the alveolar bone are available such as LATSIF, OPGs, CT, CBCT. So nowadays, CBCT is a recent and advanced diagnostic radiographic imaging that overcomes the limitations of conventional radiography by producing 3D images that allow high definition analysis of specific regions without distortion or superimposition of the structures. So this study was planned to evaluate the alveolar bone thickness and densities around permanent maxillary central incisors of different inclination with CBCT. So this study, we had got the ethical clearance, and patients with age of 18 to 36 years were selected, while patients with decayed teeth, periodontal conditions, crowding, periapical pathologies, prosthodontic crowns, craniofacial dysmorphologies were excluded. So this is our Carestream CBCT machine, which was used during the study. So with this, the density was measured using the same software. So the patients were divided into three groups. First group was lingually inclined teeth. Second group was normally inclined teeth. And third group was labially inclined teeth according to the angle of inclination. So each group were consisting of 50 patients. So the root of the teeth were divided at 5 levels. The level 1 was root apex. So this is the level 1. At root apex, this is level 2. It is between level 1 and level 3. So level 3 was the middle of the root. Then level 4 and level 5 was CEJ. So density and the labial bone thickness and lingual bone thickness was measured at these 5 levels. Apart from this, we also checked the dehiscence and fenestration. So defects greater than 2 mm from CEJ were considered as dehiscence, but which were not involving the CEJ were considered as fenestrations. So all these measurements were recorded in a data sheet for all the patients. The same measurements were repeated and average of 2 readings were taken as the final measurement. So coming to the results of the study, this is the age and gender profile of the patients. So both age were not significant and gender was not significant. So the mean age was around 25 to 27 years of age. And group 1 had 24 males and 26 females, group 2 25 and 25, and group 3 28 and 22. So coming to the analysis, while we saw the labial bone thickness was significant only at level 1, that is the root level, and level 2. Coming to lingual bone thickness, the statistically significant values were seen in level 1 and level 2. Coming to the bone density, that is grayscale values on the labial side, statistically significance was seen in level 1 and level 2, that is p-value was less than 0.05. Coming to the bone density values on lingual side, the statistically significant values were seen on level 2 and level 3. Coming to fenestrations, so fenestrations were more in group 1 and very less in group 3, while compared to dehiscence, more was seen in group 3 than group 1 and group 2. So coming to the discussion, the anterior teeth occupy most aesthetic and important zone of our face. Sometimes movement of teeth during orthodontic treatment can cause denudation of bone and the root surface contacting the bone, thereby creating a periodontal defect leading to root exposure. So the present study was assessed to evaluate the alveolar bone thickness and density around permanent maxillary incisors of different inclination. So the result of the study showed thus on the labial side, statistically significant values were seen at level 1 and level 2. So these findings were in accordance with the study conducted by Kalbasi et al. And we found one more study which was conducted by Danube, which showed that supporting alveolar bone thickness around 68 upper central incisor teeth. The results of their study showed that lingually inclined teeth had the thinnest labial bone. This finding suggests that such teeth are more susceptible for developing the damages such as fenestration and dehiscence during orthodontic treatment. On the lingual aspect, the alveolar bone thickness was least obtained in group 3. Across all the 3 levels, this finding suggests that thickest alveolar bone was present in lingually inclined teeth compared with normally and labially inclined teeth. So similar results were obtained by Sedek M. et al. And we found 2 more studies conducted by Nam and Lee et al., which showed similar results, and they also found that alveolar bone was present more over labial side of teeth with values less than 1 mm, in contrary to the palatal aspect where bone thickness was comparatively higher. So apart from this, we had also checked about the fenestration and dehiscence. So our data also suggested that lingually inclined teeth have more incidence of fenestration, and the labially inclined teeth had almost 50% less fenestrations, correlating the thin alveolar thickness of bone obtained in our study in lingually inclined teeth. This was in accordance with the study conducted by Tai and Wai et al. Similarly, highest prevalence of dehiscence was observed in lingually inclined teeth, while compared to group 1 and group 2. So these findings were also in correlation of the studies conducted by Namigan, Larto, and Almec et al. This variation could be due to the fact that in our study, we considered only maxillary central incisal, while the studies conducted by other authors had evaluation of all the teeth. So coming to conclusion, alveolar bone thickness and density varied with tooth inclination. So lingually inclined teeth had thinnest labial bone and thickest lingual bone, while labially inclined teeth showed greater labial bone thickness but thinnest lingual bone at apex. Therefore, CBCT evaluation can significantly influence treatment planning by guiding appropriate orthodontic force application. These are my references. Thank you.
No questions.
I too have no questions. Thank you.
Dr. Nishan, Dr. Rohit.
Dr. Rucha,
Yes, sir.
uh, why you have selected this age group?
So because this age group, the aesthetic is more important for these people. So we considered 18 to 36 years of age. And they are more for orthodontic treatment.
A similar study has been done before, right?
Yeah.
So what you have done any difference in your study?
So actually, we similar studies where yeah.
Yeah, Rucha. Okay, we are moving to our next presenter, Dr. Mrunal. Dr. Mrunal, could you share your slide? You are, I think you would have
Sure,
picked
sir.
your, yeah, please.
Yes, sir. Sir, is my PPT visible?
Just waiting. Just, yeah, it's visible.
Is it visible, sir?
Yeah, it's visible, visible.
Okay, thank you. So, a very good morning to respected judges. Am I audible, sir?
Yes, you are audible.
Okay, yes. So, myself, Dr. Mrunal, and the title of my presentation is Revolutionary Spectroscopic and AI based Approaches to the Multi-Class Oral Cancer Detection. Coming to introduction, as we all are aware of, oral cancer is making up more than 30% of all cancer cases in the country, and oral squamous cell carcinoma is the commonest type, around 90% of the cases of oral cancers and 3% of world total cancers. Now, these OSCC derived from among the numerous OPMDs like OSMF, leukoplakia, erythroplakia, lichen planus, like canoid reaction, etc. What is the burden of this disease? Incidence and prevalence of OPMDs and OSCC is increasing day by day, thereby escalating the burden of the oral cancer in India. The incidences of squamous cell carcinoma of the oral cavity differs widely in various parts of the world, ranges from approximately 2 to 10 per 1 lakh population per year. Now, what was the need of my study? Despite the progress that has been achieved, early detection of cancer is still quite challenging because the lesions are very heterogeneous, diagnosis are often late, and complexity in the class of benign, precancerous, and malignant tissues. Traditional techniques like inspection and biopsy are time consuming, invasive, and physician dependent, limiting their accessibility and efficiency. To overcome these limitations, innovative diagnostic approaches are required, which are not only sensitive but also will be specific, cost effective, rapid, especially for the early detection and classification of the oral cancer subtype. Now, this is the figure illustrating progressive improvement of diagnostic precision. So diagnostic limitations, traditional method insufficiencies was there. No invasive tissue analysis is there in spectroscopy integration. When we are using AI enhancement, there will be machine learning for data analysis, and there will be improved accuracy, that is enhanced diagnostic approaches. So this approach fills the gap which is left by the traditional method, and it offers more reliable and advanced diagnostics solutions. The integration of spectroscopy based methods with AI has become promising in overcoming the challenges. Techniques like Raman fluorescence, which are going to discuss this in detail later, they allowed for a non-invasive real-time analysis of the tissue by capturing unique biochemical and molecular changes that appear in normal precancerous and cancerous states. So multi-class classification is feasible through AI, though through AI models for the discriminant classification at different stages as well as on the subtypes. So integrating spectroscopy with AI promotes better diagnostic accuracies, reduces analytical time, and offers ease in the screening process. Real-time analysis and high sensitivity of the spectroscopy has a great advantage over conventional diagnostic method. Each of these spectroscopic method has its own strength and emphasizes different aspects of tissue characteristic. The first we are going to see Raman spectroscopy. It is a vibrational spectroscopic technique where inelastic light scattering from the tissue samples is measured. It furnishes a kind of molecular fingerprint of the tissue, as this technique captures a chemical composition as well as the structural information. It is highly sensitive to the changes in protein, lipids, and nucleic acid as the indicators of very early malignancies. Also, it has found utility as a non-invasive tool in oral cancer detection, providing subsite-specific differentiation. It was demonstrated that has 80 cryopreserved tongue, buccal mucosa, gingiva samples that could be differentiated as a tumor or normal tissue by using RS along with the PCA and LDA QDA models. So there was a second study where 64 cryopreserved OSCC tissue samples were applied, and we got the specificity and sensitivity above 90%. The study emphasized the ability of Raman spectroscopy to distinguish between the OSCC stages from T1 to T4 on the basis of Raman spectra. So the stage and subtype is considered might need a detailed analysis for improved diagnosis. The another one is fluorescence spectroscopy. The foundation of fluorescence spectroscopy is the idea that light is emitted by molecules called as fluorophores, we know that, so which absorb light at one wavelength and releases at another. There are two types, exogenous as well as endogenous. So the changes in intensity, wavelength, lifetime of fluorescence are biochemical and structural alterations in the tissues, such as those due to cancerous transformation. Fluorescence spectroscopy is widely used because it acquires data rapidly, it is highly sensitive, allowing for the detection of the lesion that may not be visible through the traditional clinical examination, and it is particularly effective for identifying tumor margins and assessing the progression of oral potentially malignant disorders. Third one is infrared and near infrared spectroscopy. IR and NIR spectroscopy are the absorption of IR light by tissue molecules, which will inform their states of vibrations and rotation. So the techniques are more specially used to observe the functional groups of biomolecules which may contain protein, lipid, and carbohydrate. Near infrared spectroscopy allows for the deeper tissue penetration and less scattering, thereby allowing surface lesion to be evaluated. Coming to the AI and machine learning in multi-class oral cancer detection. They are radically changing the concept of medical diagnosis, allowing detection, classification, and prediction capabilities of complex diseases. Adding spectroscopy data to AI is making it possible for the non-invasive, accurate, and efficient multi-class oral cancer diagnosis. Now, here I have summarized the commonly used AI method for oral cancer detection. The first one is deep learning models. So the key application will be high dimensional data processing, feature extractions, and pattern recognition for cancer stage differentiation. The strengths are robust handling of the complex patterns, suitable it is suitable for spectroscopic as well as the image data. Then the next is support vector machines. The classification of normal, precancerous, and malignant tissues using spectral data are the key applications, and the strength are it is effective for binary and multi-class tasks were combined with the features extraction methods. The third one is ensemble learning technique. And the key applications are multi-class classification of OSCC using histopathological images here, and transfer learning. The strengths are it combines prediction from multiple models to improve the accuracy as well as prevent overfitting. Now, advancement in the multi-class classification. It's the domain in which deep learning models and particularly neural networks are extensively used, where high dimensional spectroscopic data are proceed with the learning of complex pattern to classify different classes of oral cancer. Each class accuracy, precision, recall, and F1 scores are performance indicators, and confusion matrices are used to assess the performance across all the classes. Now, applications of AI spectroscopy integration. The spectroscopic methods such as Raman, fluorescence, and infrared spectroscopy provide detailed molecular and biochemical insight, often indicative of cancerous transformations, while AI enhances their potential by enabling the advanced data analysis, pattern recognition, and classification. Early screening, multi-class classification of lesion, monitoring the progression of the disease, and provision of cost-effective solution in resource-limited setting are some applications of AI spectroscopy in integration. Now, what are the challenges of this? The major limitations associated with the spectroscopy based AI models are the problems of overfitting, which arise from the use of small or institution specific databases, thereby limiting the generalizability to diverse the population. Then the absence of clarity in complex models like deep neural network also poses a challenge towards the clinical trust and regulatory approval. Then noise in the data. Then most of the existing databases lack representation across demographic as well as geography groups, which can lead to the biased predictions. Thus, the multi-institutional collaborations are needed to create centralized and standardized databases or the sets that include the range of lesion type from benign to malignant. Data privacy, bias correction, and the accountability of the errors in diagnosis also need to be addressed. Use of AI in diagnostic require informed consent as well as transparency. So we can come to the conclusion that the integration of spectroscopy and AI is one of the transformative potential for early detection as well as diagnosis of oral cancer that overcomes the deficiency of conventional methods. It provides excellent molecular and biochemical information concerning the progression of cancer with non-invasive real-time analysis of the tissue through spectroscopic techniques. However, this can pose limitations in several forms like insufficient dataset diversity, spectral data noise, lack of explainability for AI models, which further calls for increased attention to more robust clinical utilization in the near future. So together, spectroscopy and AI provide great promise to be transformative tools to improve the oral cancer diagnosis and management, especially in the resource constructed settings. Thank you so much for listening me.
Thank you, Mrunal. It was a good presentation, but
Thank you, sir.
I just need to know that you said in resource constrained situations you will like to use spectrometer as well as artificial
Yeah,
intelligence. But
right.
if it is resource restrained, this itself having artificial intelligence turns out to be pretty expensive, right? When you want to
Right,
use,
sir.
so how can you say resource restrained? In fact, the resource should be available.
So resource constraint, I said resource constraint setting, meaning the resources are there for multi stages. Like if my one of my student is she is doing PhD, she is from engineering, but she is doing AI, use of AI in oral precancerous lesion. So when I'm sending pictures of my patients of leukoplakia and lichen planus, so that tool is not able to differentiate between the lichen planus and leukoplakia. Where Wickham stray are specifically present, it can diagnose. But then when they are not present, and say it is a lichenoid reaction or the candidiasis, it is not able to differentiate, sir.
Correct.
So
I
what I
get you.
mean,
I get you.
yes,
No,
sir.
I get you. I get you. I understand what you're saying.
Okay,
So,
sir.
at the, I mean, since you're going to use only pictures and you're going to get artificial intelligence to decide whether what type of lesion it is, it becomes a
Mhm.
little,
Challenging.
it's a speculative situation where you can't be sure whether the lesion, the AI is reporting correctly or not. Am I right? So,
Right, sir.
did have you been able to try this out with your student, and you're able to reach any kind of specificity as far as sensitive? Okay, TK, but specificity, were you able to achieve anything?
Honestly, sir, no.
That's
We have
yeah.
complete.
So the study is good. It's a very good study.
Yes,
I mean, unless you don't do it, you don't know whether how effective are these studies. But
right,
at
sir.
the end of the day, finally, it is the biopsy which is the gold standard, which will probably tell you as to what kind of lesion it is.
100%, sir. Clinical examination, like presence of induration and all findings and histopath will be always remain a gold standard.
Yeah, yeah. But of course, unless you don't do research, there is nothing that can move ahead. So I really appreciate the kind of study that you've done.
Thank you so much,
Thank
sir.
you so much. Yeah.
Thanks.
Okay. Yeah, it's a good presentation and you have covered most of the things. So no
Yes.
questions actually.
Thank
And
you.
it's true what sir has said. We need to look out what new things our studies can bring about rather than just sitting with what we are doing in a routine basis. So good presentation.
Thank you, ma'am. Thank you.
Dr. Mrinal,
Yes, sir.
one question is here, which is having the better accuracy, whether spectroscopy or AI?
Uh, I'm not able to listen you, sir.
Which is having the better accuracy,
Huh?
spectroscopy or AI?
Sir, spectroscopy.
Are you sure?
Sir, spectroscopic techniques.
Okay, fine.
Okay. So, nice presentation, Dr. Brunal. And now it is, I think, there is one faculty who's supposed to present joining from UAE, Dr. Revan Cholesh. He is not able to join actually. So these are the four faculties who presented now, and I request all the judges to you can send your marks through email or the WhatsApp. And with this permission, we should going for our regular speakers presentation now. Onwards, Dr. Shanin would be the first speaker. So thanks all our jury member judges. Thanks Dr. Trival Pereira, Dr. Aparna Dave, Dr. Rohit, Dr. Nishant Kumar, and Dr. Hashmi couldn't join. So thanks all for sparing your precious time and judging our representatives, motivating them, asking questions, guiding them, and all. So if you want to stay with us, you can stay. Otherwise, means evaluation is already being done.
Thank you, Dr. Nurul.
Yes, yes. So
Thank you, Dr. Nurul. Thank you
yeah,
so much
thank
for
you,
having
Dr.
us.
Nurul. Yeah.
Yeah.
thanks, Dr. Nishan. Thanks for travel.
Sir, excuse me, sir.
Yeah.
Sir, mine is also left because I was not able to upload my file.
Can I? What's the name?
Dr. Bhavna Lenka, sir.
No, it's you are the first one, and we have waited for a long actually. So
Sir, there was a lot of problem with the network and the
so
app.
you please share your presentation to the email osiddcon@gmail.com, and we'll consider for the what I would say the for marking and all. But here we have the constraint. We have to move to the next speaker. Yeah.
Yes, sir.
Yeah. Sorry for
That's
the inconvenience. Yeah.
sorry, sir, from my
Yeah.
side as well. Thank you, sir.
So with this note, we are taking our first speaker today on a day two on International Digital Dentistry Congress. We are fortunate that we have Dr. Shanin Farishta. She is our first speaker today. Let me introduce her formally. Yes, Dr. Shanin is there with the phone, and who is gonna share the slide actually? Can I just check the slides are, shared?
Yeah, it's the laptop in the name of Dr. Shannon.
Yes. Okay. We are not able to see Dr. Shanin in a camera. Okay. So let me first introduce her. Dr. Shanin is an MDS conservative dentistry in endodontics. And she is a diplomat in laser dentistry from USA. She is clinical director at Laser Dentistry Multi-Specialty Dental Laser Launch, Bandra, West Mumbai, speaker and mentor of laser dentistry across globe. She's a faculty for fellowship in laser dentistry affiliated by MUHS University at IDA headquarter Mumbai. She's also speaker and hands-on trainer for endodontic and general dentistry module in Divas in laser. Then she's co-founder at Divas in Laser as a very known clinic based in Mumbai. She's co-founder at Shashafe Luxury for Healing Hands, first ever designer medical wear boutique for doctors at Bandra West, Mumbai, which is available at online platform as well. She's integral part of Grace Up Grooming for Professional Certified T2 Tobacco Intervention Initiative Specialist. She has published various articles in laser dentistry and endodontics at a national and international level. She is a member of editorial board for a scientific journal, World Journal for Advanced Scientific Research. So this is our brief introduction of Dr. Shanin. Dr. Shanin, if I have missed anything, you can add on, and you can start.
No, thank you so much. That's more than enough. Thank you. Thank you, Dr. Nurul. Can I share my screen now?
Yes.
Okay.
We have made you co-host, so you can share the screen. Yeah.
Yes.
Yeah, your screen is visible now.
Correct.
Not in slideshow, but
Yeah, I'm doing that. Don't worry.
yes. Perfect.
Okay. Thank you. Can you see me? Just pin the another window that
You have
I
already pinned actually. Yeah.
Okay. Thank you so much. Thank you so much, everyone. Very, very, very good morning. And I'll quickly start with my session for today. And here, as mentioned, I'll be speaking about lasers in day-to-day dental practice. Let's start with how we are practicing lasers in our clinic. On the left, can you see we are still rather using drills to drill through the tooth, make a cavity. And on the right, you can see some lasers working. We are working in non-contact mode. And that's how I am practicing in my practice. There's a complete shift of how lasers has personally revolutionized every aspect of dental practice, but we have taken it to the next level. This was just the brief, and let's just take into as per the penetration levels. And commonly in dentistry, we have two different types of lasers, hard tissue lasers and soft tissue lasers. Hard tissue lasers, as the name suggests, are the ones which with which we can actually work on hard tissues inside the oral cavity, like enamel, dentine, bone. And the example for that is erbium family lasers. Soft tissue lasers are the one with which we can work on soft tissues, like all the oral mucous membranes, gingiva, tongue, lips, oral mucosa, and we can do photobiomodulation as well. The commonest examples for these lasers that we use in dental practice is diode laser. Okay. And this is the most common question whenever some patient comes to us. Is there any harm with lasers? The answer lies in the basic electromagnetic spectrum that we have for radiations. As you must be remembering, in the school, we learned that there are different types of radiations. In the center of electromagnetic spectrum, we have visible light. On the right, we have ultraviolet, X-rays, and gammas. These are penetrating rays, and they have an ionizing power. Whereas on the other side, which is on the right-hand side, we have in left-hand side, we have infrared, microwave, gamma rays, and all. Okay. So as you see, the detail, how the diode lasers and the erbium lasers are placed according to the wavelength in the magnetic spectrum, they majorly fall either into visible spectrum or near infrared spectrum. Looking into that, we can very well say that our lasers are belonging to the non-ionizing portion of the electromagnetic spectrum. Hence, there is no radiation hazard. So can I say that, is it safe to use lasers on the pregnant ladies? Yes, absolutely yes. But the basics remains the basic. We have to consider that for pregnancy, the second trimester is considered safe. So we can only work in the second trimester, whether it is any dental procedure, using lasers or without using lasers. So that basics remains the basics. Okay, let's move towards the few of the evidence-based procedures that we can cover at least today. Here, with the hard tissue laser or the erbium laser, I'm using erbium chromium YSGG here. You can see, without even touching the gingival tissue, in a class 5 cavity preparation, we have contoured the gingiva. With the same laser, just with the different settings, we are actually preparing the class 5 cavity. And here's the post-operative vision. Immediately, same time, same day, we can work. As you have seen already, whenever you're using hard tissue lasers, which are the replacement in my practice for sorry, which are replacement in my practice for the drills and burrs, we always work in non-contact. It does have water and air coming out simultaneously like drills. And it has various reasons why we are using lasers. First is the selectivity, because laser specifically works on the carious tissue and removes those, leaving the sound enamel and dentine intact. That is the first advantage, and hence we say that while you're using lasers, we are doing an minimally invasive laser dentistry. Correct? Now, there is lesser pain and perception. Yes, because there is no contact, there is no vibration, there's no noise. Of course, because there is no vibration, no discomfort, no noise, it is faster, quicker, without any touching with the tooth surface, the better is the pain acceptance. Not just we are preparing the cavity, but with the inherent property of lasers, we are actually doing disinfection of the cavity as well. Since we are not in contact, the thermal rise is very, very, very less as compared to the drills. And the major part is, have you ever imagined that you are preparing a cavity and at the same time you are repairing the pulp? So yes, we do repair the pulp when we use hard tissue lasers. There are scientific reasons to it. Few of them is there is increased production of CGRP-IP, and there is also increased production of non-specific alkaline phosphatase, which helps in pulpal repair. In cases of vital pulp therapy, there are two basic types of pulp cavities or pulp capping procedures that we normally come across. One is indirect and one is direct. Indirect is when there is a minimal layer of remaining dentine thickness, so that we pulp the cap and we do a restoration of it. Direct pulp capping is when there is a nitrogenic pinpoint exposure and not the KDS exposure. And then you immediately pulp and do the procedures. In both the cases, hard tissues and soft tissue lasers can be used. In majorly, hard tissue lasers are used for indirect pulp capping cases where you get disinfection and there is a lesser need of local anesthesia as well. When you talk about direct pulp capping, the soft tissue lasers are the major ones which comes into progress, wherein you are doing controlling the hemorrhage, because the first thing that you get when you get the pulpal exposure is bleeding. And then, of course, you get this sterilization. Okay. Now let's come to the topic, endodontics, my favorite topic. Yes. So when you talk about different lasers, when you talk about erbium lasers, it has got a complete FDA clearance in 2002 to perform the complete root canal treatment. So meaning we can actually prepare an excess cavity with lasers. Then some conventional steps remains conventional because then your tactile sensation comes into play. So canal orifice finding, canal negotiations, patency checking, working length determination, and preparing such that your laser fiber can go inside is what you do as a conventional procedures. Once you are done and you know that your canals are patent, you switch to the lasers again. You do this cleaning and enlargement with the same laser. You do disinfection with the same laser, and hence you minimize a lot of clutter. It's actually very helpful in decluttering because you must be doing endo and you know how many different sets and how many different trays you need to change with each step. So this also minimize, plus giving you disinfection, giving you enlargement. And the major reason why lasers is used and being incorporated in endodontics is the whole purpose of doing a root canal is to kill bacteria. And the bacteria and the microbes which are there are hiding inside the dentinal tubules for more than 1,000, 10,000 millimeters, microns, not millimeters, microns inside the dentinal tubules. To target them, we need something by virtue of nature, of a physical instrument, or any chemicals like any irrigants, or say even sodium hypochlorite. Even after the activation and the agitations, it's difficult to reach because they have surface tension and energy. So laser, it reaches and crosses borders because it is light. So light is supposed to travel more, right? So that's the basic nature why lasers are used. Also, just not that, of course, we are getting a disinfection, but at the same time, we are getting a smear layer free canal surface, because when you use hard tissue laser, it stripes away the dentine and the smear layers, and that's how it actually enlarges the cavity. So disinfection you are doing, also you are getting a smear layer free canal, which is the main goal. Why? Because when you go ahead and do an obturation, your penetration into the dentinal tubules increases and the absorption increases, the penetration increases, disinfection increases, and at the same time, you get a 3D obturation. You must have heard about 3D obturation, right? So what do you mean by that? It means that a complex where you get every, and you try to fill every anatomical creature that comes in between, right? Here in the pictures, you can see the depths of different, this was a study done to check the sealer penetration. It is my own study. And you can see the penetration in the last slide. It's under the it's under the microscope where you can see the red things are the sealers. We actually added dyes and we checked how much penetration it is inside the spectrometer. Okay. Now, let's see how lasers are used and at what stage and where. So basically, lasers are considered to be used at the final step of disinfection when you are using diode laser. And when you're using hard tissue laser, you have to start right from the top because you can actually do your excess cavity preparation also. The commonest term that we use nowadays to do and laser irradiation is laser activated irrigation. That means that the canal is always filled with some or the other irrigant, and you are using laser to get the synergistic action of both. This is a diode laser. And after the preparation, your canals are filled with the fluid, any irrigant. I prefer sodium hypochlorite when it comes to diode laser. For hard tissue lasers, I don't even need sodium hypochlorite in certain cases. As you saw in the video, I'll just replay the video again. As you saw in the video, your light, whenever it is moving inside, your laser tip is coming out. You are irradiating this surface throughout. Light is going everywhere, and that's the light which actually helps to reach the areas and disinfect the dentinal tubules. We do a total of 3 sets of irradiations to cover the maximum wall. And between the 3 sets, we keep changing the irrigants to get the best results. Another picture indicating that how beautifully the laser can travel even if you're not at the tip. The middle picture, you can see that even without turning, going inside, you can't bend the tips, any tips, to reach these lateral canals like that. But your lasers can do because it is light. This is laser activated irrigation with erbium lasers. So the tip reaches up to the length. Here the dye was placed so that you get an idea of how the action is happening, and all the fluids are coming outside in a reverse manner. You can see. That's how the beautiful cleaning happens when you use lasers. At the same time, you get a smear-free canals, enlargement of canals. Enlargement meaning it actually preserves the natural canal shape. You don't have to give taper too much to understand and clean, and there is no need of extra exaggerated removal of dentine to clear off all the debris. This is how minimally invasive endodontics look. The canal natural shape is maintained, and then the obturation is done. This is a real-time video while I was doing that case of how we reach. This is an hard tissue laser and an erbium laser. As soon as we start, you can see air and water coming out, and that's how you come out and you finish the case. Let's move towards some aesthetic procedures other than the endo. The first is gingival depigmentation. Here's a preoperative case, picture, intraoperative, before and after. And we have a video for it. There are different wavelengths of lasers in diodes and in erbiums as well. But when you say you're using a diode, you have multiple wavelengths. Some were falling into visible light, say blue light laser, which has 450 nanometer wavelength. Some were falling into infrared sections. They have wavelengths of 810, 940, 980. And both the lasers can be used differently. Both the wavelengths can be used differently to perform the same procedure. Here we will see how. This is a picture after, where in the upper arch 450 nanometer was used and in the lower arch 980 nanometer was used. And here's the supporting look for the same. Upper we are using 949. Upper we are using 450 nanometer wavelength, non-contact mode. In the lower we are using an infrared laser, 980 nanometer wavelength. Let's move to the next case, which is of gingival polyp. We have done a lot of research together with me, with Dr. Sana, she's my sister, with all the Divazin lasers. We are continuously doing a lot of research, and we have research for every different procedure in dentistry. We have patented many handpieces, we have patented many techniques for different procedures. All you can get, and you can ask us with contacting. We have a website where you can actually go and see all that thing. I'll be giving my contact details later in the slides. So whenever you want any research paper or you want have any queries, anything regarding that, you can refer to the last page. Okay. This is a pre-operative picture. You can see a huge gingival polyp using lasers to remove it. Immediately after, you can see the gingival, you can see the tooth, and you can see the cavity, and then you fill it, because you get a complete clear-free, blood-free region. Isolation is not compromised, and you can actually go ahead and immediately do it. Another case where a soft tissue crown lengthening was done using diode lasers. Here's the pre-operative view. You can see this is the post-operative. And now there is a comparison between the length that we achieved before and after. This is a real-time video of performing restorative crown lengthening using a diode laser. 980 nanometer was used here. Before doing this, you have to make sure that you are actually, the case requires a restorative and only a soft tissue crown lengthening and not the bone contouring. You need to find out that by measuring the biological width. And once you are sure that the case approves of a soft tissue crown lengthening, you go ahead, take your diode laser and perform your crown lengthening like this. Here's the tooth was debilitated. It was a endodontically treated tooth. It was almost chopped into two different more than half of the coronal portion is already gone. But since you get a good access to all that you are working around, you can have a little confidence of building up the tooth with post-core and then following up with a endodontic crown or a post-procedural crowns. Here are small case of aesthetic crown lengthening that we have done using a soft tissue lasers. In the before, you can see a small canted smile. And after, with just a minor correction in the gingival contouring, and you get a complete aesthetic smile. On the right, you can see the picture of Mrs. India. And this case is hers, and she was the one who came to the clinic, and we did this procedure. The whole presentation is a combination of all the procedures that we commonly do in our practice using soft tissue lasers and a hard tissue laser. The next procedure comes across is removal of old restorations. When you talk about old restorations, the first picture here that you can see is a composite restoration, and we can remove a composite restoration with hard tissue lasers or an erbium laser. The next pictures you can see it's a glass ionomer cement. You can actually remove your glass ionomer cement with your hard tissue lasers. Next, we can see an old amalgam restoration. Here, we are not advised to use a laser because there's a metal here and there will be a lot of reflections when you use lasers on it to remove the process. So when you're using this hard tissue lasers, you should avoid using it over the amalgam or a metallic restoration. Next, the commonest procedure that we follow is a ceramic veneer removal without taking it. I hope you're able to hear the sound from the video. That's how a popping occurs. And this is an hard tissue laser. You laser it around across the veneer and you finish completely popping up around the surfaces. You are actually breaking the bonds and voila, your veneers pop up intact. It's not always that your veneer will come out in a complete chunk like this, but yes, in majority of cases, if you use your hard tissue lasers properly, you'll definitely get this out. Because of the constraint of timings, there are many procedures and many things that we can actually learn with. But due to constraint of time, I have to finish the presentation here. And here's are the few takeaways: that lasers are by now a well-established equipment, and we are still struggling to, adopt even the soft tissue lasers. So to start with, diode laser and a soft tissue laser is something which is very well equipped, and you can actually start practicing and make it a day-to-day practice, because these soft tissue lasers will help you to perform all the procedures, right from simple cleaning to your root canals, to your surgical procedures, to a process called as photobiomodulation or LLLT, that is low-level laser therapy. It's actually a kind of pain management therapy using lasers. Plus many aesthetic procedures like gum depigmentation, lip depigmentation, lip repositioning surgeries for gummy smiles corrections, all the aesthetic and the restorative crown lengthenings, and most importantly, your teeth bleaching or a teeth whitening. You can perform all these procedures with a simple soft tissue and a diode laser. There are many research ongoing, and there are many benefits yet to come, and it's a boon to practice lasers. This does not give you your advantage of working around in a clear field and all that. It also eases your patient's procedures, gives them comfort. You're not injecting them. You're just applying little here and there topicals, or maybe a little spray here and there, and you are actually achieving all these things. So it's just not for you. It's also the best marketing tool for your patients and best delivering tool for your patients in your practice. Okay. We in our practice are actually working with a Mercedes and a Ferrari inside our practice rather than having a Ferrari outside our practice. We actually thought of bringing it inside and delivering the best to our patients. With this small gesture, I would like to share about the venture that we have come up. This is a designer medical wear brand for doctors. It will hardly take a few seconds. Thank you so much. One-stop solution for all needs. We are available online and offline as well. That we have learned in our journey and sharing with all the people. This is a one-on-one clinical training program where we individually train participants. And this is the fellowship program. It is the only fellowship program in India, which is affiliated by an university, which is Maharashtra University, and being conducted at IDA. And here are the few details. If there is any question, any doubt, any problems, you can connect us here. You can take a screenshot. And now I rest my presentation here. Thank you so much for this wonderful opportunity, Dr. Norul. He has been working and endlessly, and my team has already been very good. Like my team has already responded with a very great response. And thank you so much for this opportunity. Can you hear me?
Yeah, you are audible. Yeah.
Yes. Thank you for accommodating at the last time. I have a hands-on. I'm currently at Hyderabad and I have an hands-on in just like 1 hour and I have to rush. Thank you for accommodating at a different time and understanding the needs. Thank you so much.
Thanks, Dr. Shannon, for your presentation and showing how the lasers are doing wonders in dentistry, whether to conserving teeth or removing this gingival polyp and all. So it's a great presentation. Anybody want to ask any question, they can ask right now. Otherwise, Dr. Shannon has given her contact details. You can connect her. You can join her program, which she is running one-on-one. So this is just like a virtual, connect where we are giving that what is happening through lasers and all. So for hands-on training, ultimately dentistry is art and science. So for learning art, you have to go and join hands-on training. So Dr. Shanin has already shared, and it is a great venture, Dr. Shanin, for bringing this medical boutique for say. So I think you have connected with some fashion designer to bring fashion wear for healthcare
That's a
professionals.
secret. That's a secret. My sister, Dr. Sana, is the one who designs because she has apparently done fashion designing. She has already the skin of working in and around aesthetics, and she's being from the childhood into all this designing stuff. But when she did her designing from Milan, she did that also, yes. And yes. And she's the main head force.
So when
And
you
the thinking
have you
ventures.
started or you're launching, means have you started?
No, we have already launched. It's been 2 years, 3 years now.
Okay.
Yeah, 2 years for our boutique, which is one of its kind boutique at Bandra West. It's the only place where you get to come inside and roam around and virtually, not just virtually, you can actually try on clothes. You can get your customized clothes and all that. And I'm available online also.
Okay.
We have a website, as was mentioned in the slide. You can go and get like a normal e-commerce. You can buy online also.
Good. Okay. So, Shanin, you are rushing for your workshop. I think you are in Hyderabad.
Yes.
So, yeah. So, with your permission, we are moving to our next endodontist.
Thank you so
She
much.
is
Thank you
also
so much.
Dr. Anisha Parmar. So, thanks for joining and sparing your time. We are able to, get your half an hour, precious half an hour. So it would be great help to our attendees and all. Yeah.
Yes, I'm
We'll
sure.
try
I'm
to,
sure.
connect you again for another program when we are.
Inshallah, we'll do in length, inshallah, next time.
Yeah,
Yes.
inshallah. Tell you. Okay. Nice, presentation. Okay.
Thank
So
you.
with this note, we are moving to our second speaker, Dr. Anisha Parmar. Dr. Anisha, are you there? Could you please unmute and open your camera? You are there. I'm just, yeah. So, Dr. Anisha, I'm just formally introducing you. You guys are known face in dentistry, but still, as an organizer, I supposed to, do my duty to organize, means introduce my speakers. So, Dr. Anisha Parmar is an MDS in conservative dentistry and endodontics, with a keen focus on biomimetic principles, actually. And as a consultant endodontist, she is dedicated to integrating modern evidence-based concept into clinical practice, with several national and international publications in her name. Dr. Parmar actively contribute to the academic and clinical advancement in dentistry. Her lecture today is on biomimetic dentistry redefining restorations, reflect her huge passion for preserving tooth structure and enhancing restorative outcome through minimal invasive techniques. So we have the techniques where we are very minimal invasive and we are more preserving, very precise, more accurate. So over to you, Dr. Anisha. If I have missed anything, you can add on in your introduction and you can start your presentation.
No, that was very perfect and precise. Thank you so much for introducing me. I'll just share my screen. Just a moment. Is my screen visible?
Yeah, it's a visible, but we are not in a slideshow mode. Yes.
Yes,
Yeah,
is
it's
this
okay.
visible
Yeah,
now?
perfect, perfect. You are audible, you are visible, your screen are visible. Go ahead.
Thank you so much. Okay, so thank you so much for introducing me. I'm Dr. Anisha Parmar, and as I've already been introduced, I'm more inclined to minimal invasive dentistry, biomimetic dentistry. Today, we are going to talk about redefining restorations. So, I'm going to introduce you to change your mind into thinking your restorative designs. So, let's begin. What comes to your mind when you see this? You see old amalgam restorations, you see micro leakage, seepage, very badly maintained oral hygiene. You go ahead and you take x-rays and you see this very deep caries approaching pulp. You do a root canal and then you end up doing invasive preps and you give a crown where you cut a lot of enamel, a lot of dentine, and you're doing a root canal. Me being an endodontist, I'm asking you, was it all necessary? Did you check how healthy was your pulp? Or did you check everything before going to this? You need to change your restorative mind. Now, I'm introducing you to biomimetics. What is biomimetics? Biomimicry is when you're copying the life, when you are saving your restoration with life like restorations. So, this is a branch of science where you're mimicking the nature tooth structure with something similar to this. So the concept of biomimetics is not actually new. We find this in the making of Eiffel Tower. You see, this is a replica, a structure which is taken from femur, which is a trabecular structure. Now, there's a shift in dentistry from where we started. We started with a lot of ancient crown removals, tooth removals, amalgam restorations to preventive measures. And now, currently, we are on regenerative dentistry. The first use of biomimetics was by Dr. Pascal Magne, who brought in this concept of cutting and preserving the maximum you can. So, what Yes. So, what are these concepts? So, we are talking about conserving the tooth structure and vitality, increasing the longevity of your restorative material, as well as your dental tooth structure, and eliminating the retreatment cycle. You keep on doing the retreatment and you keep on coming back with micro leakage and everything. So, we have to cut this cycle, and moving ahead is the key. So let's understand the biomechanics of restoration before we jump into how biomimetic dentistry works. The most important concept here you have to understand is the dome concept. The enamel acts as a protective mechanism, which is a dome over a cathedral. You see, this dome concept was given by Milch, and it makes us understand that dentino enamel junction is a very important point which protects and dissipates the stress which falls on enamel. So, your compressive load is all divided by the shape of enamel in the shape of a dome. So your dentine is protected. This protects us from micro cracks and vertical fractures. So when we are replicating the nature, we need to understand this biodome concept and biorim. Now, what is biorim? The point of highest contour below this in your posterior restoration is your bioream. Above it is your bioroom. When you are doing restorations, you have to focus that you try to reduce the amount of load or amount of extension you do in the bowel rim. Your major idea of restorative should be in the bowel dome when you're replacing your enamel. And the structures which are done this way in proper adhesive dentistry last longer. So, most important, remember and read this article. It is highly recommended. It is biodome. Protect and preserve like the natural enamel. Now, how is your biomimetic dentistry is different from your traditional dentistry? When we look at traditional crowns, it is so much invasive preps, aggressive preps with the concepts of retention and all these old concepts. Now, we don't need to do this. We focus majorly on conservative preps and adhesive bonding. So, let's understand the principles of biomimetic. These 5 principles you need to understand. I've already mentioned this as I was explaining. You need to preserve your healthy tooth structure. You need to mimic the biomechanics. Remember the dome concept and protect your dentine from micro cracks and fractures. You need to achieve the dentine sealing. We will talk ahead about dentine sealing in the session and avoid invasive protocols and respect the biological width. When you're working with the tooth, you need to understand and preserve the gum health also. It is not just the tooth you're working on, it is the entire cavity. Your entire oral should be perfect, planned, and precise. So I have this amazing concept by Dr. Pascal Magne where we understand the 7 pillars. Let us quickly go through this. This you need to remember because this will not only change your restorative dentistry, but it will also change your mindset toward the dentistry as a whole. So, what is the first thing you do when your patient comes to you? You check, right? You see how the natural dentition is, you appreciate the grooves and the details. So the first pillar and the first thing you should always do is take impressions and take notes. You should take your photographs and take into account that what you are replacing. The second pillar is, as I've already mentioned a lot of times, non-invasive and minimal invasive preps. You need to understand that when you could save it, you could preserve that little zero point 0.5 micron or 0.5 mm of dentine, preserve it. Rather than being overly excursive and removing it, try to save that minimal amount of dentine and enamel. Prevention of your pulpal vitality should be an obsession. You should not be inclined on jumping to a root canal when you can think that why not I preserve it. Try to do less invasive procedures like direct pulp sealing and pulp capping. You can use the latest advanced materials such as MTA and Biotin, which have proven to be very effective in longer run. And the third pillar, it is very important to understand bonding. When you are doing biomimetics, you are not depending on the earlier retention and resistance forms. So your bonding protocols must be clear. When we talk about bonding, the bonding to enamel is much more different than bonding to dentine. When you're bonding to dentine, you're bonding with moisture. So understand the 7th generation, the universal bonding agents, and keep that in mind. The fourth pillar is what you are replacing your natural tooth structure with. We are going to we are going to see this in detail in the session. So I'll just jump on to the replacement options for the materials. You can use resins, which is composites, including CAD-CAM materials, and the latest composite resins, which are also self-healing and short fiber reinforced composites. The fifth pillar is less is more, less invasive. Don't look for retention and resistance forms rather than focus on just preserving and giving the margins. You see here with a partial prep, preserving the cusps which are available and healthy, we could save so much. The sixth pillar is your tools in your armamentarium. You cannot work with direct vision. You need to invest and start with loops, because the more you see, the less you prep. And not just your magnification. It is very important to understand the latest techniques. You should know about immediate dentine sealing. We will understand this in today's session. Thermomodified luting techniques and deep margin elevation. We need to understand and appreciate the current protocols. Coming to the seventh pillar, and this is the most important. When we look or when we try to protect the tooth, you have to understand that you are trying for the survival of the tooth rather than your restoration. So giving an amazing zirconia crown and then ending up to have that fracture would not make sense, because your tooth got fractured, not your crown. Your crown was so strong that it couldn't break, but your tooth wasn't. So try to focus on saving the tooth rather than saving your restoration. Restoration should be a replacement. So it should be something similar to your natural tooth structure, not something which is much stronger than that. So when you're doing preparations, try to make them minimalistic and conserving the amount of dentine and enamel. You don't need to just have a 4 mm thickness, because your restorative material needs a 4 mm thickness. Your focus should be minimalistic, where you can do it with 2 mm. Why have you have to reduce the enamel and dentine just because your restoration needs it? So focus on restorations which don't need so much invasive preparations. You see, seeing this would break your heart when you have invested so much time and energy to this, and the patient losing a tooth is also a pain for the patient. So try to be conservative, thinking about long-term stability of the tooth rather than your restoration. Now let's understand what you are replacing. So earlier I mentioned in the third pillar that it's important that what you are replacing. So when we are replacing your enamel, the enamel is 95% of mineral. So the replacement material should be something which bonds and replicates. So the current protocol tells that the most efficient material at replacing enamel is your emax. It's your ceramic, because it replicates the enamel structure. It is brittle. When you see it, it can break just by falling down. But once bonded very well to the tooth structure, it becomes so hard that it doesn't break. So when you think about replacing your enamel, just your enamel, you need to think about more or less Emax or zirconia. But when you think about replacing your dentine, this is not just organic, just inorganic. This is also organic. So you need to understand that for this, you will also need something which bonds to the moisture in the dentinal tubules. So the ideal material to replace the dentine would be a resin. A latest nanofilled composites, which are microfilled, are the most good replacement material for your dentine. Now, the next important thing is what is immediate dentine sealing and how that works. So, immediate dentine sealing is used where you immediately cut your dentine. This is your freshly cut layer of dentine, and then you apply a very little layer of bonding agent and seal it with a flowable composite. Now, why do you do this? Because it significantly increases the like the incidence and intensity of post-operative sensitivity. Also, it improves your bonding to the tooth structure in the longer run. So how to do this? If you just remove, first of all, isolation is very important. Put it all under rubber dam. Try to do this. It is very good. You'll get a clean fill which is free of moisture. Excavate and remove the caries. You can use caries detecting dye whenever you are in doubt. You can use air abrasions after this. It's an optional step, but it's always better to have that clean surface without any debris. Then you apply a very thin layer of bonding agent, cure it, and a thin layer of flowable. Now, after you are doing the flowable layer, there's a very important step you have to do is you have to polish this. There's a thing which is called oxygen inhibition layer. The moment you cure your composite, it has a layer on the top which is not cured well because of the presence of oxygen. So, to remove that uncured resin on the top layer, polish it, and then you move ahead to your preparations. So, just before starting on the preparation, you have preserved and protected your dentine so it can bond and seal well. Now, how will you work next is how we go ahead with the restorative part. You start with diagnosis, you go ahead with isolation, you do adhesive sealing, restoration layering. Your restoration can be either a raising, or you can either do an onlay or an inlay. And the final and the most important step is follow up and finishing. You need to do your occlusal adjustments, you need to take a follow up after a day, after 7 days, because sometimes the patient might come with minor occlusal adjustments, which are later recognized by the patient. So always make sure you do that. You don't want any post-operative pain or sensitivity. Now, tools and armamentariums. What do you need for biomimetic dentistry preparations? First and foremost, you need rubber dam. You need slow speed burrs. You need ultrasonic tips and good light curing units. You need to understand that this completely depends on bonding. And it is very important that this is very much technique sensitive. Now, what are the types of different biomimetic restorations? You can do inlays, you can do onlays, you can do endocrowns. Don't do complete crown over your tooth, rather do an endocrown. You can look for veneers, you can do direct and indirect bonded composite fillings. When we talk about biomimetic dentistry, I always come across questions where people are just focused on ceramics. This is not just ceramics, it is also composites. It is about how you're using them well to replicate your natural tooth structure. If you want to bond them together with a layer of composite and an onlay ceramic over it, that can be done. But you need to broaden your mind into thinking that biomimetics is not just ceramic materials. It is how you use the latest materials to your advances according to your patient. So we'll start with composites. When we are doing composites, it's very important that you understand, excavate, remove all the caries. As I said, you can be less invasive. You can leave a layer which is not your infected dentine, but your affected dentine, which can protect your pulp. Deep margin elevation whenever needed. What is deep margin elevation? Deep margin elevation is where you're elevating your gingival margin to a level where you can restore it well. You need to first finish your deep margin and then you can start ahead and do your class 2s. This in the picture, we can see we are elevating the deep margin. We are doing a composite class 2 prep first. And then we are using a fiber reinforced material. These are fibers which are available, the latest advancement. And what do? They give the strength to the restoration which just composite cannot give. So this is where you are replacing in a biomimetic way with your composites, adding on the strength for the dentine to take in the forces and the enamel. And this gives wonderful results. Now, next is ceramic inlays. We all know the inlay preparations is something similar to your class 2s, but you don't need to give your retention and resistance form for this. You only need to excavate, give bevels, and try to be more conservative with the preparations. The most questions we have is with onlay preps. In onlay preps, remember you need to only create the space for ceramic. You need only 1 to 2 mm for ceramics because once bonded, they are very strong. You need to understand and do a morphologically driven preparation. You need to do bevels and give inclinations on the tooth structure. Now, what is tabletops, onlay, and crowns? When you're just removing and replacing your occlusal tables, this is your tabletops. Just your occlusal table is replaced. This is used when you're increasing your vertical dimension or you have a patient with invasive and excessive sensitivity in your posterior tooth and you have some space. If you have space, you can do a tabletop, increase the VD generalized and give a functional occlusion. Your one lay is when you're replacing your occlusal table along with your surface. So it's an aesthetically driven preparation. And crowns, which I usually ask everyone to avoid. You don't need to do crowns in today's world. Just focus on bonding protocols and do your tabletops and inlays. Now, for inlay preparations, when you're doing the occlusal box, your central fossa should be planned. The amount of material which needs to be replaced is somewhere about 1 to 2 mm. So only that much needs to be prepared. And wherever you feel that it is very near to your pulp, you can add on a layer of composite and then do a preparation, which should be morphologically driven. You need to understand the dome concept and always follow it. Now coming to the endocrowns. Now what is endocrowns? When you're replacing the root canal treated tooth, you can take retention from inside your pulp chamber. That's the preparation you do for an endocrown. You need a ferrule of an healthy dentine. If that is not available, if it is a class 2, you can convert it into a class 1. You can do some changes and prepare a occlusal table and give it a circumferential ferrule, and this helps for the bonding as well as dissipating the force and prevention against fracture. And this also has the margins which is above, and you're taking a resistance and retentions from inside the pulp chamber. So the dental endocrown is something like this. Now, this is the traditional and biomimetic dentistry, how it is different. I've already talked about it, so I'll not repeat it again. Now, let us understand that why and how biomimetic dentistry is not just a trial thing. It is not experimental. Because I keep on coming across people who say that it would not stay, your crown will come off, or your bonded restoration will come off. There's no much trials done, but it's not true. It has been there for more than 20 to 30 years. And it is not experimental based, it is evidence based. I also come across clinicians who complain that it takes a lot of time. You say applying a rubber dam takes a lot of time, but it is about convincing your mind that it's just a 5 minutes thing. Apply the rubber dam and understand that the time you save while doing the moisture control in the entire treatment reduces to just 5 minutes of the exercise you do for rubber dam application. So for preparations, it's even lesser because you're not doing a completely invasive preps for crowns. You're just removing what is needed for your replacement material. So it doesn't take long. It is efficiency taken ahead with practice. So try to practice it rather than being thinking that this will not work. Now, technique sensitivity is very important. Your proper moisture control should be there. Your curing machine should be good. You need to understand this because it's all depending on the bonding. I keep on repeating this because your entire game is all about bonding your tooth, because the bonding is the only way we are connecting the two things, and isolation is the key. There's nothing we can change about it. So keep this in mind. I'll wrap it up with this. So start today is what I'm saying. When you look at the tooth, which is very much fractured, broken, with too much extensive caries, try to understand that you can save it. Maybe you can save the pulp if it is not infected. Once infected, being an endodontist, I know there's not much you can do, but if you can take a chance, do that. You do your immediate dentine sealing, you do your deep margin elevation, you take your photographs, and you understand and review your own work, because with that you'll keep on reviewing your work and being better, and preserve more, sacrifice less, be biomimetic. So I'll be ending my session here with just 3 points I would want you all to remember. It is about examination and taking a pause. So the next time you come across a restoration which you feel it's very deep and you're not sure if you can save it or not, it's a very young patient with a young tooth with deep caries, examine, take records, check your pulpal health. take a pause, review everything, and plan it. Plan your action A, plan your action B, and then change your thinking. Think about how you can save this rather than being invasive and doing the root canal and doing a plaster work. Try to change this cycle, and I think maybe you'll be able to preserve more healthy pulp tooth structure and see better results over time. Thank you.
Thanks, Dr. Anisha, for very enriching presentation on biomimetics. And your last 4 words is preserve more, sacrifice less is very important.
True.
And consider
It's
the
true.
biology of, and then science. So with this note, any from audience want to ask any question, they can ask right away. Otherwise, in the last presentation, Dr. Parmar has given her number as well. So you can take the screenshot and you can connect her to ask question. Anybody want to ask any question, they can ask question right away, or if they can type on a chat and then they can ask question. There is a one question, Chetan Bagade is asking, which bonding agent you prefer? Dr. Parmar, there is a one question in the chat that someone is asking.
Okay.
Just refer it that Dr. Chetan is asking, which bonding agent you prefer?
So I prefer the seventh generation bonding agents, but it all depends again on what restorative you are doing. So per se, if you are replacing your enamel, you need to do H bond cure. When you are replacing your dentine, you directly need to bond. You don't need to etch it. It depends on the cycle you're following. If you're using a 3M material, use a 3M bonding agent with 3M composite. If you is using the Ivoclar material, they have 7th generation bonding agents. Then use that with Ivoclar composites. I personally prefer 3M ESP bonding agent, which works well and has a least post-operative sensitivity. I've also done an article on the same, which was compared to a 5th generation bonding agent, and it turned out that the 7th generation ESP 3M works better.
Any more questions from anyone? No. So, Dr. Anisha, if you would like to stay with us, you can stay so that if any question comes related to biomimetic, we'll refer you. And with this note, we have one speaker who's supposed to join, Dr. Sejin Chandran. He's supposed to talk on digital translation in oral implantology, but somehow Dr. Uruji is saying that great lecture, ma'am. So somehow he not able
Thank
to
you, Dr.
join.
Uruj.
So with this, we are moving to our next speaker, Dr. Harshvardhan Arya. Dr. Harsha, are you there? Can you unmute?
Yeah, Dr. Nurul, I'm here.
Yeah. Okay. Okay. So we are, means this is our third speaker today, Dr. Harshvardhan. Before I go to the, request Dr. Harshvardhan to start his presentation, let me introduce formally. Dr. Harshvardhan Arya did his BDS from Naya Dental College and in Mumbai in 1997, and MDS in prosthodontics from GDC Nagpur in 2002. He was ex-professor and PG guide to Swargiya Dada Saheb Kalmik Dental College, Nagpur. He ran a private clinic practice with emphasis on dental implants, CAD/CAM based restorative dentistry. He is a co-guide to PhD research projects on FEM and rapid prototyping at the Regional Engineering College VNIT Nagpur with international publication. Currently, Dr. Harsh is a principal investigator for a project to develop an indigenous dental CAD/CAM system by the Department of Science and Technology, Government of India. He runs a dental laboratory with focus on all ceramic CAD/CAM restoration and implant superstructures. He is an ex-guest faculty in prosthodontics at the SSR Dental College, Mauritius, has lectures extensively all over the country on restorative dentistry and implantology at various workshops and conferences organized by Indian Dental Association and private organizations. He has also lectured on digital dentistry at the MIDC 2018 at Kuala Lumpur, Malaysia. Dr. Harsh is also a sectional editor for the Journal of Indian Prosthodontic Society. He is the second person in India to be certified by the Digital Dental Academy Berlin, Germany. Currently, Dr. Hertz is the key opinion leader of chairside dental CAD/CAM technology (CEREC) for the Indian subcontinent. Uh, while I was connecting Dr. Sanjay for requesting him to join this program, he was not in India. He was out. I think he was in Mauritius or some, I don't know, I'm not remembering.
Philippines.
Philippines, actually, yes. And somehow we are not able to connect because the connectivity issue, but somehow through WhatsApp we coordinated, and we are fortunate that we are able to get Dr. Arya in our program. So over to you, Dr. Arya. If I missed anything in your introduction, you can add on, and you can start your presentation. Yeah.
Right. Thank you very much, Dr. Nurul, for that kind introduction. And start sharing my screen now.
Yes. Dr. Harshvardhan is, I think, get disconnected. He would be joining again, I think. He gonna talk on digital workflow on materials in contemporary implantology. Unmute, Dr. Arya. Yeah. Yeah, it's now visible. You unmute, Dr. Harshvardhan. Your microphone is unmuted mode.
All right. So now can you hear me?
Yeah, it's visible. Yes, yes.
Right. Screen.
Your slides are visible, but not in
Okay,
a slideshow mode. Yeah, no, it's slideshow mode. Perfect, perfect. Go ahead, sir.
Okay. Yeah, sorry for that. I'm actually outside my city, so the network may be a little affected, but I'll try to do my best. So first of all, thank you to the organizing committee of this wonderful online platform. I think this is a great way of sharing knowledge and learning, because we find it difficult to travel to different places in a year to attend conferences. Here we can sit at the comfort of our own home and learn and share. So without wasting much time, today's topic of my presentation is digital protocols and various materials in contemporary implantology. My colleague, Dr. Sejin Chandran, will later on tell you more about digital implantology. Yeah. So why is there a need to understand them? Why do we want to understand this? We have to know the various materials that are involved in um, production of various restorations in contemporary implantology. And as you know, that this is a very rapid field, and what is being used today can very well change tomorrow. Um, we the newer materials and techniques keep on coming, and we have to keep ourselves abreast with these developments. we have to develop clinical protocols which are efficient, which are faster, which are easier, which involve less of repeats and problems, right? So efficient treatment with enhanced patient satisfaction. So today's patients are very well informed. They are aware of the options that are available today, and they want to choose something which is going to be efficient as well as cost effective. So the first step into digital dentistry is by the virtue of intraoral scanners. And few years back, this was a very a commodity which was rare. But today there is so much to choose from. So here you can see that there are variety of intraoral scanners available in the market, and we are spoiled for choices. The cost of these scanners has also come down, and it is up to us to evaluate whether all these scanners are going to work in the our clinical scenario, right? So is there a difference between a cheap scanner which is just costing a few lakh rupees, and as compared to some premium scanners that might be at least 4 or 5 times costlier than that? So does speed and accuracy really help? So we come to these parameters to evaluate any intraoral scanner when we are talking about digital implantology. So in specifically in implantology, we need both these things. We need speed and we need accuracy, right? So if you look at these studies, there are a number of studies coming in regarding these parameters. And especially when we are talking about scanning for full arch implant cases, this is where things get really interesting. And most of us want a protocol where we can make a scan and then deliver the restoration in as less appointments as possible. So if you look at these studies, they will find that that the deviation today with the premium scanners is very less. The scanners are becoming more and more accurate, and we are finding that uh, with the advent of newer technologies, the accuracy is increasing. So the conclusion of these studies is digital impressions for full arch implant supported prosthesis can be as accurate as conventional impressions, depending on the scanner and very importantly, the software. So it's not only the hardware that is important, but it is also how comprehensive the software of these scanners are. So my suggestion to all the clinicians who are going to venture into getting an intraoral scanner is don't only look at the hardware, but also give a thought and study the software carefully, because that is what is really going to make a big difference. So those who practice implantology, this is my question: that is your lab still asking you to take this kind of a jig trial? If the answer is yes, which means that your lab does not trust the accuracy of your intraoral scanners. So in spite of having a scanner, if you send a scan using various scan bodies, and if your lab on the next appointment sends you a jig like this, that means they don't really trust your scanner, and they want to be sure there's absolutely nothing wrong with it, because we want
There is a connectivity issue with Dr. Harshvardhan Arya. Let him connect again, or let the connectivity rejoin, then he will continue. Just wait for a while. Sorry for the inconvenience. Yes, continue, Dr. Harshvardhan. Unmute, sir, unmute. Dr. Arya, could you please unmute yourself?
Yeah, there. Yeah. Yeah, sorry for that interruption. I'm really sorry.
Not at all.
Some problem with the network. So as I was saying that scanning full arches is the real challenge. So I wanted to show this particular case. Let me go back a little. Yeah. So we have seen the how easy it is to scan the mandibular arch by using the modern scanners. And when we try and use a very good, fast, accurate scanner, things become very important. And I particularly want to show how the use of software helps us do things that can allow us to take one single scan and deliver the final prosthesis. So this was like a dream few years back, but now it is very much possible. We can actually take a scan using these scanners, and the next step can be the final delivery of the prosthesis. So this is how we are able to combine jaw relations in the same scan. As you can see, this is a complete denture made for the patient, and the reference
ठीक है, हम करते हैं, देखते हैं.
back. I'm is getting interrupted far very often, but let me try one last time. If it is not working out, I'll just have to excuse myself.
No, Dr. Harshvardhan, it happens. It happens.
Yeah.
It is a,
All right. So I'll be as quick as possible. So this bite alignment becomes an issue many times. We find that the software is not able to align the upper and the lower jaws in all the situation, especially when there are edentulous scans. And this is where the real challenge comes. But the software is improving, and there are certain tips and tricks that we can use. This is a very crucial step. If we are able to record the jaw relation at the time of the scan, then making the prosthesis becomes very easy. So once your scan goes to the dental laboratory, they will then start processing. They will directly choose the implant system from the library in the software like Exocad, and whatever system that you use, they'll be choosing a scan body, and they will start processing the restoration. So Sometimes what happens is some dentists are so obsessed with doing digital dentistry that their labs are not prepared. For example, they send an intraoral scan, but they don't have the relevant tie bases which are necessary for fabricating a screw retained restoration. So what the lab does is they will do a 3D printing of the model using a digital analog, and they will put a stock abutment there and fabricate a crown for you. They will scan that directly on the model and then prepare. So this is not really a true digital workflow, right? So they will make a crown just like how they do for a conventional analog model. So in digital dentistry, what you really need are these tie bases. These are specialized abutments which are very specific to the implant system that you use. So in this workflow, you will find that you first need scan bodies, which will be put on the implant in the patient's mouth, and then you will take an intraoral scan. So the scan bodies can be of two types. One is the implant level, which anchors directly into the implant. The other is multi-unit scan bodies, which obviously will work on multi-unit abutments when you are doing full arch restorations, right? And then what you need is a tie base. So these tie bases again will be either implant level for making single crowns or 3-unit bridges, or they would be multi-unit level, which are used in multi-unit abutment. And then what you also need is a digital analog. So your normal laboratory analog is not going to work in the laboratory. For doing a digital protocol, we need a digital analog, right? So once this crown is fabricated in the material of your choice, usually it is monolithic zirconia, this is then bonded onto the tie bases in the laboratory. So this involves extra oral cementation of the zirconia crowns on the tie bases. Now, this is done in the laboratory. It's not done in the patient's mouth. So there is no risk of excess cement going into the peri-implant sulcus, right? There are some dedicated cements which are available for this purpose, for cementation or luting of these superstructure onto the tie bases, right? So as you can see here, this is an example, intraoral scan taken using the implant level scan bodies. And this is the final restoration, which you can see it fits perfectly on the tie base. And once it is bonded, it is converted into a screw retained restoration, and it is stocked in the patient's mouth. So this is how it looks like. You have the tie base, which is sandblasted at the bottom. You have the superstructure, which is made in retention screw or abutment screw. Right? So here we have a completely screw retained crown, which is made from a single digital scan. This does not operations, right? You can of course work on at multi-unit level as well, and you can make bridges. For example, we are using lots of tilted implants these days, and when with these tilted implants, you need a corrected path of insertion, which is achieved by using the correct angulation of multi-unit abutments, and then we can prepare. Just to show you another example where you three-dimensional and two implants were placed tilted. One was a pterygoid, and the other is a conventional implant. Again. Yeah, I think I'm back. I'm really sorry about this, but let us try and proceed further. So this is the final result. So in the market, you see number of different scan bodies which are available. One must understand, and many times these dental laboratories will send you their own scan bodies. Now, this is okay as long as the entire digital workflow is perfected. However, my suggestion would always be try to take original scan bodies which are provided by the implant manufacturer, because they are made with the precise dimensions which are needed to deliver a perfect restoration. And we have to also ensure that these scan bodies are present in the library of the software that is used by the dental laboratory. So there is a third party syndrome which goes on, that somebody attends a big conference like IDS and they will find some cheap scan bodies and they will bring them. But you need to understand that just having these scan bodies is not enough. You also need a digital analog which is pertaining to that particular scan body. And then you also need other components like the tie bases which are needed. So tie bases which are conforming to that particular scan body. Unless you have this, all the three things in place, your accuracy can be compromised. Right? So here you see an example of a peak scan body. So this is made up of peak. It is autoclavable, obviously, and can be reused. There are certain implant systems which give metallic scan bodies, which are supposed to be more rigid and more resistant to distortion after repeated autoclavings. Right. So this is an example of metallic scan bodies which you see. So try to confirm to the manufacturer, and whatever scan bodies is provided by your implant system, that should only be used. Right. So when we talk about full arch restorations, what are the modern ways in which they are being fabricated? So till a few years back, we were making either hybrid dentures, where there was a casted metal bar on which denture acrylic teeth were acrylized. Okay, this was the first type of full arch restoration, especially for FP3 type of cases. Then, of course, porcelain fused to metal became very popular on multi-unit abutments, and even today, that is one of the options that we have. We have, a framework which is laser sintered, and then over which ceramic is layered. But what we are now moving on is much better, stronger, lighter types of materials. Like we have the milled titanium framework, on which we can have either PMMA or we can have zirconia as the superstructure. So this provides best of both worlds. So you have a very light, accurately fitting framework on which you have a very strong aesthetic material as the final one. So as you can see here, this is a scan of a maxillary arch with around 8 implants in place, and 7 implants, sorry. And then from here, we are able to directly go to the next stage, where this is a titanium bar with PMMA superstructure. Right? So directly second visit, we are able to deliver the final restoration. So this is especially good for outstation patients who cannot come to your clinic again and again. And everybody would like less appointments and achieve the excellent results. So this is the final. The upper arch is in PMMA, and the lower arch was done many years back. That is in layered PFM, full arch framework. Right? So this is how a laser sintering technology works. We have stopped casting now. We are not doing casting in implantology. We are doing laser sintering. This is a very accurate additive manufacturing technology by which we are able to make various metallic frameworks and restorations like partial dentures. So we are using metals like cobalt chromium or even titanium. So here you see layer by layer, the material is deposited by the machine and a laser comes and fuses them together, right? So this is a DMLS partial denture. The framework was So I'm really thankful to the audience that you're still around in spite of these interruptions. But we'll go ahead and try and complete this. Thank you very much, and my sincere apologies to you for this
Not at all.
repeated interruptions.
Not at all. It's happened sometimes. It's a connectivity issue. Carry on. Continue.
I'm sorry.
Not
I
at
was
all. Yeah.
so
Please, please. Yeah, go ahead, sir.
So till now, whatever is said, is it clear? You are able to hear properly?
Sir, you are audible, and it's a very engaging, sir. Yeah, it's
Thank you. Thank you very much.
yeah,
Thank
okay.
you. So, all right. So, okay. So from here we move to custom multi scan bodies in the mouth. Take this scan, and the framework is designed and then it is layered. So just to show you an example of a PFM based full arch framework, which was made by laser sintering and then layered. Right. Then, of course, we are able to combine different materials together to achieve a good result. So this patient was restored with full arch implants, full mouth implants. So we have the PFM or porcelain fused to metal in the upper arch, and we have a hybrid framework in the lower arch. So it's not necessary that you have to stick to only one material. Depending on the need, you can mix and match. So this is an OPG showing both the arches being restored, the upper with PFM and lower with hybrid titanium bar and composite resin hybrid for the lower on an all-in-four. Another type of variation of this is the mallow type of frameworks, which were very popular till a few years back. Personally, I don't like this type of configuration because it is very difficult to retrieve. Although it looks very aesthetic when it is delivered, but it is the retrievability part is very difficult because you see that either the hole comes on the labial surface and then you have to cement the crown over it. So this will have a basic framework on which there will be individual PFM or zirconia crowns. So this was very popular a few years back, but all clinicians as well as laboratories have realized that there is a problem in retrievability, and because of that, now this is not being used very commonly now. Right? What is popular now and what is recommended is milled titanium framework. And if you see at the bottom, you can see the milling of this framework. So this is one of the most accurate frameworks that can be produced out of a disc of titanium, and most 5-axis modern machines are able to mill. Obviously, the disadvantage is that it takes 5 to 6 hours to mill one arch, and it is expensive. Right? So but when it is done properly, you find that you have a combination of two very good materials, that is titanium and zirconia, and you have a framework which is made in titanium over which monolithic milled zirconia framework is bonded. Again, like tie bases, this single piece framework, it can sometimes be in 2 or 3 pieces also if needed. It is bonded on the titanium. So you have the fitting surface on the implants, which is made in titanium, and you have the tissue surface, which is in zirconia. So you have a very aesthetically looking prosthesis. Now, when we want to make such kind of prosthesis, we must be very sure about the position of the teeth and the lip support, etc. So it is because these techniques are very expensive. If you get something wrong and you realize it at a later stage, then you will have to repeat the entire procedure again. And it is very expensive for the lab as well as for the dentist. So it is better to take a PMMA trial like this in the mouth. So as we make prosthesis in various parts, my presentation is also coming in various parts. But thank you for your patience. Okay, so I like to take a PMMA trial even after with the titanium trial, because we want to ensure that aesthetically we have all the parameters in place. So PMMA, this PMMA is 3D printed. It is very cheap, so you can make 2, 3, 4 trials at a very cheap cost. But it is always better to get the trials right, and then you deliver the final. So this is the final restoration. It has a titanium framework over which you have zirconia. So a lot of aesthetic characterization can be achieved. And the best part is that it is very light in weight. So this is how it looks like on the radiograph. It is very light and patient is very, very comfortable. Now, this concept can be used for partial applications also. It is not only limited to full arch restoration. Here you can see that partial frameworks, even 3-unit bridge can be made by the same technique over multi-unit abutments, and you can have the superstructure either in PMMA or in zirconia, right? So today the digital protocols have improved so much that we are now doing complete guided surgeries and digital planning. I'm sure you would have seen number of cases being put up on social media. For a long time, since I have been doing freehand implant placement for around 20 years now, I was very skeptical about using surgical guides initially, but once I started using them, I realized that how good results we can get. So this is a case of failing upper dentition and lower, which has been long-term edentulism. We extract the teeth, we put the surgical guide here, and we fix the surgical guide and start placing implants through them. So this is fully guided protocol. So these are the implants placed and the multi-unit abutments which have been installed. So in such guided approach, we are able to select the abutments ahead of time. Even before the implant surgery has been started, we know exactly what multi-unit abutments will we need, and we order and keep them ready. So that saves a lot of time in mixing and matching these abutments in the mouth. You can see there are only 2 angled abutments in the distal configuration. All other anterior abutments are straight. They have straight multi-unit abutments. So we had just 3D printed a prosthesis just to verify whether our planning was correct. And we see here that the planning is so accurate that the access holes are coming exactly from the areas where we had planned. So this is the modern way of scanning. This is using photogrammetry, and these are very special types of scan bodies that you probably would have seen sometimes in social media, some of the clinicians showing this. This is supposed to be the most accurate way of taking scan intraorally for full arch frameworks. And it basically, the speed increases tremendously. Earlier, there was a extra oral scanner which was needed to scan these kind of scan bodies. But now many companies have come up with intraoral scanning. See more and more often these kind of scan bodies being used for the upper as well as for the lower arches. And we have this prosthesis. The upper is titanium with PMMA, and the lower is traditional hybrid. So I just wanted to see how accurate they can be, and we find that the results are quite accurate. So this is the final result. You can see everything is planned and executed as per the plan. So this saves a lot of time for the patient and the clinician. And the most remarkable thing that you see is on the next day of surgery, the patient has no swelling, zero pain, no hematomas, because all those are consequences of raising the flap and doing a lot of bone reduction. Now it is possible to avoid that. May not be in all cases, but most of the cases. So this is sometimes do zygomatic implants and scan very challenging with the traditional or bodies, and that is where we are moving on to photogrammetry as a scanning technique, right? So these are the various types of materials that can be used. Another exciting framework material is bio HPP, that is actually PEEK material, which is reinforced with filler particles. So it is possible to make custom abutments in PEEK or even custom full arch frameworks. So I'll just show you a case. This is a full arch implant case where the framework is made in a non-metallic material. imagine a non-metallic material which is 4 times or 5 times lighter than cobalt chromium. It is absolutely inert. Okay, it doesn't have any allergic potential. It is very inert material. It has been used in orthopedics for many years, and now it is being introduced in dentistry. It has been around for a decade. And you see here the framework, and you have milled milled composite teeth, right? So here you see the upper and the lower arches, where you have the full arch configuration only on 5 implants. So we need something which is lighter. We cannot have a very heavy material here. And then these are bonded and they are layered using composite resin. So the lab will do layering of the gingival portion and staining and glazing, and it can be made to look very, very natural, and a lot of characterization can be done. So this is the finished product from there, and this is how it looks like in the patient's mouth, right? And when you see the OPG of the same case, you see it is non-metallic, right? So you are able to see the fitting of the multi-unit abutments and the framework through the framework. If you remember the zirconia case, everything is radio opaque. You can't see or make out anything at all. So this is that one of the few advantages that we have of this kind of material, right? So what are the pros of using CAD/CAM technology? You have accuracy, you have predictability, it is faster, definitely, and automation is less dependent on manpower. So it is not dependent on the skill of the technician. Once you design, of course, designing skills are still necessary, but hand skills are less important. So you get more predictable results, and a lab can cater to a number of dentists. So mass production is possible. What are the disadvantages? Yes, it is expensive to begin with and requires some substantial initial investment. If a CAD/CAM machine breaks down, everything stops. So because you are so dependent on digital technology that many newer technicians don't know how to do a casting and process, right? So it can be a problem sometimes, and it can reach to a bottleneck. And dentists have to update. So I don't see this is necessarily a disadvantage. It can be an advantage. You have to update yourself and learn about these technologies. So last, before I close my presentation, talk about 3D printing, which is emerging as a very rapidly evolving technology. And there are various applications of 3D printing, like making models. This is where we started from. But now we are making even splints, which are 3D printed, aligners, which are 3D printed, surgical guides, which are used more and more often now. And we are also now, I have reached the stage where we are able to print composite crowns and bridges. So earlier they were temporaries, now they are permanent restorations. And very soon you will have 3D printers which are already in the process, which will be able to print EMAX, that is lithium disilicate, as well as zirconium. So the future is that every dentist will have a 3D printer, just like how we have intraoral scanners now, which are becoming so popular. Very soon, within few years, my guess is less than 5 years, all dentists will have a 3D printer in their clinic, and they will be able to fabricate simple restoration themselves, right? So what are the advantages of 3D printing? It is very convenient, it is very fast, it is cheaper than milling. So most of the times it is far more cheaper to do 3D printing. And the disadvantage that it is continuously evolving technology. So unlike milling, which has been around for more than 15 years, and it is still very stable technology, 3D printing keeps on changing every few months. So some new technology comes, it was LED, then there were structured light, and there were so many different materials. It requires higher maintenance. So 3D printers typically require more maintenance as compared to milling machines. Very strong materials still cannot be printed. So like I mentioned, zirconia, it is still in the research stage. They are not able to match the efficacy of milling zirconia and then sintering it by 3D printing. It is still in progress. So just to end my presentations, digital dentistry with intraoral scanning and CAD/CAM softwares is the norm now. It is not the future. It is being used every single day in all the laboratories, and it is accessible to everyone, not only in big cities, but even in smaller towns. Now, knowledge regarding these techniques have to be updated. So dental laboratory usually to newer technologies. Dentists, however, lag behind sometimes. So it is not enough now, to give your scans or give your files to the lab. You have to participate more in the design process. Okay, wide range of material is now available, and you need to understand these materials so that you can choose a more appropriate material for the given situation, right? So what material combination works for one case may not be the best choice for another case, right? So you have to be aware of these materials. Analog dentistry will still be relevant. Remember that we are in the digital era. Doesn't mean that we should forget our skills of taking impressions or making impressions, taking jaw relations, and sometimes using the very traditional techniques. Because sometimes you'll be stuck in a case where digital protocols will fail and to use the analog dentistry, right? The overall involvement of dentists in the laboratory process is going to be more and more. So, for example, if you work with a So finally, we managed to finish the presentation in time, and with a lot of hiccups. So my sincere apologies once again to all of you for this. So last 2 points, yeah, this is where we have completed. Thank you very much, Dr. Nurul, for this opportunity, and I'll be happy to answer any questions if there are.
There is a one question on the chat, Dr. Arya.
Yeah, please go ahead. In the chat, okay, can you please read it for me? Can you read the question, please?
Just wait, I'm just checking here.
Yeah, sure.
There's a question is, what is the role of virtual articulations in regard to full mouth restoration with implants?
Yeah, okay. So it's good that you have asked this question. Virtual articulation is present in almost all design softwares today, like Exocad or 3Shape. And there are certain devices like a digital Facebook, a jaw, which are available today in the market. But however, even without these modern devices, it is all the softwares already have a virtual articulation. It is up to the technician to use certain mean values, which how we were using a mean value articulator or a semi-adjustable articulator, and design your case. So even when you do not ask for it, your software in the laboratory is already using some sort of virtual articulation. Okay? Now, if you want to be very particular about giving some values which are pertaining to the jaw motion, like condylar inclination, like immediate side shift, like Bennett angle, you can record these values by whatever means, by analog or digital, and convey it to your laboratory. Now, all technicians are not aware of this digital articulation. It works in the background automatically for them. But if you want to go you achieve more perfection in occlusion, you can use these values, communicate them to the technician, and they can incorporate these. So a virtual, the software will have a representation of all the articulators that are present in the market today, and whichever articulator you like to use, you can communicate these values. Now, practically speaking, I personally do not do this because, like I mentioned, some mean values which are already fed in the software works very well in most of the cases. But if you want to be more accurate, you can do that. So these things are available. Virtual articulation is available.
Any more question from anybody who want to ask question with Dr.
Yeah, sure.
Harshawardhan? Yeah. So Dr. Harshawardhan, there is no more question, and if you want to stay with us, you can stay. Otherwise, if there is any question comes, no, I will ask after the talk of Dr. Sankalp Mittal. We have a next speaker who is
Sure. Most welcome. Once again, my sincere apologies for the interruptions in between. And thank you.
It's very embarrassing for me. You are to many times for apology. It's happened.
Thank you very much. Thank you. I wish. Yeah. Thank you. And I wish the conference very well. And please enjoy the rest of the sessions. Thank you very much.
So with this note, with your permission, Dr. Harsh, we are going with our next speaker, Dr. Sankalp Mittal. Dr. Sankalp.
Yeah, sure.
Yeah. Can you unmute yourself, Dr. Sankalp? Yes. Yeah. So, Dr. Sankalp, I'm just giving your brief introduction. Dr. Sankalp Mittal is a professor in oral and maxillofacial surgery and superintendent and additional principal, Government Dental College, Jaipur. He's a registrar of Rajasthan Dental Council, and he's also a diplomat at AOI, ICOA, and WCOI. Over to you, Dr. Sankalp. If you want to add anything in your introduction, you can add and you can continue. Your
Am I
slides
audible?
are visible, yeah.
Hello?
Yeah, Dr. Sankalp.
Yeah, so my screen is visible, sir?
Yeah, your screen is visible.
So good morning, everyone. And of course, it is a pleasure to be part of this unique, totally online conference. So I would like to thank the organizers and Mr. Naul for inviting me to share my views on implant complications. Because it is initially when I was asked to give the title of the presentation, I said I'll speak on the implant complications. But when I went through the theme of the conference, I realized that it is mainly on the digital dentistry. So I slightly modified my presentation, and I'll be speaking on the complications of the implantology, which finally I somehow managed with the digital technology. So my topic will be the digital rescue, how I manage that implant complication with the digital technique. So probably this is how this lecture will fit into the theme of the conference. And this will give you insight also that these complications could have been prevented if from the beginning itself, I would have used some guided software or the implant planning software, or at least I would have had a look at a CBCT. So most of the time you will realize that these complications has happened because either we don't pay some attention preoperatively to the details of the patient. And then, of course, some intraoperatively overconfident we are. So we make the small mistakes, which usually we don't think about. And that is where the digital planning plays its key role. When you are planning digitally, you are compelled to go through the preoperative data, pictures, intraoral scans, and the CBCTs. So that gives you a mental picture that how you have to go ahead with the particular case. And mostly, this is the most important thing which will prevent you from the complication. Like this is, I will show you 4 or 5 cases. These are interesting cases. I'm sure you will enjoy it, and it will give you the message also that how it the digital technology, how it helps us. So like this is the first case. This was a old age lady which was referred to us, and the history is that implant was attempted few days back in the right upper 7 region. And now some complication has happened, so she was referred to me. When she came to me at that time, she was not having any particular complaint. slight inflammation was there internally, you can see at the upper 7 region. Otherwise, as such, there was only mild pain and no complaint. But the history was that implant was attempted and some complication has happened. So when I took the CT scan, when I had a look at the CBCT, now you can see that actually it was a case of attempted indirect sinus leak. So indirect sinus leaks were attempted. And when my colleague was, or my friend was trying to put the implant inside, suddenly it disappeared. So then in post-operative CBCT, they realized that the implant is displaced into the sinus, or it is now, you can see on the cross section of the CBCT that it is actually, the implant is displayed at the floor of the sinus. So that is why this case was referred to me for the management. So now the question arises is what to do with this implant. And after removing or keeping this implant, whatever we decide, what about the next step to how to restore the patient? Because patient went to that dentist because of the desire of that having a tooth in the upper 7 region. So we had two problems. One is to remove the implant. Another is simultaneously, if it is possible to place another implant. But because already we had a deficient bone there, that is why the dentist tried to do indirect sinus lift, which unfortunately led to a complication. So this is again a post-op picture. You can see the implant is placed just at the floor of the sinus. So now the interesting part is what I want to show you is when I put this post-operative CT scan on my implant planning software, like mostly I use a DTX implant software, which is from Nobel Biocare. So when I put this post-op CBCT on the implant planning software, you can see in the 3D image, the implant is, and can you see this is the implant, which is in the sinus. And can you see I have superimposed the intraoral scan also on the CT scan. So now we have an intraoral scan, we have a CBCT, and we are taking a help of an implant planning software. And on the implant planning software, when I was playing with the different methods available on the software, then I realized that if I tilt my implant direction slightly towards the mesial and slightly towards the palatal, then I have a lot of bone available to place another implant. So can you see when I tilt my axis slightly towards the premolar, not too close to its root, but slight angulation, say 15 degree towards the premolar. So I have plenty of bone. Even if I place my implant straight, I can place a 9 millimeter long implant. And if I place my implant slightly more palatally, I can get away with a 15 millimeter long implant. So now you see the digital planning has changed the entire scenario. It was a case where we were not able to place the implant because of the deficient bone. And slight tilting of the implant axis is giving us so much of bone that I'm sure that if I use this angle, I'll be able to load it immediately also. So now one thing we know where the bone is. The bone is slightly mesial and slightly palatal. Now the question is, will I be able to place my implant, second implant? First implant has gone into sinus, second implant into this desired direction. So of course, with the experience and with repeated multiple intraoral IOPs and all, you can try to do this. But now you also know, I also know that it is not short method. Then what to do? Then the best thing is to make a guide. So we virtually place the implant in the same direction, in the same bone. We could realize that we can easily place a 4.3 millimeter into 15 millimeter long implant in this direction. Another view, again, you can see that if we go slightly palatal, there is plenty of bone available. There is no need of going to indirect sinus lift in this case. And we can avoid the sinus. We can go palatal to the sinus. So you can see our proposed implant will be palatal to the direction of the first implant. And mesiodistally also, you can see that we have sufficient safe distance from the root of the adjacent tooth. So this is virtually the implant has been placed. Once we are satisfied with its location, and the bone surrounding with it. Then we plant a guide over it. So you can see an intraoral scan is very important when you plan a guide, especially a tooth supported guide over a CBCT. So this is a guide was designed and then it was printed. I'm sure by now you must be knowing it that when you design the guide, you make a STL file, you send the STL file to the 3D printer and then makes a guide. In the guide, you need to put an implant specific sleeve. So that you usually get from the implant company. So the implant specific sleeve you put in the guide. And then another thing you need is a guided surgery kit. So of course, for every implant system, there is a specific guided surgery system. So you must have different, whatever implant system you are using, I'll advise you to have a guided surgery system of that particular system. So this is the guide. Now through the guide, we are doing the surgery. Now you can see this is a novel implant. So in the novel, you have key system. So there are, the drills are same. You have different keys which decide the diameter of the hole and through which you drill. So this is the implant which is placed through the guide. And we got sufficient stability, sufficient primary stability. If I remember, it was more than 15 Newton centimeter. So that is giving us the confidence that we can load it immediately. So now you see what has changed. I have not done anything extra. The drilling protocol is same, which you people also use. What extra I did is I just put this CVCT on the software and I realized I just found the bone where it can be placed. That's all. And then I made a guide which helped me to place the implant in that bone. So this was flaplessly, it was done. And then once we are satisfied with the implant placement, then we thought about the previous implant. We gave a crestal incision, vestibular incision, made a window in the maxillary sinus, and then removed the previous implant, and then closed it. And this is just after a few days, you can see we have given a prosthesis also to the patient. So again, I would like to emphasize that from a case where we were thinking that there is bone is not there and we might have to do an indirect sinus lift, forget about the immediate loading. And then that led to a complication. That means the implant was displaced into the sinus. And then from there, we are landed up to a immediate loading and an immediate prosthesis given to the patient. So it changes a lot in the patient's perspective also, and it gives you confidence. It gives confidence to you also. This was post-op OPG. This is IUP after a few months. You can see there is no bone loss. Usually we think that if the implant is tilted, if it is not axial, there might be some forces and it can lead to bone loss. So in my opinion, if your implant abutment junction is good, mostly there will be no bone loss because of the tilting of the implant. We feel that this implant is tilted, but actually it might be in line with the occlusal forces. So this is the first case I wanted to share that how manage the complication with the help of digital thing. This is the post-op CBCT. It is showing that where exactly we have placed our implant where we wanted to. Slide mesial and palatal up to the nasal floor. Coming to the second case. Now this was another important case. We planned for upper full arch rehabilitation with 2 anterior implant, 2 zygomas and 2 pterygoids. So when the patient came back to us for the prosthetic rehabilitation, then we realized that this is the left pterygoid and this is the right pterygoid. So right pterygoid has a mobility. So actually it was not in the pterygoid bone only. You can see this is the right implant which was supposed to enter into pterygoid. You can see it is going back, and it has just missed the pterygoid and it is lying lateral to the pterygoid plates. So it is actually lateral to the maximum. So that is why when there was no bone to engage it, so it was mobile. Initially, probably intraoperatively, we got some stability because it has perforated the posterior lateral wall of the maxilla. But that was not sufficient to hold it or to get it integrated. Eventually, when the patient came to us, it was moving. So now we had to remove it. There is no other way. There is no point of waiting. So we removed it. Now, once you remove it, Now we had two options, either we use these 5 implants and make a prosthesis. But if you see this, if you make a prosthesis on this right side, there will be a huge cantilever. And that will lead to again detrimental forces on the anterior implants. So another option is we do a sinus lift and place an implant. Third option is we again try to place a pterygoid. But since once we have failed in the pterygoid, probably it was a difficult case, maybe some direction is particular so that we miss the pterygoid. So this time we thought, why not to plan it virtually, and if it is possible to place a pterygoid in this, then try it with the guided system. So then we put this CBCT on the virtual planning software. In this case, we use 3-shape implant studio. And you can see we planned a guide. We planned a pterygoid implant going from the tuberosity to the pterygoid. So the red one is the pterygoid, the yellow one is the part of posterior maxilla. And it looks like that if we go through the guide, we will be able to achieve the desired position. So how to make a guide? Again, as I told you, we need a CBCT and we need an intraoral scan. So we took the intraoral scan with these abutments and the healing caps in position so that the guide will be able to seat over them and the guide will have some sort of stability. Unlike the edentulous cases in which usually the guide is mucosa dependent and the stability is an issue. So we made a guide. You can see the guide is seated perfectly over the already placed abutments. And then this is the area where we want to drill. So again, I would like to emphasize that you need a CBCT, you need an intraoral scan, and then you need an implant planning software. Once you do the implant on the implant planning software, mostly these are free versions are available. On the free versions, you can plan the implant. But if you want to make a guide, then you have to convert that plan into STL format. After STL format conversion, you send that file to 3D printer. So you can have your in-house 3D printer, or otherwise you can set that file to any lab which can print for you. Now, once the guide is printed, again, you need this sleeve. Sleeve comes from the implant company because they are implant specific. Now you put this sleeve inside, and then you need an implant surgery kit. So in this case, I used the Norris implant because Norris has got some specific implants which are made for pterygoid region. They are sharp apex and then progressively enlarging body, so it suits in the pterygoid region. Another important thing is Norris has got a kit, guided surgery kit specifically made for the pterygoid implants. So this is that kit we used, guided surgery kit for the pterygoid implants, and it has got a long drill which goes up to the desired depth. And then after that, can you see on the entire depth we got the bone. So we were very happy then, and this is how we use the implant kit. And the implant was placed through the guide. Again, you can see that in a position where we were not able to place the implant, where we failed to place the implant in the correct position. And it was our second attempt. Usually in the second or third attempt, we try to open the area. We want to be doubly sure that we are going into the bone. So mostly we raise the flap and place the implant, but because we were sure, because of the guide, that we are going into the bone and in the desired direction, it could achieve this stage with the flapless technique. So important thing is you spent a lot of time on the preoperative planning, on the preoperative guide fabrication, but intraoperatively now you see how much time and effort and the morbidity you are saving, and with the predictability. So now there is no need to raise the flap. There is no need to suture. There is no swelling post-op, no pain post-op. So everything is same. And is in spite of being flapless, you know that you are into the desired direction and the desired place. So this is how post-operative it came out. The implant was in the place, and you can see the CBCT. Of course, when you do such sort of cases, you should have a curiosity from inside that how my case went. So every case should be followed by a post-op CBCT, and you should honestly check it whether I have achieved my desired goal or there is some deviation is there. If deviation is there, you should be able to find out the answer why, what was the need, what was the reason for the deviation, so that in next case you can avoid those. Anyway, in this case, God was kind that we were able to achieve what we planned with a good stability. So we could load this case again immediately. We started with the prosthetic procedure, and within few days we finished the processes. And this is the cross section. You can see the implant is exactly in the middle of the pterygoid. This is how the prosthesis is finished for this case. So again, I can tell you that though it was able, again, we could have tried the placing the second pterygoid without any help of any guide. But again, it is not about the question of whether we will be able to do it with Laplace or without any guide or not. We could have been able to do it without guide also, but it is about the predictability. The main thing is predictability. The key word is predictability. That how sure you are that in this attempt, second attempt or third attempt, I'll be able to achieve the goal. So you are the surgeon, you will be doing the surgery, but in between, if you take the digital help, it maximizes the chances of success. Now, the third case I would like to share is another case in which most probably I missed on the planning part. This patient came to me with the missing posteriors. You can see the root stems are there in the upper maxilla, in the maxilla. So,
Dr. Sankalp, sorry to interrupt you. Your the next speaker after you is Dr. Puneet, and he's supposed to take flight. So you can finish, as soon as possible. It's one. So you take time, no worry, but just try to conclude so that he can join.
I'll conclude after this case.
Yeah, please. You can take time,
So
but yes,
after
yes.
this, in this case, I put 2 implants on the left side, 2 on the right side, and gave a screw tail prosthesis. So it went well for few years, but after a few years, patient came back with the mobility on the left side. On the left side, when I removed the prosthesis, then I realized that the left implant is fractured. The left implant is fractured in the pterygoid region. Now you see there is no bone in the 6th region, 7th region, and the pterygoid where we wanted to have anchorage, there is already a fractured implant. Now, what are the options we have? Now, one option is again we do a sinus lift and wait for some times, or place a zygoma. But if you want to place a single zygoma and combine it with the anterior implant, one anterior implant, there will be too much of flexion. So then again, I was fortunate. Then on the IUP, I realized that beneath the floor of the sinus and above the fractured implant, there is some bone is there, and we can try to place the implant there. So again, I put it on the DTX software, and the DTX software, to my surprise, it was possible. There was so much of bone was there that it was possible that we can place another pterygoid bypassing the fractured implant. Again, the question remains the same, whether we can do it freehand or not. So again, we made a guide, printed a guide, and then placed the implant through the guide. So we were fortunate, patient was also fortunate that we were able to achieve what we planned. So this is the second implant we placed there. And then we could get away with this case with the help of guided surgery. So guided surgery is usually very, very helpful in managing all the complications. This is another last case I would like to show. This was a case where we put multiple implants. Some implants failed. This is the last implant we placed. This went into the sinus, going into, so this was also moving. So when we, now you see, this is the sinus, this is the anterior wall of the sinus, and there is a small amount of bone which is available between the sinus and the distal implant. So we wanted to place another implant in this small bone. Now the question is whether we can do it freehand. We tried freehand, but we end up placing this implant. So it was very difficult to place this bone implant here without putting this implant or without entering into the sinus. So again, we made a guide, and through the guide, we placed this implant, and we were able to achieve a good primary stability and the perfect implant position where we wanted. So we could finish this case with the help of digital technology. So before I finish, I would like to show this. This was my initial guide way, I think 10 years back when I ordered it. So On the planning, it is for the mandible. So can you see on the planning, it was looking like the implants were in the center of the bone. But when the implant guide came out, can you see the implants were coming out in the center of the floor of the mouth? So pre-operative planning is very, very important. Guide is not important. Guide will give you the result what you have planned the guide. So if you are not taking care, if you are not using your brain, guide can also fail or guide can also lead you into the wrong position. So it is basically your efforts and your experience which you combine with the digital technology that will lead to a good results. Thank you very much. If any questions are there, I'm happy to answer. Otherwise,
Thanks, Dr. Mittal. Very, knowledgeable the presentation. And anybody want to ask the question, they can put the question. They can unmute himself or herself and ask question here. Otherwise, they can put on a chat box as well, and we'll forward it to our speaker. So there is no question, Dr. Sankalp. If you can stay with us for some time, so that if the question arises, we can come back to you in a chat. With your permission, should we move on to the next speaker, Dr.
yes,
Sankalp?
please.
Yeah. So our next speaker is Dr. Puneet. Dr. Puneet, can you unmute yourself? Yes.
Yeah.
Good afternoon, sir.
Good afternoon. Good afternoon.
So before we start, I'm just giving you a brief introduction of Dr. Puneet. As an organizer, our responsibility to introduce formally. Dr. Puneet Batra is Pro Vice Chancellor, Dean, School of Dental Sciences and Dean, School of Allied Health Sciences, Professor and Head of the Department of Orthodontics and Dentofacial Orthopedics at Manav Rachna Institute of Research and Studies, Faridabad. He is President, Indian Orthodontic Society. He is a member of Dental Council of India. He is a member of Smile Train Medical Advisory Council and Research and Innovative Council. He is a past president of Indian Society of Cleft Lip and Palate and Craniofacial branch. Then he is a secretary of IDA Southwest Delhi branch. He is consultant orthodontics and implantologist, Dr. Shweta's Dental Clinic at Delhi. And he is a cleft orthodontist, Global Hospital and Research Center, Mount Abu, Rajasthan, Sant Permanent Hospital, New Delhi. Recently, he is a recipient of PP Jacob Award at KG Kannan Award of Indian Orthodontic Society. He is a recipient of a Commonwealth Scholarship at Great Ormond Street Hospital for Sick Children, London, and TC White Award for Dundee Dental School of Scotland. So over to you, Dr. Puneet. If I want to add anything, you can add. It's a very brief introduction. If I missed anything,
No, thank you so much for this introduction. I'll just share my screen and I'll quickly go through a presentation. I'm sorry, actually, I have to take a flight. I am in Goa. We have the 25th year celebration of the Indian Board of Orthodontics. I'm one of the diplomates as well as the president of the society. So I just would like to say the role of digital technology in cleft care is something which I have been working on since many years. And it's very important for us to understand that with children born with cleft lip and palate, they require a team approach. So about 40,000 kids are born in our country every year, and it requires the presence of dental specialists, including prosthodontists, or orthodontists, dental surgeons, periodontists, as well as a team of surgeons, maxillofacial surgeons, including plastic surgeons, as well as speech therapists. So, the teams are many now. There was a time when there were not many cleft teams. And if we talk about digital dentistry also has a very long history. It is from the year 1965 when the lasers were first introduced to a number of intraoral scanners, 3D printing. You saw just before this talk a discussion of use of splints, 3D printed, as well as multiple options. So, what is digital dentistry? Dentistry's basics have not changed. The basic principles remain the same. However, we are looking at more effective and efficient methods of treatment. And also, we need to make sure that the highest quality of dental care is given to the patients, along with a better experience for the patients and more reliable and accurate treatment to them. So, digital technology makes that possible. There is a viewpoint that when you go digital, you do not require to work with the basics. It's not true. The basics remain the same. So, what does digitization offer? It offers a digital impression. When you take an impression with an elastomeric material or with alginate, digital impressions make it more fail-safe as well as more accurate. There is also a possibility of, planning vectors, planning treatment using CAD as well as printing the appliances, and 3D printing is a possible solution. So what it does is that, the patient is not waiting for the appliance to be fabricated. It can be given right away and it can be monitored remotely. Now a patient visit just to say that everything's going well is not required. You have remote monitoring platforms where you can assess the treatment outcomes and follow it up. So, there are various instances in cleft patients where you can do proper, documentation, study model analysis, analysis of smile design, treatment planning, and fabrication of orthodontic appliances. So treatment planning in 3 dimensions can be done using computer-aided design and computer-aided manufacturing for appliance customization and software integration of digital models. 3D facial imaging and CBCT can actually make it possible to simulate the treatment plan and also communicate with the patient. So, when we look at the advantages of it, you can do a digital videography where you can record the patient's speech, oral function, and smile, and assess this information, improve the efficacy and consistency of treatment outcomes, and also look at outcomes in a more better way. So, I was commissioned for FDI to create an innovative solution for cleft care through digitization with a group from Colombia and Scotland. And this is Dentsply Sirona, which also was a partner to it, and Dr. Reina Seaman from there contributed to this course. So this is available free online, and there are 2 MOOCs which are available. One is on oral health professionals, and one is for cleft care teams. This is the QR code. If anybody wants to scan, you can do the course free of cost. And once you answer the questions, you can download a certificate which tells you that you've learned about how digital workflow can be used in cleft orthodontics. So how do you make these workflows? Let's look at each of these workflows. Cleft orthodontics involves 4 phases. One, when the child is born, where you can do pre-surgical infant orthopedics. One in the mixed dentition, which is this red box, where you are preparing the patient for bone grafting, and also you are doing maxillary protraction. Then the regular phase of orthodontics, and if the patient requires orthognathic surgery, that phase is required. So what is pre-surgical infant orthopedics? What happens is when the baby is born, the mother's estrogen is very high in the nasal septum. Therefore, this tissue is plastic and can be turned into any shape desirable. So what we do is that there are different methods of applying force to do the tissue molding. It could be an active force or a passive force where you are using tapes extraorally or intraorally. So the concept of giving feeding plates has changed totally. There is no need to give a feeding plate to a cleft baby if you know how to give proper feeding instructions. Also, there is a very big debate on the role for pre-surgical infant orthopedics. So what we've done is that, there is an appliance from Canada called DynaClef, where you have a nasal elevator alone. You can just elevate the nose by this taping system, and you don't need an intraoral plate. And you can see a good outcome of nasal deformity as well as the cleft defect reduction, which happens with this taping system. So another issue is that the patient with the traditional appliances have to come every week to the doctor. Now, we compared weekly visits versus one-step technique, which was being followed at Yennupaya Dental College, and we found that the alveolar molding outcomes were similar. So let's look at this premaxilla, which is jutting out, and this premaxilla has been brought back within the first 4 months of birth because of this maternal estrogen. So if you see another case of bilateral cleft, you can see that the premaxilla is deviated to one side. And once you try to, bring it to the center and try to develop the columella tissue. This is possible in the first 4 months. Now, how do you record the facial scans? It's very difficult. The babies are mobile. So what we did was that we published a frame where you can put your mobile phone and it revolves around the baby and you can scan the facial soft tissue of the baby. It's just like the pram of a baby where the baby is looking at the toy on top of the pram and is occupied. So this is how it works. It just revolves around the baby and records the facial scan. This was published in the Cleft Palate Craniofacial Journal during the COVID time. And we found that the scans are much better when you do it using this technique. Now, we also started using aligners for nasoalveolar molding. The first case in the world from our unit was published in 2019. This is that baby, pre, and you can see how this big defect has reduced after sequential use of aligners. So this is an aligner every week, 1, 2, 3, 4. So the next 4 weeks, the subsequent 4 weeks, and subsequently, at the end of treatment, the alveolar arches have come together. And if you see, this is, the defect which has reduced so much courtesy the aligner treatment. So what is the digital workflow we are proposing? You scan the maxilla of the cleft child, you scan the face, the STL file can be used for vector planning. You can segment the cast, do movement 1 millimeter a week for the alveolus, put an elevator which is 3D printed, and remotely monitor these babies till the molding effect is completed. So digital photographs can be taken. Conventional impression is replaced with scanning of babies. Then, you can plan the treatment on a computer screen, which is much more fail-safe. And you can see how, the planning works. And every week, the treatment is programmed. You print a set of casts and directly print aligners, or you can make aligners indirectly on these casts and give to the patient. Once you've given this to the patient, you can give instructions and then use a remote monitoring app and see that the mother is doing the steps properly, and the patient, in 4 months can undergo the nasoalveolar molding. Now, this child grows up and is in the mixed dentition. The role of mixed dentition orthodontics is to prepare the child for an alveolar bone graft. As you can see in this picture, the arch is coordinated and the region is developed so that the surgeon can transplant the patient's own bone. The timing of this is determined by the root formation. When the root of a tooth is 1/3 to half developed, that is the time it erupts into the oral cavity. So we have to plan treatment just before the root develops so that it can erupt into the oral cavity. So again, one of our publications where we use nitinol expanders to expand the maxilla and then grafted these cases. So what is the digital workflow you can follow? The digital workflow involves digital records, which are digital photographs, as we all do. Then the digital, cephalogram and OPG or radiographs and a cone beam CT scan. So, it helps you visualize what is the quantum of volume of bone which needs to be transplanted and which are the positions of the teeth. And an intraoral scan, which can help in planning the treatment for these children. So, here you can see how individual tooth movement can be programmed, and we can, make sure that we get a good outcome for these patients. Now, the next this thing is to manufacture either aligners or a 3D printed device. So we've got a cohort of patients we are using with aligners, and then we have 3D printing, and this is one of my friend Dr. Digant Thakkar from Rajkot who prints these devices depending on the need of the patient, which tooth needs expansion and what is the quantum of movement required. So with on the right side is an aligner system. It's a Japanese system which has an expansion screw inbuilt. So you can see the expander with the expansion screw, which has to be worn only at night and expanded. And we are just about to finish this cohort of patients and publish our outcomes. So, now you want to do the bone graft. So 3D imaging, why do you do a bone graft? The principle is simple. You want a tooth to erupt through it. You want to stabilize the arch, make it into one unit, obliterate the fistulae, and provision of bone support to the alar base, right? So if you see here, this is what the reason for doing the bone graft is, that the alar base on the left side is much lower compared to the alar base on the right side. So once you do that graft, you're able to elevate the nasal septum and you're able to actually get a good outcome in terms of symmetry. Now, have a look at this patient. The root of the erupting canine is 2/3 formed. So, and the arch is well developed. So what we did was we did a bone graft. The reduced enamel epithelium around the crown of this tooth allows the tooth to erupt through the graft. And if you see on the right side, it looks like a complete maxilla because the planning has been done well. Now, the bone is taken from the patient's own bone. This is iliac crest bone, which has been taken in this child. And you can see that it's a full complement of dentation after a successful bone graft because you've evaluated it, you've done the timing correct, and the tooth has erupted through it. Now, this situation is about salvaging the graft. There is a very high incidence of impacted canines in cleft children. It's 1:20. In a non-cleft, if it was one impacted canine, in cleft, it is going to be 20. Now, you can see this child where we grafted, we got the impacted canine down, and this is that maxilla, and it looks like a complete maxilla because the planning has been done well. Another patient where we've expanded the arches, we've tried to, because there was no bone, no soft tissue, there was no buccal vestibule, we had to first do a vestibuloplasty, then do the bone graft, and you can see that there is a complete set of dentation for this child bilaterally with a successful bone graft, though the teeth size are different. So you can see the eyes of this patient and the confidence level after the process is complete. And here you can see a mutilated dentition and then few teeth, different sizes, but in proper alignment. So, post this bone graft surgery, you can do again a remote monitoring on your cell phone itself. And even during the orthognathic planning, you can see the defect size on a CBCT. You can 3D print a scaffold on which the bone graft is placed. Now, here the bone graft has been placed and, in person post-surgical follow-up of the patient. Now, permanent dentation in a patient now who's graduated to the permanent dentation requires planning. And, again, the 3D workflow works here. We have digital photographic records, cephalometric records, and we can also, plan digitally the outcome. So you can see that here every step is planned, how much movement is planned digitally, so that we know what is going to be the final outcome and what teeth are to be replaced finally when we finish our treatment. So also, you can print your expanders. You can use this digital workflow with planning and then remote monitor your patients instead of calling them every time. Also, orthognathic surgery. Some of these patients, about 30% of them require orthognathic surgery. Orthognathic surgery in cleft children is different from non-cleft because in non-cleft children, the upper incisors are proclined and the lower incisors are retroclined. However, in cleft, both the upper and the lower incisors are retroclined because of this scar tissue of the upper lip. So you can see a patient of orthognathic, which has been, brought forward beautifully with orthognathic surgery. And another patient where distraction osteogenesis, the red frame has been used to protract this maxilla forward. Another patient where a segment of bone on the left maxillary segment has been osteotomized and brought forward to create a complete maxilla. Now, have a look at the eyes of this patient and the smile, confidence, and the vertical correction which has been done, and the correction in the arch. Now, we've also used distractors. This is a segmental distraction which has happened. We've cut one segment and distracted it to the other side to make a complete maxillary arch. Now, what is the digital workflow for orthognathic surgery? Again, digital records. digital Ceph OPG, a cone beam CT scan, a 3D software which is used to plan and diagnose treatment, creating a simulation. Surgical splints are 3D printed, and you are actually doing the surgery and 3D printing these splints, and then remote post-surgical follow-up, and then planning. Implants also, the first implant in the world, the lecture before me was on implants, was done by Professor, was Dr. Brenemark accidentally found that titanium could be used as implant material, but it was Professor Jan Lilia, with whom I worked for many years. He had his house wall to wall with Professor Brenemark, and they had a swimming pool in the basement, which was common. So I visited them in 21 years ago, where he told me the story that the first implant in the world was put in a cleft child, and I have photographs of that cleft child who had that implant in his mouth for 46 years. Now we do implants not on the cleft side. We like to move the tooth onto the cleft side grafted bone and place the implant in the region which is native bone, so that there is no chance of failure. So you can have a look at this patient. The canine, the lateral incisor is missing. We have moved the canine mesally and put the implant. This is a Nobel Biocare implant which I put, and a crown on top. So digital workflow can also be used for oral rehab, having good records, proper planning software. So, I want to just say that, there is no harm in hoping as long as you prepare for the worst in cleft patients. And being different simply means that you have something unique to offer to the world. So, digital is never going to take away the way how we treat patients, the basics of it, but it is going to be an addendum in offering good quality, efficient, and effective care to our patients. Thank you very much for a patient hearing. And if there are any questions, I'd like to happily answer them.
Thanks, Dr. Puneet, for joining us, giving your precious time, whether you are in the transit, actually, you are in Goa and you have to catch the flight, but still you have given your precious time to our attendees. Anybody who want to ask the question, such a senior academician researcher is with us, so you can ask the question right away. If you have any question, you can type on a chat actually, and then you can ask question.
Yeah, if you don't have any questions, you can just email me. I am very happy to, answer any question.
I'll pass on if there is any question. I'll pass on to you, and I'll give you the detail who is asking the question, so you can reply on the email.
Thank you so much for
Thanks,
this.
Dr. Puneet, for joining. Yeah.
You.
Thanks for joining us. So with your permission, should we move on to the
Yeah,
next
yeah,
speaker,
please,
because Dr.
please,
Sejin
please.
is
Thank you.
waiting for long in a hotel room actually. Dr. Sejin is in a hotel, and he's also in his travel actually. So Dr. Sejin, thanks that you still, though you are in traveling, but you are able to manage to join us. So before I move on to, give your formal introduction, uh, can you unmute yourself just to see? Hello.
1 second.
Yes. I'm just giving you a brief introduction, and then you can start your presentation. So Dr. Sejin Chandra is an eminent oral and maxillofacial surgeon and oral implantologist with over 26 years of experience serving both national and international clientele. He is managing director at chief surgeon at Kamla Dental Specialty Hospital at NABH accredited hospital, and he is internationally acclaimed center located in the heart of Trivandrum. Under his leadership, the hospital staffed by a multidisciplinary team. He has become a hub of advanced digital dental care, attracting patients from around the globe. Dr. Chandra is widely recognized for his expertise in trauma care, orthodontic surgery, and dental implant based full mouth rehabilitation. He holds fellowship and diplomat. He holds from certification in implantology from International Congress of Oral Implantologists, as well as fellowship and mastership from the Indian Society of Oral Implantologists. In 2024, he earned a PhD in oral implantology and a dissertation on accuracy level of digital protocols in immediate placement of implant in extraction sockets. A pioneer in integrating digital workflows for implantology, he is a sought-after key opinion leader for various dental implant manufacturers. His effort is in digitalizing maxillofacial surgery, oral implantology, and CAD/CAM-based prosthetic workflow are recognized worldwide. And he is considered as an early adapter and pioneer in digital dentistry across India. He is one of the global ambassadors of Digital Dentistry Society, the DDS, and one of the founder of member of Association of Digital Dentistry in India, ADDA. Committed to his excellence in clinical practice and patient care, Dr. Chandran also serves as a senior consultant at SP Medifort, PRS, and GG hospitals. His contribution to dentistry have been recognized with several prestigious awards, including the Dr. APJ Abdul Kalam Lifetime Achievement Award, the FAMDent Special Dentist of the Year in Oral Implantology 2019, and a FAMDent Superstar Award in 2025. He remains dedicated to make cutting-edge technology in dental care accessible and affordable to all. With this brief introduction, I would like to invite Dr. Sejin to start his presentation, and his talk today is on digital transition in oral implantology. Over to you, Dr. Sejin.
Thank you so much.
If I missed anything, you can add on in your introduction.
No, it is a quite elaborative description what you have given about me, the introduction. I hope my screen is visible for all.
Yes, it's a visible.
Okay, now let me play it. Yeah. Thank you, Iddcon and Dr. Anwar for inviting me for this lecture. And I'm so sorry I got delayed because I was in another conference, Indian Association of Oral Implantology, happening in Chennai, and I had to rush back to hotel and catch up with you people. Thank you so much. And let me move on to my topic for the day is the digital implant workflow and its deviation from analog to digital. What so far I traveled in this field. Like anyone, I started my implantology way back in 2000, and when I recorded the cases in 2003 and 2004, you can see very well how novice our work was and how it turned out our workflow much acceptable to the global community now. Like everyone, we used to think, like I could have done this better. When we sit and analyze that where it went wrong, like it is because of a bad planning. So now starting from analog to freehand, the digital workflow from freehand, the amazing results what we get and the parallelism we get in implants, and that makes very easy for the digital, the prosthodontics to do the digital workflow is better. So now let me show you how I plan and how I execute my cases in this small presentation. Analogs, we used to take the help of the cast and we used to find the long axis of the proposed prosthetics, and we used to plan our implants. In digital, it is all made easy by the templates of the future prosthesis, by the models of crowns, of the multiple crowns, and then we check for the long axis and the available bone in the CBCT. Gone are the days we work with two-dimensional radiographs and assessment. And because it can give sudden, sometimes it can give some unexpected anatomical variations, and sometimes we miss to find the available bone in terms when you look at two-dimensional picture. Imagine you're assessing a posterior mandibular scenario with a regular RVG or a panoramic radiograph. You will sometimes see that we have almost 11 millimeters of bone, but actually it is only 7 because the lingual plate is restricting for the drilling. And see, when you wanted to be short about your implant placement in all 3 dimensions, in terms of depth, the buccolingual directions, or in the mesiodistal variations, how can you get a bullseye shots with this implant placements is only by the digital protocols and guided surgeries. Guided, though it is having a lot of laborious process to create a surgical gate and work on. But the advantages what it gives is like phenomenal, like it can show you the results, like when you place the implants in the long axis, when you have the correct crown root ratio, when you place the implants in the right depth, and when the implant is properly placed in the bone in such a way that it is surrounded by bone all around, and the emergence profile is created, then the bone loss what you see in so many years is very, very minimal. This is the same patient received a treatment from me around 7 years back with a regular platform matching implant and a regular workflow. And this is something what I deliver nowadays with zero bone loss or otherwise very minimal bone loss and a crustal bone remaining in the stable position for long. Now, let me tell you what it delivers. When the implant is kept almost 4 to 5 millimeters from the free gingival margin or the proposed gingiva of the prosthesis, then minimum 3 millimeters of soft tissue if it is available, then you get something called as zero bone loss. This is a concept derived by Dr. Thomas Lingavicius and team from Lithuania. I was fortunate to be with him and to do some studies along with his thought process. And it gave rise to a concept of zero bone loss concept, where you use a polished zirconia or a titanium subbase, and it remains in the soft bone for a considerable amount of minimum 6 weeks time, and it develops an emergence profile that is as natural to a natural tooth, and it will give a stable bone around the implant, and the guided surgeries will help you to plan your implants in such a way that not only in the posteriors, even in the anterior region, when you wanted to decide the trajectory of an implant, it will help you to place the implant in the right trajectory that you are planning to get the palatal emergence of the this one screw hole in a screw retained restoration along with the aesthetic biologic contour. When you talk about all these things, what we are doing nowadays clinically is only 10%, 20% of the job, and the 80% of the job is already done by the planning and your team members. And you just refine the planning and go for the gate fabrication. It is instant. Nowadays, in our practice, we make it in 1 day time. In-house CBCT, in-house 3D printing, in-house scanners. That has made the workflow in such a faster way. Morning, a patient comes in, they receive the implant by the afternoon, and we temporize and send them. Reducing the chairside time, increase the productivity, return of your investment, all these things are assured. Because so many patients who are visiting us are travelers, because we are in a tourist destination near to Kovalam and in Trivandrum. We get clients from across the globe. And not only that, nowadays they started coming only for the dental treatment and combining with Ayurveda and yoga, our traditional health sciences, and they club it with the dental tourism. And now, whatever investment we have made, I can tell you by direct and indirect, it made a huge return and benefits. And now, let me tell you, why not everyone is not going for these digital protocols? Because many are really scared about the higher investment what they are making and the maintenance of all these equipments and higher learning curve. Of course, you have to learn it through the toughest way to make it your routine in your dental practice. Can I balance between this digital and analog workflow? Yes, of course. It's all the difficulty is only till you master a software and you plan your implant placements yourself, and you have total control of these digital protocols that is happening. My first experience with the digital protocol was in 2009 when we started doing these cases with Nobel Biocare. And that time we used to send our patient for CT, and the planning used to be done by a third person. And we used to scan the dentures and with the fiducials. And then we used to take the patient for the surgery with the gate that was given to us. This was the planning and this was the outcome. And we used to wait for 55, 60 days for this surgical gate to reach from Nobel's Sweden center. And even with the limited knowledge what we did, it is still working fine. That time we thought it is an escapism from planning it ourselves, and anything that is guided, it works fine. But if you see in the radiograph, you can see that some of the screws are off and some of the angulations are off, but still we believe we could do a good job at that point of time. Now, this is the article that time we published in 2009, along with one of my colleagues, that the different accuracy levels of that guided implant protocol, we did it for the first time. And now in my practice, which is almost a 26-year-old practice, and where we have now these many doctors, around 15 doctors, among that 9 of them are specialty people, and we together, we decide a multidisciplinary treatment plan for our patients, combining perio, prosto, and the surgical protocols, and we maintain high standards of implant care in our city. And now coming to all the digital gadgets and the acquisition of the facial scan, the acquisition of the intraoral scan, and then taking the hard bones, this on detailing through the CBCT, clubbing everything together and creating a virtual patient on my computer, and then deciding where to place the implant. And it is 1:1, and the accuracy levels are so high, and the 3D printed gates, and then going ahead. And now we are doing even the prosthetics in 1 day time by doing CEREC milling. And that is how we made the time saved and giving the implant and prosthetics in a very short period of time. People who are coming to us for 1 day or 2 days in Trivandrum, they receive the implant and temporization. They go back next time when they come. We are mostly taking hardly 1 or 2 days to deliver their prosthesis. So getting used to all these new terms like DICOM, STL, OBG, and PLY, all this digital language is becoming very common, and that is becoming our language for the dentist in these years' time. So now it depends upon your interest. You can outsource at any point. Like you can even take the CVCT from an outside center. You can have your planning done by another person, gate fabricated by another person, and even the companies are nowadays coming and taking the scanning in your clinics. So it is not only for the richest and elite people in dentistry, or it is not just meant for the highest paying capacity people in your society. Now it is becoming for everyone. Like with the outsourced scenario, your investment is less. But with the help of the in-house scenario, you can make it much faster. Nowadays, we are using so many softwares like 3Shape, ExoCAD, Up2Gate for different purposes. Now, this is a study that is we published in 2023, the evolution of a digital planning software that is about Up2Gate and how it helps us in doing routine dental procedures like implantology. Now, me being a KOL of a implant system, and we followed some principles, and along with the colleagues from across the globe, we could find that the protocols what we are doing and the type of the technology that you are using is at par with any other European standards. Now, let us look at some of the cases. And this is a regular workflow in our place where we have taken the STL, where we have taken a DICOM image in the CBCT machine. We are clubbing these two and we are making it a merged files. And then in that, we are doing a digital waxer. So so many steps are taken away and it is all completing in 3 minutes time. And then we do implant planning, giving all safety aspects to sinus floor and inferior nerve. And then comes a digital gate fabrication using Up2Gate system. So in this software, we make a spoonless and a sleeveless guided workflow, and it is so fast in execution, and it is 3D printed in-house and sterilized and taken for the surgery. So the drill system is made in such a way that it is having a it is in a sequential format of the diameters and length. And once you follow the correct sequencing, you get a flawless implant placement as desired and as planned in CBCT. So what is the meaning of doing a regular planning and advanced planning and executing freehand? You make human errors. So when you do this guided system, you get to see beautiful prosthetics axially loaded and equally spaced, and it is safe from the adjacent tooth and even from the anatomical structures. So once I started working in this flow, we started understanding the merit of these systems and we started propagating it. the guided implants and what we have done in our clinical practice, along with the big names in digital dentistry society, we could publish so many articles. One of this is done along with Fabrizio Longo, Hermite Lerner, and Sam Amar, and me together. We published an 1-year follow-up study of around 650 guided surgical cases. Even in Straumann, we have BLX system, and that we started using recently. And we started doing that with the 3Shape software. And you can very well see how the workflow, how simple the workflow is. And we can create surgical gates, and we can print it in-house and see the beauty of the planning. You can evaluate in all dimensions, from buccolingual, from the lingual side, even from top to the top-wise view, or even inverted view. And so you wanted to check it in all 3 or 4 dimensions, it is possible. And it gives the right drill and sleeve and the sequencing in such a way that you needn't worry about anything else. It's all planned. It is a blind procedure later. You're drilling it, the bone is drilled, and it is expanded with the implant placement. See the beauty of the implants, and it's spacing from one another, and the beauty of the prosthetic system, that it is made so easy and predictable. So coming to all these cases that I can show you, like it is an anterior case where Straumann BLX implants are given in an ideal implant positioning, and you see the type of workflow what you are carrying out, and the patient goes back with the temporization in a 1-day time. And once the temporization is done and the later converted to the permanent crowns, these are the results. And this is for multiple posterior teeth. We have done it with the R2 gate system. I'm just rushing through because I'm given with a less timing, and you can see how gated system works day-to-day practice. Like every second or third implant what you are placing, it is with the gated protocols. So the time taken is not so long. See, it is from morning till evening, your gate is ready. And when you do it like that, and when you wanted to temporize and send the patient at some time, given with all the biological formula that we used, these are the results. Like nowadays, implants success rate and the success formula is changed. It is not just the survival of the implant and holding the tooth in position. It should look same like your natural dentition. That is how it should be. And coming to the follow-up of many cases that what we have done, it is a 10-year follow-up of a anterior implant case where the patient had to extract 2 anteriors because of external resorption and history of RC treatment. And then now see the result, what he is getting: equally spaced implants, vertical height is established, and the prosthesis is made accordingly. And he is, both the patient and the doctor, both are happy for the outcome. So this is, of course, having a learning curve. You have to have an analog implantology thorough in your mind and in your hands, so that this is a given added advantage to give you a consistency in your work and to have total control of what you are doing and what your expectations are. Now, see in this, the results, what the patient is enjoying. He is an IAS officer now. After 10 years, he got his civil service exams cleared, and now he is working as an assistant collector in nearby district in our state. And imagine doing a full mouth rehabilitation with the gated protocols. You can establish a vertical height, you can establish an arch form, you can have all the teeth alignment, and you can decide where all you want the access holes. Accordingly, you can decide the implant positions, and one in the molar region, one in the canine region, and tilted implants. See the workflow happening. It's not difficult. Once the gate is stable, once the planning is correct, see, you get to see your implants placed well, angulated well in the safest anatomical position, giving you a prosthesis much easy outcome. The prosthetics is also nowadays digitalized, and this is on full arch, full mouth, full arch, segmental cases. All these things are like a toy game when you establish your digital protocols in-house. The articulation, the articulator, the plaster models, the wax bites made ready, all these things are obsolete now. You have a total control of your implant placement through the anatomic positions that you established in digital way. And once the digital planning is over, the gates are fabricated and it is stabilized using anchor pins. And even in edgeless conditions, you get extremely neat outcome without damaging any of the vital structures. So I can show you a number of cases where we have done the regular cases, zygomatic implants, cord zygomas, and even see the zygomatic procedure is nowadays an in-chair protocol because we know at what angulation we have to give and raising a small flap under local anesthesia and then retracting and seeing the anterior wall of maxilla and taking your drill and going to the zygoma proper and anchoring it. See, the game is very simple now. So let it be two zygomas and two anterior implants or cord zygomas like this. And see the number of cases that we have done with the digital protocols, either in-house 3D printed, resin 3D printed models, or otherwise 3D printed titanium gates that we fabricated, and see the outcome. There is no room for error. Implants are equally placed, equally spaced, and it is well anchored to the native bone, and there is no chance of it failing. And the failure is expected and all the possible failure chances are taken care, and then these are the results. In extraction sockets, it is amazing. We never thought we can do this very, very predictable bullseye shot placement in the palatal side of an extraction socket or in the bifurcation or trifurcation. And that led to an accuracy level check in immediate placement of implants. That was the topic for my PhD work also. Like this got published in Journal of Dentistry. And I will tell you the 6 years of work, what I have done in the extraction socket management that gave me a confidence to place any implants in any socket. And in a given scenario, like we started comparing the accuracies and we got to know that the guided surgical protocols are offering that great results and the accuracy levels that it can be considered even for very critical conditions like where you have to be 0.1 millimeter accurate in bifurcation and trifurcation. Guided surgery, there are risks like it's based on the aforementioned accuracy. There is a consensus that which we always made that it should be 2 millimeter away from any anatomical structure, and you have to have a control over the procedure. And you should be careful when you select your patients. The patient is not having adequate mouth opening to hold the gate in place or to use your extended drill systems, then you are in trouble. You can create a gate, but you cannot use it in the patient's mouth. So minimizing the area of this gate or otherwise minimizing the height of the gate, but at the same time with better resins, you're having stronger gate system with the stabilizing anchoring systems and correcting the check of the accuracies, then you can go ahead. No, guided with the sleeve or without sleeve, it is still another debating topic. To avoid fracture, sometimes we splint them together and we give supporting bars to stabilize it. And yeah, this is the revolution of the digital system. Like companies have come out with guided drills for their systems and the digital protocols. Nowadays, we are using even Navident. That is, the accuracy levels can be achieved by this on dynamic navigation. That means we needn't create any gate, but at the same time, you can place the implants with a pre-guided, pre-decided trajectory with the help of a map, this on sensor and tracker, and that is giving us more accuracy levels without the tedious workflow of creating a surgical guide and working. And one more thing is any modification that we need, it is possible through navigation. So the accuracy levels are so high that we started using it even for the static gates and navigation is our part of any maxillofacial surgeries that I do nowadays. Like you can see this, the accuracy levels of a guided system allows us to work in this vertical maxillary excess case and with guided surgery for the mandible, that is a BSSO. I could complete this procedure when I used to take 3 hours and 4 hours for a byjaw surgery. This I could complete in 1 hour's time. Though it was one among the first few cases that we are done with the guided protocols, it gave extremely good results and the cutting gates were prepared. And that when we cut through a gate and when these dimensions are proper and when the angulations are proper, then the results are amazing. Like it is like just fitting like two pre-cut the fragments of bone and then placed it one over each other and splinting them, or otherwise giving a plate and screw and fixing it. The rigid fixation is achieved. See the result what we got. There is actually for the gate fabrication, we removed his brackets. And once we got done with his orthognathic surgery, and me and my team, we were really surprised and we were very happy that his occlusion is like a class 1 occlusion without any lateral deviation, or it is with a maximum intercuspation, and patient didn't allow us to do any refinement as a post-orthognathic surgery orthodontics. That is, post-surgical orthodontics was not accepted by the patient, and he was very happy with this outcome. So it is the digital half of me working all the time, given with any opportunity that is coming in my dentistry or surgery. This is how I take this forward. And I am very happy to share my workflows and my thought process with a group of friends online. I thank the organizers and Dr. Anwar for this invitation. Thank you. Thank you so much.
Thanks, Dr. Sejin, for connecting all the way from Chennai for us and sharing your very, amazing, digital dentistry has totally changed the, dentistry which we practices actually. Yeah, I'm a 2003 graduate, and when I left the college at that time, the very conventional methods are being used for implants and all. But now, after 20 years, I changed leap and bound actually, and everywhere so accurate, so minimally invasive. The procedures are available, so that we have getting a very great outcome and all. So with this, I'm just requesting audience if they want to ask any question. We have very great implantologist and oral surgeon, having international repute with us. So it's our privilege. If you want to ask any question, you can ask. Otherwise, you can connect with her. I think he would be love to share his contact details. So any problem you are facing, if you want to learn anything, you can connect Dr. Sejin, and Sejin would mentor you, guide you for that. So any question you can put on a chat box. Otherwise, we'll move on to the next speaker.
Thank you.
Thanks, Dr. Sejin, for sparing your time and all. Yes.
It's an
We
honor.
will come again for you when we are organizing any other program. Such a
Please.
experienced oral surgeon and working in orthognathic surgery, implantology, and also.
Sure, anytime.
First time we privileged that we got you. Fortunately, yeah.
Thank you.
Thanks. Thanks. No, so our next, with your permission, we are moving to the next speaker, Dr. Sejin. Dr. Abdul Hamid Attar is our next speaker. Dr. Hamid, Dr. Abdul Hamid, are you there?
Hi.
Yeah.
Can you, am I audible?
Yeah, you are audible. And we have made
Can
you.
I share my screen?
You can share your screen. Meanwhile, I'll just introduce you formally.
Is it clear?
Yeah, it's visible, but not in slideshow. Yeah, no, it's in a slideshow mode.
1 second.
Just wait. I'm just.
Let me minimize this. Yeah. Let me know when to start, please.
Yes, yeah. Let me introduce you, and then you can start it.
Sure.
Yeah. So we are privileged that we have Dr. Abdul Hamid Attar with us. He is a distinguished oral and maxillofacial surgeon, having 1.5 decades of experience consulting across Mumbai, Pune, Bangalore, Dubai. He is a key opinion leader and accredited trainer for Bone Easy India, specialized in customized craniofacial reconstruction and digital dental rehabilitation using advanced 3D printing and CAD technology. He has received multiple accolades, including being thrice awarded as the best maxillofacial surgeon and is known for his contribution to innovation and training in the field. Dr. Hamid has numerous national and international publications and recently coined the term anagital representing the fusion of analog and digital workflow in surgery. He also introduced a risk scoring criteria for dental implants for guide sustainable implant planning. He holds 2 patents with a third in the pipeline. Great. And continues to drive technological innovation in dental and maxillofacial surgery. So this is the brief introduction. I am just passing to Dr. Abdul Hamid to his screen is visible. So Dr. Hamid, you can start your presentation.
Yeah, good afternoon, everybody. Am I clear and audible?
You are audible, you are visible. Your slides are
Yeah,
also visible.
thank you, Dr. Anwar, for this opportunity, and thank you, the entire organizing team, for this invitation. I'm really happy and privileged to be here, a part of this among super stalwarts of various specialities. So let me begin with my presentation. I would like to moving. Just give me 1 minute. It's not moving. Is it changing my slide?
No, it's a stand still. It's a stuck actually. It's not changing.
1 second. I don't know what's wrong. Yeah. Is it fine?
Yeah, it's visible now.
So my today's topic is all about the implant hopes, where we don't feel that anything is possible in these areas. So let me begin with the short story of an Pygmalion, is a gifted sculptor from the Greek mythology. So he had a very, what do you say, that a very talented hand, or he is a very talented person, where he used to sculpt the various type of sculptures. And it was something. One day he made a sculpture of a woman, and it was so realistic that he used to always pray to the god that once if he gets a life to this sculpture, he will marry and he will keep that as a lifetime. So similarly, what we strive in our day-to-day practice, that we should have achieved something for our patient, and that is a glacier, what is he has achieved in his life. So with this, I would like to start my presentation. And here there is a great quote by Dr. Brenner: "No one should die with their teeth sitting in a glass of water." And I also believe that same. That means no one should have a removable dentures. They should have a permanent teeth in their mouth. And whether there is a bone or not, that is what I believe. And one should get the teeth. So that's with this, I would like to start. Today, I would like to take you to the journey where I am going to. 1 second, it's my screen. Yeah. So innovative frontiers of rehabilitation, where the bone or the jaws are severely resorbed. So atrophic jaw, this is one of the most challenging situation. I'm not going to talk about the conventional where the sufficient amount of bone is available and you want to place implants. Everybody can do that. But there are certain situations where you don't have bone or it is severely resolved. In that situation, what you can do? So to provide stable bone or endoosseous bone, we need a good quantity of bone. But patient doesn't understand whether they have bone or not. What they want is the procedure should be comfortable and it should finish up in a very short span of time. But what they are expecting more is the aesthetic and functional outcome of whatever procedure as a clinician we are providing to them. They don't understand what you are going to do inside the bone, but they are going to see the final outcome, what they are getting it. So let's look at the classification of the edentulous jaw. Everybody knows this is the class 1 dentate with a good amount of teeth as well as the bone. Immediate after extraction, we have a class 2. As the days progress without any intervention, there is a high chances that the bone gets resorbed in a different pattern, both in maxilla and mandible, and finally will end up into the severely resorbed, that is class 5 and class 6 type of a bone. That is where the challenge starts. So if you look at the maxilla, these are the zones we have a bone. Usually at the severely resorbed ridges, we get bone in the anterior zone, that is of zone number 1. But what about zone number 2 and 3? In that situation, we have a different approaches we'll see. So what we can do if you get a severely resorbed ridge in maxilla, you can graft or you do a osteogenesis, that is destruction osteogenesis, or you tilt the implant or use a short implants for the dental rehabilitation, or you can go for a remote anchorage, or you can go a pterygoid implant or nasal floor engagement. All those things can be done, but still we need some amount of bone to be available there for the anchoring the implants. What about in mandible? You can do bone grafting, vertical destruction, learn lateralization. If you want to use whatever the amount of bone is available, then you can tilt the implant, that is all on 4, all on 6 short wide implants can be used. And finally, cortical engagement by nerve bypassing or all other things can be done. But is it possible every time? No, it's not possible. So look at these options. That is, one is grafting and second is a graftless. I can classify into two broad ways. So if you wanted to graft, then the options inlay onlay graft, GBR, allular splitting, and with the bone grafting, distraction osteogenesis, maxillary sinus. But all these things have their own complications. It is complicated, time taking. You need lot of skills, high chances of failure. We have to invest a lot of money on bone graft, and of course you cannot do or achieve everything in a short span of time, and you have to wait for 6 to 8 months for the final thesis. If you wanted to do any graftless procedure for these kind of a patients, you have to go for different approaches. That is, if you have a sufficient bone in the zone 1, you can go ahead and do all on 4 in the anterior zone. If you don't have a bone in the anterior, you have to go for all on 4, all on 6 by tilting the implant. Furthermore, you can go transsinus, pterygoids, or zygomatic bones, or all those things you have to do. If you look at the mandible, there is a maximum high chances that you will have a bone in the anterior zone in a severely resorbed. If you have a bone, then you can go for all on 4, all on 6 short implants, or tilt the implants in the anterior zone, and you can finish the case. But there are certain stages where you will not able to get a good amount of bone to anchor even implants. So these are the few options: tilting the implant in zygomas, pterygoids, anterior nasal anchorage, or tilting the bone in the end, or sinus lift, etc. For mandible, you can do all on 4 by tilting this kind of an implants, but it's not always possible in extremely clinical situations. For these kind of a cases, if you see this case of a maxilla severely resorbed, either maybe because of the long span edentulous period, or there may be resection or some sort of a pathological situation where this kind of a situation we find. If you see this case, there's hardly few millimeter of bone in the anterior, but rest of the alveolus is gone. If you look at this mandible, hardly any bone. But if you see this way, it is having a high amount of bone. But if you see in all three dimensional, there is hardly any bone and there is a curvature. So it's making difficult for us to put implants in the mandible. So what can be done for this kind of a situation? This is the same case of the maxilla. If you see in the cross section, hardly any amount of bone is available for placing the implants. These are certain films. You can see hardly any bone there in the posterior or in the both right and left. If you see the lateral OPG format of this CBCT scan, hardly any bone is there in the maxilla. So what options we have? You can go for zygoma, microvascular surgeries, take a fibula graft from the leg, put it into the maxilla, wait for 6 to 8 months, then you do implants or simultaneous implant, or else you go for patient-specific implants. All these are possible. But yes, this is huge surgical intervention is needed. A donor site surgery is there. There is a high chances that you may not be able to get a good aesthetic things. Here, you need to have at least a zygoma. Sometimes I will show you the situations where even the zygoma is very thinned out to place zygomatic implants. In that situation, what you can do? This is a case of mucormycosis. Hardly any maxillary bone was there, but still, if you see on the left side, there's hardly any zygomatic bone in both the sides. We tried to put, but achieved nicely. That is also one kind of an option what we can do for the severely or resected these things. So this kind of post-op the outcomes we can achieve after the zygomatic in post-Mucor cases. But is it possible that we can do all those cases with zygomatic implant? When I compare with patient-specific implant, the zygomatic implants are technique sensitive and incorrect positioning are high chances. You need a lot of skill to place it. Yes, of course, Dr. Sagan has already informed and discussed a lot about the guided implantology. Even with the help of guide, we can do zygomatic implants. But the situations where you have no reference points to place the guides, how we can put a guide in that situation? So that is the biggest challenge if you go for a digital placement of zygomatic implants. If you have a good amount of alveolus or no, at least for a reference point or a fixation pins for the guides, then of course you can do it. If you don't have anything to fix the guides, how we can do that? So that is one big challenge in the guided implants. So comparing that, I feel PSI will be more less invasive than compared to the zygomatic implants. Then comes to microvascular surgery. Yes, of course, it is. This is the case where we have a severely resorbed maxilla as well as mandible. Here in this situation, I have opted for a maxillary fibulary graft because I don't wanted to go for a two fibulas either for maxilla and mandible. So I opted a fibula with soft tissue graft in the maxillary areas, and whereas I opted PSI for the mandible. So outcomes are precisely good. This fibula with endosseous implant. Simultaneously, while doing fibula, we placed 4 implants in the fibula and we obtained the nice outcomes. This is the post-op healing. If you see, there's a large soft tissue requirement was there. That's why the fibula graft has been decided to go for in maxilla. And this is how the process is has it done, and this is how the outcome is achieved. The lower jaw is a PSI, that is a patient-specific implant opted for this patient. When I compare, microvascular is complex procedure, multiple surgeries may be required, patient comorbidities may not permit additional procedures in the donor site areas, challenges of failure, non-union of the graft that we have taken from the leg is high. If we lose that, then you are in a negative. That means you have lost one more bone graft opportunity. So that's the reason why I believe PSI can suffice this kind of problems when it comes to the complex cases. So CAD-CAM technology or technological support for rehabilitating these cases will be more comfortable than coming to the complex surgical cases. So precision, efficiency, and outcome with the PSI are always possible. Let us look at the workflow, how we can do it. The first and foremost thing is the data acquisition. That means we have to obtain bone segmentation from the DICOM data of a CBCT. I personally prefer to go for a CT scan data rather than a CBCT because we need a large FOV, that is a field of vision, and with good voxel size, that is 0.75 slicing. That is very much important. Then once we get the DICOM data, we have to segment that. What is the meaning of segmentation? DICOM data is just a two-dimensional voxels things, which we have to align it properly and so get a segmentation of a area of interest. I'll show you how the segmentation data seen as once it has been segmented. Then comes the designing. Once the design is done for the PSI, it has to be approved by the operating surgeon. Usually what happens, the clinicians, they just send the data to the companies for a designing of a PSI, and the company designs it and send it back to the surgeon, and the surgeon tries to put it inside the patient mouth or patient's body. But unfortunate thing, they don't understand how to now what amount of bone has to be reduced or how amount of the bone is there. And the most important thing in PSI is the soft tissue envelope or coverage after the fixation of this PSIs. So that is important. So those data, along with the data, you have to give them all those details, what kind of a soft tissue we have, what kind of a soft tissue, whether this tissue is radiated or non-radiated in case of cancers, whether there is a large soft tissue defect If there is a large soft tissue defect in the patient, then you have to think for a microvascular soft tissue closure with PSIs. So those most important points are there. This is the DICOM file which has been taken into the software. Maybe 3D slicers or many more segmenting tools are there. Using that, you can convert that DICOM data into a STL format. That is the conversion of STL DICOM data to STL. That is, STL is a workable format for the designing. So once it is taken, we have to take it to the designing software where we design this kind of an implant. If you see on the left side video, right side video, you'll see there's the light blue color, the implants we are designing on the surface of the bone available. So this is the partial maxilla in the anterior. If you see, there is a hardly a few millimeters of bone, that too very close to nasal floor, plus very thinned out. If we wanted to do graft and all those things, it will take a lot of time, and we need a lot of skill to regenerate this kind of a defect. So in this case, a prosthetic driven designing has been done for teeth. The future processes has been planned before. Then according to that, we can design the implant as per the requirement, and we can check all the screws what we are going to use to fix this PSIs in a cross section, where it is going in a sinus or nose or any other important anatomical structures, and you can change accordingly. This is how the implants are designed in a various cross section. Both in maxilla and mandible also can be done, or partial mandible the same way it can be done, segmented, taken into the software. The teeth are planned as per the final processes. Then according to the final processes virtually planned, the multi-unit base has been created, and with this multi-unit we can create a implant to fix the multi-unit this abutments with the help of a short plates. These are, if you see, these are the yellow, they act as a holding plates or the retentive plates, and blue color stuff, they all are the abutments. Either it is a multi-unit abutment or an internal connection abutments, or sometimes you can use a cemented abutments, which is already attached to this yellow kind of yellow plates for a fixation. So this is how the implants are designed. Even you can check in a cross section the screws, where the screws will go. The position can be changed if it is damaging the nerves. So that is the beauty of the PSIs. You can manipulate everything as per your requirement. This is a case of severe maxilla and mandible. The mandible again has been designed, both mandible. And as I told, the surgery, the patient always looks at the end result. They don't want what you are going to do on the bone or inside the oral cavity. So the prosthetic is always planned pre-hand. So this is how the face scans are done, the pre-operative digital wax-ups, plus the digital face board transfer and the digital JR or VR, whatever the needed for the final process is taken. And this entire digital format is transferred to the planning software, and where it can be merged with the final processes as well as with the PSI. With these two important data merging to each other, we can get a final design. So if we can see, this is the teeth arranged, and depending upon the teeth arranged or a wax up, we can take from the digital designing and transfer it to this planning software, and we can plan this the final processes. Depending upon the final processes, we can design our abutments and their angulation within the PSIs. So this is the very complex case where the patient has underwent multiple automatic surgeries, and finally, if you see, there is a fixation plate, the entire maxilla has resolved. In that situation, we got this patient for a final processes for dental rehabilitation. So this is how this complex, even the complex cases can be designed with the help of a planning software and can be executed with the PSIs. Now there is a certain protocols while designing we follow. For mandible, we follows the Chamfy's line of osseointegration, because these are the trajectories where the maximum force is transmitted when the implants are being fixed into the dissolved mandible. So this is how, if you see, this is the area of maximum stress. We can use that. In the posterior, it is a ramus, or in the anterior ridge, oblique ridge, which can be used for the fixation. So this is how this implant, as per the Chamfy's line of osseointegration, we design the PSI for the mandible. Similarly, for maxilla, the maximum force-bearing areas or force transmission areas are the buttresses, anterior, middle, and posterior. Depending upon these three buttresses, we plan our final pier size. This is the anterior buttress, the plate goes here, and this is the posterior buttress or the middle buttress. These buttresses are more useful in transmitting the force once it is applied to the pier side. So that is how it has been designed for a force distribution. If you see, there are the components for the PSI is the fixation plate. We have a multi-unit base, then the fixation screws and zygoma screws. I will split this into small segments. This is the fixation screw at the zygoma that takes a maximum force when it has been applied to the PSI. These are small screws in the anterior butters. If you look at this, we have a multi-unit base on which multi-units can be attached. So I believe multi-unit should be separated from the PSI. It should be two-stage, one, the abutment, then the multi-unit, then comes the processes, as we do it in a conventional endosseous implant. Endosseous implant, we have a fixation, then comes the multi-unit, then comes the final prosthetic screws or cylinders. Similarly, it should be retrievable. Something goes wrong at this level of abutment, if it is incorporated with the the base implant, then you have to remove the entire implant. So we have a guide for abutment to be inserted slightly within the bone. So we need to create that crater into the bone. This is how, once it has been fixed, this is the multi-unit abutment which can be fixed at this base, which is retrievable. So that is how the prosthetic is always retrieval from PSI. That is most important thing in PSI. If this is attached or incorporated within this PSI, if something goes wrong at this level, we have to remove this entire implant, which is again a big challenge. So looking at that, we have created the separate multi-unit abutment for PSIs. This is the zygomatic screw for the fixation and maximum load bearing transmitted to this from the implant to the bone. And this is how the mandible PSIs has been planned. Previously, we used to make a single unit right and left, but now we have started splitting right and left alone separated. The left one is separate and the right one is separate. So this is again a fixation plate adapted according to the Chamfy's line of osseointegration, two connecting plates, and finally there is an abutment on which the multi-unit screws has been used to fix. If you see closely, there is a crater created into the bone, whatever the amount of bone is available, so that soft tissue coverage and the abutment goes inside the soft tissue will not have any issues. If this crater is not been created and the plate goes at this level, there's a high chances this plate get exposed to the oral cavity, and this is a chance that we have a failure or exposure of a metal part of this implant. If you see, we have already created a denture beforehand because we have all the data right from JR to interval scans, everything. So we can prefabricated the denture. Once it has been fixed, we can directly fix on to the multi-units in the intraoperatively. This is how the implants are supplied. This is the box, the rail box, the fixation screws are there. These are the implants. We can use it for the case. This is the emergency screws. This is the regular screws we have for your cases. This is how we remove it. This is the implants there for the maxilla. These are the fixation screws. Let us look at some of the case scenarios. Case one, of course, this is severely resolved maxilla. Though it looks we have a lot of bone there, but if you see clinically, once the flap is raised, there is hardly any bone here. Directly, we are reaching to the base of the maxilla. This is the hardly 1 mm. There is a maxillary sinus. So this is after the exposure, butters to butters, similar like a zygomatic. But instead of in zygoma, we have to create osteotomy for a zygomatic implant. But here we don't have to do anything. We just have to do some modification in the alveolar part of the maxilla where the implant is going to be seated. If you see, there's two craters. This is how the implants are checked before we go inside the oral cavity. This is how the implants are placed, and just putting few screws, we are done. There is no much of what you say the procedures in between from the exposure of the tissue to the fixation of the implant. No, we have to just create some osteotomy, that too with the help of the guide provided by the designing company. We can just create that this implant goes and passively sit. Once it is sit, we have to just put a screws inside the bone. This is how the right side and left side. This is, if you see, this is the zygomatic screws which goes and deep seated inside the zygomatic bone. This is how the zygomatic screws are supplied by the company. All are these screws, whatever is being provided by the company, are the site specific and the depth specific. So you don't have to worry. They have been designated numbers. We have to use it accordingly. So this is how the zygomatic screws are placed without any much of problem. You have to just drill one slot inside the bone and you can just put this screw, it will get inside. So this is a small video of how the procedure is. The incision from buttress to buttress, the flap is raised. This is how the guide is put for the osteotomy, for the abutment to be seated inside the bone. Once it is seated, check for the proper positioning. This is how now the implants are positioned passively. If you see, just glide the implant, it is fixed, and the screws are self-drilling, or sometimes if it's not self-drilling, one small ditch in the cortical plate and you can just put the screws directly onto the bone. So this is how simple it is. You can just hold, this is self-drilling screws going inside the anterior buttress. This is the palatal screws. You have to just put it with the help of piezo dispenser. No much of problem. Once it has been there, we prefabricated dentures can be fixed immediately after the surgery without any waste of time. This is the final occlusion. This is the post-op healing after a few months. This is the immediate post-op scanning to check the screws. If you see, all the screws are within the bone and the implants are adapted very precisely the amount of bone available there. So this is how the PSIs are done and fixed inside the jaw. This is immediate post-op. If you see the nicely multi-unit abutments with a good AP spread, what we all always try to achieve, it is pre-planned. We don't have to worry about that. This is the immediate dentures, what we can just, after the surgery can be regularly how we do it for all on 4, all on 6. Similarly, we can put up, fix it with the cylinders. This is the final processes. We can do it after 6 months. This is still the temporization. The old denture only has been transferred to the patient for immediate temporization. After few months, this is immediate post-op. After few months, we can call the patient back again. This is how the final processes has been designed and delivered to the patient after few months. That is around 5 to 6 months. We wait to settle down the entire soft tissue. Then we call the patient. This is how the patient looks after the surgery, after 6 months. So this is how the post-op. I was talking about the zygomatic screw. If you see, there's the 2 zygomatic screws on the left side, one on the right side with multiple small screws on the zygoma, anterior butter screws. And this is a multi-unit. If you see, there is precisely fitting the PFM processes in the PSI. Let's see about the second case, that is a post-maxillary osteotomy. Here, there is a complete maxilla has been removed with remaining only the zygoma. Still, if you see, we can think of placing this zygomatic implant in this situation. But very unfortunately, in Mucor, we have a cortical bones, plates, but inside, if you see, there is hardly any bone inside the zygoma. This is how the incision is given. The full thickness flap is raised. If you see, there is the entire bone is hollowed up to the zygomatic body. So this is how the implants are placed. If you look at this situation, this is right and left, precisely fixed. This is the immediate prosthesis, fabricated, checked into the on the cast, and immediately after the surgery, this is how the patient, and it is done, everything it's done within 48 hours. So that is the beauty of PSI. That is patient came to us with this, and she left after the surgery. It was done under GA. After the surgery, 48 hours. This is how the patient has discharged from the center. So this is the post-op X-ray. If you see here, it will be appreciate that there is hardly any zygomatic bone there for putting zygomatic implants. This very thin zygoma left for anchoring this zygomatic screws for the PSI. If in this case, if we go for a zygomatic implants, there will be entire zygoma implant. Is hardly few millimeters of zygomatic implants will be there in the bone. Rest all will be hanging freely into the soft tissue or into the areas where it will have a long cantilever effect. Even if you go for a bilateral splinting of the zygoma implants. After maybe few months or so, there will be high chances that it will start loosening from this area because it will not have a good stability in the zygomatic implants because of the flexure. There's one more case of ectodermal dysplasia. This is the patient came to us with this kind of an bone, hardly any bone. You know that this is the same STL what I have shown you before. If you look at his bone, there's only 2 teeth present. Rest all the maxilla is not developed only. So in this situation, if I wanted to go for a zygomatic implant, you can see there's hardly any amount of zygoma is there to give one. And I will not be happy to place one zygomatic implant in this direction and do the prosthesis. It's not possible. If I have to hang it the implant like this, then it will be whole implant will be in a cantilever impact. There is no support for the zygomatic implant except in zygoma. So this is not possible to do with the zygomatic implants. So in this situation, what we have done, we have planned a PSI. This is how after the exposure, the entire maxilla is there. There is no maxilla in the hardly few a few millimeter of anterior maxilla is available with 2 teeth in the anterior zone. We have some small modification in the anterior zone for abutment sitting. This is the max implant. If you see the inner part of the implant is treated one, is SLA treated, whereas the outer part of the implant for tissue compatibility, we always keep it a mirror polished or what can say highly polished surface. So this is how the implant has been designed. Right and left placement. If you see these 2 side implants, right and left, precisely sitting with the multi-units and the gingival formers in place. We took a buccal fat graft to cover this implant because the tissue was very thin because of the underdevelopment of maxilla. So this is the post-op healing after a few days of surgery. And this is the immediate temporization, the denture created for immediate temporization. This is what we have achieved immediately after the surgery. This is the pre-op. This is the post-op of the patient within few days after the surgery. This is how the mandible we managed to do all on 4 for this case, but maxilla we did a PSI. Similarly, this is the post-op X-ray and the CT scan of a patient to check the precise fitting of the implant there. And yes, of course. Even there is a situation where we have to remove the entire maxilla or mandible. This is the case where we have removed the entire mandible post ameloblastoma, where we want the patient was young. He don't wanted to go for an fibula. We don't wanted to put him under stress because he was a coach for a football team. So he wanted something out of the box. No, we wanted to think. So we did a customized implant for the mandibular reconstruction, but at the same time, we put a provision of a same multi-unit base there at the anterior and the posterior area so that we can give him the teeth once he's settled. This is the immediate post-op after few months, like around 3 months. This is how we have given a polomolo kind of an prosthesis for this patient. We are followed up for this maybe more than almost now 5.5 years. This is we are following up. If you see where there was no bone, even in that situation, we did a PSI and we got a good result. This is the post-op CT scan of the patient. So this is how the regular prosthesis, what we do for all on 4, do an interval scan with the scanners, just send it to the lab. They will create a bar or any kind of a manual or a digital. I am a very big fan of Energital. I have coined this term recently, where I believe the entire digital workflow for the prosthetic at least will not be suffix the outcome, because whatever we are doing it digitally, it is in a static workflow. But once you put it into the patient mouth, it becomes a dynamic. So we have to check before we deliver the patient for final prosthesis. It should be done under both analog as well as the digital format. So whatever you are doing, the digital things, it should be taken into the mouth for a dynamic examination of the dentures in all the exclusion or whatever movement you are expecting. So this is how we do it. We do all the entire procedure digitally, but at the end we go Energital or analog pattern, just put it in the patient mouth. We check all those possible problems in a denture or a final prosthesis, and we manually correct that. Then we fix finally for the patient, final prosthesis to the patient. This is how the implants have been, and the final prosthesis are checked and corrected and done. Finally, this is the term Energital, which has recently I have published in an article. So where I believe it should be a combination of analog as well as a digital, where it comes to the final prosthesis. Of course, at the end, I would like to compare my possible procedures, what we can do, grafting, tilting, implants, zygomatic. When I say PSI, patient-specific implant, the bone requirement, we don't, even if there is no bone, we can do the reconstruction, entire maxilla or mandible, both. Surgical time, short. When I compare it with the PSI or a zygomatic implant, you have to just raise, put the implant. Yes, of course, we have to be very careful when it comes to the soft tissue closure for the PSIs. It should be very precisely closed. If you don't have a good amount of soft tissue, you have to borrow from the local or a distant flaps. Morbidity, minimal. Aesthetic or functional, excellent. Cost, yes, of course, when I compare, it is almost same to the other Smith. So I started with the story of a Pygmalion. For him, it was a Galatia was the outcome, and for us, it is a smile of a patient, which is a Galatia for us. This is how the patient came to us without or hardly any bone in the both arches. We did a PSI for this, and this is what the outcome which satisfies as a clinician when it comes to the outcome. So yes, of course, there are certain complications, material fracture. Yes, of course, the DMLS PSIs are always no for full mouth rehabs or any kind of a PSIs. So DMLS material, if you are using it, the companies are giving you a DMLS PSI should not use. I strongly recommend EBM, that is the electronic beam melting technology. If you are using for PSIs, it's good. Peri-implantitis, if you don't close the implants properly with the soft tissue, yes, of course. Implant exposure, then again, this one important factor, it should be always considered beforehand, by before designing the implant. Infections, yes, of course, it's a part and parcel of all the surgeries. Even here, it can be, you can face it. Lack of osseointegration, yes, similarly to that of the endosseous implant, if it's not handled properly or if it is not prepared in a clean room procedures, then of course it can have a problem of a or lack of osseointegration. Now, usually people ask me whether these PSIs gets osseointegrated. Yes, they osseointegrate with the native bone. The entire plate can get osseointegrated. Finally, I would like to conclude with the discussion that PSI can be excellent rescue option when it comes to be severely resolved. The main advantage resides in offering an alternative, more invasive surgical procedures like fibula or any other zygoma implant. It is less invasive and yes, of course, immediate prosthesis, which nowadays a bigger challenge. The patient comes and they ask for an immediate loading. They don't want to wait for a month or no, like that. With PSI, yes, of course, we can do immediate loading. That is possible. So I suggest that you should not read only my success stories or anybody's success stories before. Don't conclude yourself before you try and see the cases by your hand. So thank you for patient listening. This is my team of people who help me, because PSI is not a one person's games. You have to have a team for CAD CAM designing, for designing to fabrication. We need a prosthetist, we need a surgeons. A lot of people needed in the background for these kind of cases. So I would like to thanks to my entire team for supporting me and helping me throughout these cases. With this, I would like to end my session. Thank you very much, Dr. Anwar.
Thanks, Dr. Abdul Hamid, for sharing your insights about PSI. And I just seen that, even in a highly atrophic, when the bones without maxilla or the mandible, you are able to, rehabilitate that patient, and the patient can get their teeth back actually. So it's a very amazing technology, and slowly and gradually, it's like magic is happening, that people are, when the conventional method have a no scope actually, but here we have a lot of scope. Even we have a very resolved zygomatic bone or maxilla, or even in case of ameloblastoma, you have removed the whole mandible, but still you able to rehabilitate. So great, the PSI and all. And but it is a bit, I think, more costlier than the the other implants. Yeah.
No, nowadays the cost has been reduced to a major. Like before we started, I started in 2000, maybe around like 10, 11. But I'm working on this technology since 2008. But comparing to that time and today, it is almost half nowadays.
Yes. Okay. But you are
But
having
I would request the entire the people who are listening to me, this should be the last resort for any of your cases. It should not be the first resort for your cases. You should sit and think. You need to observe the case properly before you go for an PSI. Usually what happens nowadays, the people who listens to my talk, they will call me, oh doctor, there is one case for PSI. I say you should not decide that. This should be the last resort for any of your cases. If you can manage to do with endosseous or by tilting or anything, you should go at first that, then you can think of any other options.
Okay. Any question from anybody who want to ask question? Dr. Abdul Hamid. Otherwise, we have our designated speaker, Dr. Abhay Lamba, who joined from Faridabad. So he is waiting for a long. So anybody who want to ask question, you can ask question on the chat box, or if you having any issue related to such cases, so you can we can let you connect to Dr. Abdul Hamid, and you can email
I'm
him.
writing my email ID on a chat box. If
Yeah,
anybody
please do.
wants to
Yeah,
ask
that
me,
would be
you
better.
can just please
Sure, sir. They can
mail
share
me
the
on this.
photographs. They can share the the radiographs, etc. to connect with how to the outcome and all. Yes, Dr. Hamid HMD77@gmail.com. Okay. So with this permission, Dr. Abdul Hamid, we are lagging say 40 minutes.
Please,
So we have to cover up,
please,
and
please,
we are
please.
rushing to our next speaker. So our next
Thank you very much, Dr. Anwar.
Yeah.
And Dr. Abhay sir, all the best for your presentation.
So we are moving to our next speaker, Dr. Abhay Lamba. He completed his graduation from prestigious Manipal College of Dental Sciences in 1994, and he is a postgraduate certificate in oral implantology from Manipal College of Dental Science, Manipal in 2001, and he is MSc in Master of Oral Implantology from Goethe University, Germany in 2016. He is a member of Indian Dental Association, Indian Society of Oral Implantology, Academy of Osseointegration, Academy of General Dentistry. He is also a member of SOLA, Society of Oral Laser Application, and he is a fellow of the International Congress of Oral Implantology. So if you have missed anything, Dr. Abhay, it's a very brief introduction. You can add on about yourself so that our audience will understand well, and you can share your slide and you can start your presentation. Sorry, we are a bit late actually. Your scheduled time is 3 o'clock, but it's 3:45. So please bear with us because one or two speaker get technical glitches and they have the interruptions, and also that's why we get delayed. Over to you, Dr. Lamba.
Thank you, Dr. Narul, for a brief introduction. I hope my voice is clear. Can you listen to me?
Yeah, you quite clear. Clear, sir.
Yes, sir. Very okay. Okay, so thank Dr. Narul for inviting me to share my experiences on beautiful online platform, Iddcon. This really appreciate that you have started that, and you invited me to share my experience there. So my topic for presentation is full mouth rehabilitation with implants and immediate function. So before I start, I would like to share a quote from my spiritual guru. Knowledge can only be got in one way, the way of experience. There is no other way to know. And this is how I learned, and I feel by doing things, it makes things happen. So before I start some clinical cases regarding that, I would like to share a bit of theoretical part or a physiological part of immediate function of full mouth rehabilitation with implants are the factors influencing early loading. So if you look at, there's two major parts to it. One is the implant part, and the other one is the physiological part. So if you look at implants, we are looking at the first one is a primary stability, as everybody knows about it. I would prefer to have a bicortical support for my implants to load them immediately, and this ensures that my implant's going to stay in the mouth. Then the most important part is the pro-angiogenic surface. The surface which helps in developing the new capillary or new vascularization around implants. And these surfaces, it's because of hydrophilicity of the implant surface or peptide surface of the surface, or pro-inflammatory cell missings there. A lot of factors are there nowadays, and surface treatment helps in achieving that. And topography of the implant is how rough it is and how much heat it generates while we place the implant. That also helps in creating an immunomodulation around the implant, or give rise to physiological factors of the implant bed and the bone around the implant. And it's how it helps in creating more pro-angiogenic surface there. It increase the, or how a body decrease the rejection of implant. So it also depends upon the surface charge, whether the surface is charged or no, there's oxide layer or no. That all those factors are very important to know that. Also, we type of titanium being used there. Nowadays, a lot of implant systems comes with zirconia, because as study states that zirconia is more pro-angiogenic surface as compared to titanium. So these factors just play a part into a faster osseointegration of the implant. Also, the bone type of at interface, bone volume. Sometimes it looks very easy that in a very narrow space I place the implant. But if you do not have a nice, sufficient vascularized bone mass around your implant, it's not gonna you create a new bone or osseointegration or strong osseointegration, because there's a lack of vascularization and the supply of cells required there. So bone volume is very important. Vascularity of the site is also very important. The condition of the periosteum. So you respect. My first lesson, what I learned during my implant course was, you respect, you get respect. So you have to give respect to the periosteum, the flaps and everything. That if you really damage it, it's going to cause more inflammation and can lead to a bone resorption also. So yes, we look into the studies. If I look into different studies, we are actually become very predictable for immediate all-on-4 and or full mouth rehabilitation with implants, also along with natural teeth. There's a different protocols to that, and I'm going to talk about it. But off lately in history, it is becoming very predictable. Earlier, we never used to do in maxilla, but mandible, we used to do it. And earlier, we used to do all full arch rehabilitation, like all on 4, all on 6. Nowadays, we do segmental also. And a posterior segment also, we do immediate loading and functional loading. I'll talk about few cases with my cases. So if you look at the immediate protocols, we are looking at primary stability. We prefer to have apically tapered implant to engage into our jaw cortex. Fully tapered implants are also, which is a bit more aggressive to grab more bone or to give us more primary stability. Then we are looking at hydrophilicity of the implant surface topography, which is talking about pro-androgenic surface. And then if I go into planning phase, because I feel proper prosthetic planning prevents prosthetic problems later on. So it's a purely a prosthetic, as Dr. Abdul Hamid was also talking about prosthetic science, and it is said without prosthetic designing or planning, we cannot actually ascertain what kind of implant placement we are going to do. And prosthetic is the foremost criteria here to plan any implant rehabilitation cases. So when we do a prosthetic planning, we have to look at what type of platform we're going to use, a multi-unit abutment or a cemented or a screw retained, how much gingival, what type of biotype the patient has it. So according to that, we need to have type of abutment we choose in here. And then how deep we want to place your implant. That also is also a criteria here, because sometimes we are doing immediate implantation and we expect some bone resorption or remodeling around at the crest or at the ridge level. So if we are placing implant which is looking good with a multi-unit abutment and nicely sitting on the middle of the ridge, but after the healing and bone resorption or remodeling modeling of the crest, it becomes more buccally oriented, looks out of the arch. So if we place our implant little submerged, then we can use a shorter collar height, and we can bring the implant more deeper or more into the center of the ridge. So these factors does play a important part in planning. I'm going to share these with my clinical cases. And the temporization components also important here, which system has all the temporary components available there, which is not very expensive on the pocket of patient, but still rigid enough to or strong enough to stay there for the transient period. And the lab components, whether you have a digital format there or you want to do with the analog one. I prefer digital one because it cuts short steps. Also, it's fast to do that. So I'm going to talk about more of a digital workflows and the hybrid ones. So already since morning, there's a lot of where we are talking about the digital workflows. I'm not going deeper into it. But then I would say digital printing is an important part. So selecting a good digital printer for your office is important here. And I'll talk about intraoral scanning during the surgical phases. Now, during planning, you should always have a biometric component there. As I was just mentioning, that sometimes a rich buccal resorption happens, especially in maxilla. I normally use a late resorbing bone graft material to safeguard my buccal bone profile. So for the anterior, also label profile. Soft shield is one of the important technique coming in market or in clinical technique is there. You can use that. Some people who are not proficient in this technique, we can use materials. Now, I was talking about studies in terms as the studies literature long term. If you look at it, as you can see, 0 to 5 years is roughly 100%. And as we go on to 3 to 4 years, this is nearly 100%. And if you look at the longitudinal studies, which is 5 to 10 years, it's also nearly 100%, like 98%. These factors in a long term plays a lot of factors like smoking, accident, or other medical condition also plays a effect in the long term stability of implants. So in long term, 98% is justifiable. So if I start with the case, this gentleman is a long-term diabetic case and is being stabilized with insulin, is a type 1 type. And otherwise, oral hygiene was fine, but then the patient came to me in 2002 with some maxillas and payments. And all these were shaky and severe bronchitis was as we did a flap surgery. And then we stabilized the gums. And then after that, we did the full mouth extraction and we did the implant placement. But when the patient came back later, did implants, but not immediately. And the loans patient now having a problem losing some teeth, as you can see here. He has already lost one premolar, just a bit shaky. So this time we realized to change them implants or rehabilitate them with implants. So we did a digital plan first. So we were planning to retain the canines, and then we want to place 4 implants in a posterior region, in a first premolar and molar region. So we 4 sites there for implant placement. One was already extracted, so other 3 sites were selected. So here in the system, we just give them a site that where we want to place an implant, and then we go ahead with the prosthetic planning. So here on interval scan, we create a gingival margin here just to tell the system that there's a to care. So we do a prosthetic planning. We create 4 sites where we want to plate, and where there was it there, we remove digitally and we mark it again. And then we did a digital planning here. So the system gives us a proposal, T proposal here. So we have to prosthetically plan the teeth there, how wide it will be and how occlusal table we want to keep it, what will be the interarch height of the teeth, what space, leave space we're going to leave it. After all that, we select the teeth. And this proposal, as you can see here, and then we go ahead and we do a implant planning. We superimpose that prosthetic implant on SCBCT, and then we plan our implants. We purposely create a 5-degree variation between two implants, anterior and posterior implant, in both X and Y axis. That is bucco-to-lingual and mesial to distal. So we, because most of the multi-unit abutment can take the variation of more than 30 degree. So I just want to keep a 5 degree. That's good enough to create a segmental, I would say, loading protocol, where we counterbalance the forces anteriorly, posteriorly, intrusion, extrusion, and lateral forces in all three planes. So after selecting the systems, the size of the implant, and we go ahead with the surgical guide. Why I still use surgical guide after 3 decades in implant practice, it actually gives us more precision, also across the control on our prosthetic design. So here, after we plan, we keep this planning report on the chair side, just to be sure whether we are doing in a sequence, just for my team to be aware of it. So once we design a surgical guide, normally these surgical guides, we keep these windows open just to see how stable my guide is over the remaining teeth there. So this is a tooth-supported guide I made there. I didn't expect the teeth which were lying in between because I wanted my guide to be separated there. So I shifted to my system and select my fabrication of guide, how thick I want, which window I want. Like in posteriors, I want to keep a slot on buccal sides. And for maxilla, I do it on the palatal side, so I can slide my drills into the side. So at 10 mm variation, I can create there. My patient need not to open my so big so that when you settle, if there's a slot, I about 10 mm of at least open there. After designing the combination of slide, normally we do 3D printing nowadays. In older time, we used to make, so this was melt or available material there, PML material, which is available, but which is also sterilized. So this technique was sleeve and sleeve, so where we select a master sleeve, and in that we select different sleeves as per the printing protocol. So we start with a palatal and then go to the final fill. So the holes are made as per the final hole, and then we keep on shaping the sleeve inside. We call it sleeve and sleeve concept. So these implants were placed. As you can see, my implants are not parallel. I get a little variation there. 5 elimination is good enough to counterbalance each other anteriorly, posteriorly, and buccally. So after I place the implant, they look quite parallel, but they have a variation. So these implants have different variation and angulation. And also from the top, you can see one implant is more liberally, and one is more regulated. So just to create a variation on that. So once we do, this case is quite old, so I've done a digital analog impression for this case, but nowadays we have digital impressions there. So we create a physiological bioelectrical framework, which is more resilient and can stay for more than 1 year as patient was traveling or not planning to come back for 1 year. So we did plan a process and scan it, and we create a design, a proposal which we made it earlier. And here, once the design is ready, we tell the system to split it, a veneer part and the framework part. The framework was made in a bioexpective framework that is a peak with zirconia and fused zirconia, and over that we make the veneer part in PMMA. And outside, we join them together. So once it's ready, out. So it's more of a digital framework. As you can see, we peak frameworks, and also the system was cutting a part of human, and then we joined them together. So as you can see here, my system has actually we have my parts and part framework part. So once this is decided, we will machine to fabricate, and once we restore it on the patient's file. So this is really, it's also they have to be more natural look, I think. So the patient was recalled from the waiting room. Patient waited for about an hour, and then we cemented it. And it was very smooth. It's actually no later. So this is restored the function. So after the surgery, as you can see here, the implants being submerged, and then this later on the patient came. We gave the patient a fabricated one, a PHPP framework because patient was diabetic, so we wanted to bone train the bone around the implants. We wanted to bone the implant in a progressive way. We call it progressive bone make the implant much more. So this was a pharmacist made with a biological or physiological meal and some composites. I think slide is kind of stuck. The process was made. And there was was in the room, so we have taken it again. And the process was given. Okay, as you can see, we haven't lost any bone, but as around the implants, abutments, there was some modification of remodeling. Crest bone was there. Later on, the patient came back and wanted to replace the front teeth also. So we extracted and replaced 2 more implants in front, and we scanned it. We gave the patient a temporary in the beginning, and later on we restored it with a full arch rehabilitation. The upper was done in 2002 in same submerged protocol. So this was titanium processes made and given to the patient. I'm so sorry, the system is running a bit slow. The slides are going a bit slow. Maybe they are a bit heavier. Okay. So the final process is given later on after a year. And once all teeth were, the peri-implant bone was quite dense and stable, gums were stable, we gave in the final process. So this is another case where we have done a case in 2007, some implants in the lower jaw and some endodontic treatment for the upper teeth, and then some crowns there. It was stable, and the patient had a little issue of smoking and food hygiene. It was not maintaining well. He was a teeth bite case with a posterior height or a bite collapse case where we need to do a full mouth rehabilitation case. So as you can see here, there was hardly any posterior teeth, and some crowns were damaged and highly attrition in the anterior teeth also. So we placed some implants to raise the bite, and we have given some crowns to the patient. So the bite was raised to a level, and the patient was happy with it. So we sent the patient back home. And then later on, the patient came to us in 2013. After post 5 years, everything was looking fine, bone stable, everything was comfortable with the patient. But though he was complaining of some pain in the front teeth, and we checked X-ray, everything looks fine to us. In 2015, it was fine, but when the patient came here, we felt there was a space between two anterior teeth, 1 and 2-1, and that was suggestive of some fracture of roots. So we took an X-ray and we decided to check. So it was all fractured. The front 4 teeth were fractured as well as the canine was fractured. So we decided to remove those teeth and to place 4 implants and rehabilitate once again the full mouth, and we place the implants in variable position there, and then we use multi-unit to make them parallel there to balance or counterbalance the forces there. A lot of doctors ask me, why didn't you use a cemented restoration or a straight abutment, why multi-unit abutment and interiors? Like by submerging these implants, because this particular system has a locking multi-unit abutment for bridge work. So crown bridge work is also can be done with these multi-unit abutments. We call them mini abutments. So we did a temporary layer, and we created nice little contour. Some temporary purposely we create a space, interdental space here, for gingiva to walk in. Reason being is that when you submerge your implant and you create a bone between or interface area, so it makes the gums move more down for maxilla, more up for the mandible. So gingiva normally follows the bone. And when you create more bone, you use a bed switch or conical abutment type of implants here. So you submerge the implant so the bone can grow around your conical abutment and pushes the gingiva more up. So here the bone grows. This is called zero bone loss concept, and we have been using it from the last 10, 20 years. And we are having a good success here. And here we don't have to, every year the bone grows over implants. So it's like a bone growing concept. And here the tissue start working in between. So you this area in a ceramic processes, we remove the glaze part and we just polish it for hemidrosolum attachment so they can walk in. So from here to here, and then we later on changed the temporary to permanent, and we changed the vertical icons again to black and white. As you can see here, we have papilla coming in here, and a stable papilla, and we gave a final prosthesis. Now these processes, as you can see here, the papilla start keep on filling in the space, and over the year from 2015, they remain stable. So 2018, 2020, 21, principle and a long-term stability. And the bone keeps on growing. So from here to here to here. So it's like creating a nice perioral environment for the gums and peribone to stable to remain stable around our implants. So prosthetic planning is must have. So from 2018, 2000. This case is a senior citizen case with some basic need and other topic on that. So okay, this gentleman was 82 years old and his wish was to have fixed teeth. When we look inside, there was a lot of bone loss here. As you can see here, there was a big dip here. So he has lost bone here between the left mandible area. We have lost a bone. Sorry, I think there's some mental issue.
Thanks, Dr. Abhay, for joining us. There might be some connectivity and internet issue actually in a midway. So your slides are moving slightly, but it's okay. It's a connectivity issue. Anybody want to ask any question with Dr. Abhay? We are privileged that Dr. Abhay with us. So you can ask question with Dr. Abhay. Otherwise, Dr. Abhay, you can post your email ID on the chat so that if they want to ask any question, they can email to you.
Yeah, last week, there is some PowerPoint issue here. That's connected to your right. It's actually raining outside, so let's see what's happening.
Yes. Okay.
So maybe the next speed is slow down. I can share this presentation with you and can share with the participants.
Sure. You can share the presentation and we can share to all our subscribers who have. Yes. So with the permission, you, Dr. Abhay, should we move to the next speaker?
Thank you.
Yes. Okay. Thanks. Thanks, Dr. So our next speaker is Dr. Neeraj Rohida. Dr. Neeraj, are you there?
Hello.
Yes, Dr. Neeraj.
Yes.
So
I hope I am audible.
Yeah, you are audible, and let me introduce you, and then we can start your presentation.
Sure.
So, say confirm your speaking language. English. So, Dr. Neeraj S. Rohida is an associate professor in orthodontics and clinical researcher. He has, to his credit, research article published in American Journal of Orthodontics and World Journal of Orthodontics, and is a mentor to PhD student at IIT Bombay. Since completing his master's in orthodontics from esteemed Government Dental College, Mumbai in 2009, Dr. Neeraj has been into exclusive orthodontic practice at Mumbai, India. He is a developer, owner of DTS PRO Pro, DTS 3D and other upcoming software under the DTS umbrella. DTS is recognized as one of the top 5 software in the world. So with this brief introduction, Dr. Neeraj, if you want to add anything, if I missed something and it's relevant, you can add so that our audience would understand you well, and then you can start your presentation. Over to you, Dr. Neeraj.
Yes, thank you for the introduction. I will just share my screen.
Yes, it's visible. Your screen is visible. Keep it in slide share mode.
Yes, I think I hope it is visible now. Right?
Yeah, it's a perfect.
Yeah, thank you for the introduction, and let me give you an overview of this session where I'll be talking through a brief about the importance of simulations and the 2D to 3D workflow in digital smile designing. So let me start by, I need to, yeah. So I'm an orthodontist. I practice in Mumbai in a place called Powai. So a little snapshot about my practice there. Uh, right. I always believe in the one of the more powerful concepts which sort of happen in the consulting area is getting the patient say yes to treatment, and the focus is primarily on the patient motivational or the simulation part. So we always, as dental business owners, need to always take care of the ethical business aspect of dentistry, right? So that involves the ethical business marketing or the dental marketing. We are always supposed to sort of hone our clinical skills. So we have taken care of the marketing where the patient is there in the waiting area. We are supposed to be good in our clinical skills any which ways. So then what remains in between is getting the patient say yes to treatment. This is where the patient motivational part, the patient acceptance part is a very critical part in most dental treatment procedures, right? Now, typically, envision a scenario where a patient walks into the dental office wanting to get the diastema closed, right? Typically, what is our workflow is the moment we look at this patient, there will be multiple treatment options which come into our own minds. And then we start explaining them to the patients, right? So the moment you look at a patient like this, probably a third of you would say, oh, I would do braces for this patient and close the diastema orthodontically. Another third would say I would probably do direct chair side composites. And probably another third of the audience would say, oh, I would like to do a more definitive restoration in the form of porcelain veneers, right? Now, for the patient to envision and understand these treatment protocols, it is like dental jargon. They do not really relate to the different kinds of effects these treatment protocols would have on their smile. And what are the different ways that we use to convey these different treatment protocols to patient? We either show them before after pictures that are treated by us in our offices. We use certain similes, or of course we show them physical models. One of the more predictable ways of showcasing patients' prospective post-op results are doing direct or indirect wax-ups or mock-ups. The only disadvantage of this method is you can, of course, do this in patients who are motivated, who want to undergo treatment. But you cannot do this for every patient who walks into the dental office because you do not have the time, money, effort, and resources to do the same. And eventually the patient would say, oh, doc, I don't need this. Why are you putting something into my mouth, right? I don't want to see. I don't need to undergo any changes to my smile. So that gets us to the point which says that a picture is worth then probably more than 1,000 words when it comes to case acceptance in dentistry. This is the concept of emotional dentistry. So if you are able to showcase something to the patients on their own smile, on their own picture, it makes a world of a difference as far as patient motivation and decision making as well as treatment acceptance is concerned. So very important term, emotional dentistry. There's of course a lot of science behind it. And if we are able to showcase patients something like this on their own smile, not using other patient before after pictures, not using physical models, this gives them a world of confidence because it shows them a roadmap. It shows them a blueprint of how the treatment is going to sort of change the position of teeth. And not only that, if we are able to showcase different treatment option simulations. So for example, I'm able to showcase a bonding simulation versus an orthodontic simulation using a single image. That is where your decision making comes into play. So that is the role of digital software, simulation softwares. And that is how we ended up developing a software by the name of DTS Pro. The idea was to have a simple user-friendly interface where we are able to do quick simulations for the patient to sort of understand and motivate right in the first visit. So we want to showcase patients something when they have come in the chief complaint, after the chief complaint is taken care of, right? So I will show you a few cases that document the workflow of 2D to 3D. Now this patient walked into the dental office wanting to get the wisdom tooth extracted. After the wisdom tooth was extracted, I of course saw that there is possibility of doing a cosmetic enhancement for this patient. All we did was take a single picture, show the patient a visual simulation. So on the top is the one which is a simulation. And of course, it runs in the form of a video loop before after. So the patient understands, they get an idea, they build value, they perceive value into what can change in their smile. And the top is a simulation. The bottom right, of course, the patient opted for doing ceramic veneers. And that is how we ended up the case. The idea here is not to show you the treatment planning. The idea is to how to bring value into treatment, because for this patient, he's absolutely okay with the way his teeth look because he doesn't understand or he's not able to perceive the value of what a cosmetic enhancement do, not only to his smile, but to his overall personality, right? Another case on the top left is a picture. As you can see, there is a little gingival zenith mismatch. The central incisors, gingival levels lower than the lateral incisors. Now, cases like these would involve reduction or subtractive for dentistry. There is no other way other than digital means to showcase patients how the post-op results would really look like, right? So we are able to do a very quick simulation on the top. Patient, of course, I've done a little exaggerated simulation there so that the patient could really understand and decipher what I was trying to say. The patient said yes to treatment, and bottom, all we did was we did a little bit of gum contouring there and some bonding. That's about it. But again, showcasing the patient, communicating with the patient with visual tools which they can relate to and understand. Simulations are not limited only to aesthetic treatments, to whitening or to veneers. Now, this is a patient who I used to see, have been seeing probably for the last 8 years. Now, each time I look at this patient and I used to tell her to do something about her smile, right? And she's like, Doc, I am okay at this age. Who's going to look at me? How does it really matter? The typical, the feedback which all of us keep getting from our patients. And one fine day, of course, I did a simulation for the patient. And the moment I did a simulation is where the patient actually got excited and asked, Doc, is there something which can be done for my patient, for my case? And of course, I said, yes, we can do something like this. And of course, we did full mouth implants for the patient. I'm not here to talk about the treatment protocol as we discussed in the beginning, but the workflow, the idea of how visual tools and visual communication and digital workflows can help bring a lot of value to our treatment. And of course, we did full mouth implants and immediate loading protocol for this patient. But the idea of a simple picture, which really couldn't, and I couldn't sort of motivate the patient to do treatment probably for the last 6 or 7 years by me coaxing her into treatment, what a simple simulation like this could actually help her envision and get ready for that treatment. So simulations have a role to play in across all specialties in dentistry, be it orthodontics, be it of course cosmetic dentistry, smile designing, digital smile designs, or even full mouth restorations, be it implants, be it dentures. We use these simulations and digital plans and workflows to sort of add value to a lot of treatment that we carry out. So that's the power of simple visual simulations. Orthodontics, my specialty is, of course, again, one more field where we use simulations quite a lot because many times, even though the patients are aware about treatment, uh, because they do not understand the value which aligned teeth or a straight smile would bring, Sometimes they would quote that, I'm too old for braces and I can't undergo 1 year of treatment. So these visual tools help us perceive them, what could significantly change with their smile after they undergo treatment, right? So that's digital simulations for you. And of course, we don't stop only at uh, the pictures. We sometimes use frontal views or profile views to even demonstrate profile changes. So extraction versus non-extraction, and sometimes even orthodontic myofunctional appliance or even orthognathic proposed changes. Now, are these the most ideal way to showcase treatment or the most scientific way of showcasing profile changes after treatment? No. Lateral cephalometric prediction tracing analysis are one of the best ways to showcase treatment. But the point here only lies is patients cannot really again understand to black and white X-ray images as much as they can understand on their own visual photographs. That is, again, I reiterate the point, the power of visual communication tools with the patients. Right. So I'll just take you through a little bit of workflow of how do we do a 2D and then convert that same thing into a 3D. So we start by always taking a photograph, doing a simulation. That's with the DTS Pro. That's a 2D software. And of course, then we use the DTS 3D software to design and to then actually 3D print the mockups. So what is the difference between an analog and a digital smile design workflow? So I have picked up two cases here to showcase the workflow. So patient who wanted to improve the aesthetics of a smile, we always start with a full face smiling photo to carry out the simulation like that. That's the simulation again, which we have done using the DTS Pro 2D software. The patient liked what she saw and wanted to further go ahead with treatment. We, of course, also did the treatment simulation on a retracted image as well. Once the simulation was done, the new proposed shapes and position of teeth, we use certain tools in the DTS software itself, which are basically the digital smile designing protocol tools to plan the treatment and communicate this with the dental lab. So this is also called as a 2D smile framework. We send this to the lab and then the lab does a manual wax up. So as we can see, this is a physical model, a physical impression which has been shared by the lab, which we have shared with the lab, that is, and the lab does a manual wax up. Because a physical impression has been used here, a manual wax up has been done here by the lab technician. This is also called as the analog method of digital smile design, right? So then the lab sent us this mock-up back, and then we transferred it in the patient's mouth using a putty guide or a ProTemp guided index. And that completes our clinical test drive. So first was a digital simulation. Second is a clinical test drive where we actually transfer the 3D printed mock-up smile to the patient's mouth. So that's approval number 2. The patient liked what she saw. We use that same mock-up to carry out certain crown lengthenings there. So we just use our laser gingivoplasty to do some crown lengthenings. And those were the final restorations in place. So that's the complete workflow from 2D up to 3D. So because we have used an analog way, that's a manual wax up for carrying out the wax up part. This is also called as the analog method of digital smile designing. So then what is a complete digital workflow? So again, I take the example of a second patient, a patient who wanted to get the smile corrected, but she had a commitment on time. She was to get engaged in the next 15 days. So while orthodontics is the most ideal treatment option for this patient, because of lack of time, we wanted to give her something which is interim. We did not want to cut and chop a lot of teeth. She said she'll revisit us back post the commitment to get a definitive orthodontic treatment done. But we went ahead and planned the case using the same workflow. We shoot extraoral images, carry out the simulations using the DTS Pro 2D software, The patient liked, yes, she said, I really want something like this. And we went ahead, did the 2D treatment planning. We have marked all the new positions of teeth. Now here the difference is, as you can see, we have again done a wax up here, but I have done this wax up myself in-house using a 3D software. That's DTS 3D in this case, of course. The difference here from an analog workflow, in an analog workflow, there was a manual wax up, the normal wax and knife carver, typical carvings that we do. Here we have used digital tools to carry out that same wax up. Right, once I have done the wax up, we 3D printed the model, and then because she was a patient who needed definitive orthodontics, we did not do a long-term solution. We did only an interim restoration using injectable composites for her, but she was very happy with the smile, and she's now scheduled to see us back for her orthodontic corrections. So that's the difference between an analog and a digital smile design workflow. So I'll show you a few cases here that sort of makes us understand the predictability with which we can get with digital workflows. So a patient who wanted to get again the smile corrected or the gaps closed, we evaluated both the orthodontic and the additive options, and eventually ended up towards the additive part. So again, the protocol remains the same, where we do a quick simulation for the patient to understand what the new smile would look like. That's step one of the workflow. If the patient likes what they see, we go ahead and do a little more planning. Again, use the DTS Pro 2D software here. And those are the 2D treatment plans. The digital I think I had lost some connectivity. Am I audible? I'll just check again if I am audible.
You are audible, Dr. Neeraj. You are audible.
Thank you so much. I was just cross-checking. Thank you. Right. So we did I just come back. So I did a 3D designing using the DTS 3D software. So that was again digital tools used there, and we 3D printed the smile and transferred the mock-up part to the patient's mouth. So the patient liked what they saw, and then eventually we went with the definitive prosthesis. So we have checkpoint one is the digital simulation, where we showcase patient something, but then we always top it up by showcasing the intraoral mock-up, where the patient actually feels, sees the thing in their mouth. That's a retracted view with the ProTemp in place. And then we'll always do a short video before, after, with and without the mock-up. Right, another patient who was not from a very affordable socioeconomic background. She just wanted to get the teeth whitened, and of course we can see that the patient had a lot of fluorosis, and only bleaching was definitely not the solution. You could see all the mottled appearance that we have of enamel there. Now again, the patient had come with getting primarily only bleaching done with a budget of around 5 to 10,000 rupees in mind, because that's what she had read on Google is going to cost her to do normal bleaching. But again, of course, we spoke her through the different options and then showed her a simulation that this is what is possible and why bleaching is not possible. And of course, the patient understood, saw the perceived value in that simulation. She agreed to treatment, went ahead with the 2D treatment plan, did the 3D printed designs, the 3D printed wax up, made a putty guide, and used the ProTemp to transfer the thing to her mouth. We used that same mock-up to carry out some laser contouring. Those are the just post-op contoured gingiva. And veneers that were cemented there. And you could actually see the kind of change, of course. So the point is this patient actually took a loan to get her teeth veneered, So sometimes it is not that the patients don't want to change something about their smile. We as dentists are not able to add a lot of perceived value to patients to actually make them understand of the difference which a simple smile enhancement could do, not only to their face, but to their entire personality and probably their entire life, right? I am sure everybody here agrees to what I say. It is not the patients don't want to look good. Everybody wants to look good, right? Everybody is spending so much time, effort, energy, resources on looking good, every part of their body. Why would they sort of want to leave the smile, which is probably the most important part of how a person looks like, out of that equation? Of course, there is fear. There's a fear of needles, the fear of unknown. The patients don't really know what is going to happen, and eventually they cannot envision the changes. This is where your digital tools become very, very, very valuable in showcasing them without touching their teeth, the prospective results of what a smile enhancement can do. And of course, as we discussed, smile enhancement is not limited to veneers or to bleaching. It could be implants, it could be repairing that small chip and a class 1 fracture, right? So yes, that's where digital tool become very mandatory in today's world. So a couple of cases more with a similar workflow. We always follow with a start with a simulation there, showcase the patient that this is what is possible, do the 2D treatment plan. I did the 3D designing again for this patient. We use a face scan for this patient. So I've just put a picture of a face scan. And for this patient, we did 3D printed mock-up, 3D printed veneers. We did not use the regular injectable putty guide. We actually manufactured only the veneers and of course use them as long-term provisionals. And those are the provisionals cemented in the patient's mouth. And as usual, we will always end up with a before-after video. Similar case, we have a pre-op workflow. We do a simulation, the 2D treatment plan, 3D designing, (3D printed mock-up), and that's the provisional cemented in the patient's mouth. And we can do the same process for the lower teeth as well. Those are the pre-op pictures, simulation. We have the treatment plan, 3D designing for the lower teeth, the mock-ups. The patient was ready for veneers for the lower jaw. So we did 3D, the cemented the veneers, and that's the before after with the veneers cemented in place. An interesting case here, a case who came to us wanting only to get that right central incisor worked upon. And of course, as you can see, I've put up an OPG there. Of course, it's a little small, but that tooth needed extraction because it was completely resorbed. It had got a lot of internal and external resorption. So, but the patient was very adamant. I just want you to work on that single tooth, nothing else. I still did my routine protocol where I did the picture and showed the patient a simulation. And the patient said, yes, I want something like this. That is where I told him that I can give you something like this, but I will have to work on more of your teeth. And finally, the patient sort of understood the motive of treatment. We did the 2D treatment plan and followed up with the 3D designing. Now, this is not an ideal case of mock-up because that central incisor was way too protrusive. And to do a mock-up, I would have to mock up all the other teeth in the most protrusive position, but I still took a chance. I thought, let me see how it is going to look like. Did my 3D printed mock-up, and I still transferred it to the patient's mouth there. And he was happy what he saw, of course, and he was ready for treatment. We did the extractions, placed the implant. So the same workflow, it remains for us, that we shoot images, do the simulation, do the 3D designing in-house, 3D print the mock-up, and transfer it to the patient's mouth. Okay, absolute same workflow. That is where digital dentistry is. It makes our workflows very repeatable, very predictable. All right, and that is how we were able to do the before after mock-up as well. So that is where probably I want to end up my discussion with maybe a case or two to just the penultimate case probably. So he's a patient with, of course, a cleft there. As you can see, he's a patient who wanted to do veneers, but because of the cleft on the left-hand side, we had very poor bone, and he wasn't an ideal candidate to do anything definitive there, at least on the left lateral and on the canine. And we, of course, explained the limitations of treatment, but I told her that, we can at least make your occlusal plane a little more symmetric. And even he said, I am absolutely okay with even this amount of correction. So I still went ahead and did the 2D treatment plan. And you could see on the patient's left-hand side, the left lateral and the left canine, they're way too superior, the gingival levels, and that's because there wasn't enough bone there. So we did a mock-up and the patient liked what he saw. He said, yes, give me something like this. We did direct chair side composite bonding for the patient there using the index. And that is how we were able to at least improve the smile to an extent from where we started to where we eventually were able to take the patient to. So that's the same. And I would like to probably conclude my discussion by saying that these digital tools are a very important mode of communication between three entities which go into the treatment execution. That is a dentist, the patient, of course, and the dental lab technician. And most of the times, these three do not communicate well with each other. What the dentist is talking to the patient is something which is not effectively communicated. So I believe using simulations, using the 2D treatment plans are one of the most effective ways of having all three entities on the same page. So I hope I have been able to throw some light on what the 2D to 3D digital smile design workflow is all about. And I hope we will be able to get much more predictable results with the use of these digital tools. And thank you so much for your time and for your kind attention. I'm open to any questions. You can always follow our software page, that's dts.pro, or you can always follow my Instagram handle too, that's Neeraj Rohida. And I'll be always there to answer any questions if at all. Thank you so much for your time.
Thanks, Dr. Neeraj, for sparing your time. Anybody want to ask any question related to, from 2D to 3D smile designing? Because we are getting a great outcome actually. The post and pre operations, we have seen that good outcome, and it's a 3D printing, so that you said that the lab technician, the dentist, and the patient on the same page. So the whatever is the expectation of simulation, we are reaching to the expectation and all. Anybody want to ask any question? They can ask question, or Dr. Rohida have left his email ID on the last slide, I think. Or you can put your email ID. So anybody want to ask any question or you want to learn anything, they can connect you directly. If you want to ask any question, you can unmute here only and ask question. Details of software. Somebody, Wakar Siddiqui is asking that.
It is there on the website. I will just put up the website again here. And if there are anything, you can always connect with me, but I will just share the.
There is a one. Just hold on.
So I've just put up the website there. All the details of the software, that's DTS Pro, is there on the website. That's dentaltreatmentsimulation.com. So yeah.
Can we do this for a trauma cases? Somebody asked.
If I understand trauma correctly, you means a dental trauma. I'm sure a class 1 or a class 2 fracture. If it is a simulation, definitely yes. We also use 3D designing. Even if I'm doing a composite, for example, I can actually 3D print my model and use it as a palatal guide index to build my composite. So yes, if that's what you mean by trauma, yes, definitely you can use it.
Okay. Very enriching knowledge, and thanks for the confession. There is a, yeah, Isha is saying thanks. Uh, somebody is asking, somebody has unmuted and asking question, but due to connectivity, we are not able to hear him. So with
Yeah,
this note,
can we use this software directly?
I'm sorry, can you come again, please?
yes, Dr. Vakar, yeah.
I'm not clear. Yeah, can we use this software directly, or it requires some time to
No, of
simulate
course,
the
see,
case and all?
anything new, you need to have a little bit of a learning curve. Of course, there are two different modules. There is a 2D part and there is a 3D part. The 2D part is a straightforward one using images, which doesn't need a lot of training. 3D ones, you would need a little bit of training, but it's a self-learn sort of software, and we have a support team in place for the same. So yes, I hope that was what the question was, and all the details are definitely there on the website. You can reach out to the support team through the website itself for any further questions, if at all related to the software.
Thanks. Yes, yeah. So with this note, Dr. Neeraj, should we move on to, with your permission, to the next speaker? We are running short of
Yes,
time.
thank you so much for your time, and wish everybody the best.
Thanks
Thank
a
you.
lot for sharing your precious half an hour to us. Yeah.
Thank you. Thank
We'll
you.
try connect again for any future programs.
For sure. Thank you.
Okay, thanks. So we are moving to our next speaker, Dr. Nitin Thomas. Dr. Nitin, are you there? Could you unmute yourself and open your camera?
Hi,
Yes.
hi.
Yeah.
Hope I am safe, peaceful. Hi,
Yeah,
doctor.
yes, great. So let me introduce you formally, and then you can start
Yeah.
your presentation. Dr. Nitin Thomas is an oral medicine radiology specialist, completed his BDS from Government Dental College, Bangalore, and MDS in oral medicine and radiology from MS Ramaiah Dental College, Bangalore. After MDS, he joined the Maxillofacial Diagnostics Oral and Medical Medicine Radiology Center, Kochi in 2017, where he started his 3D printing journey with application in implant surgical guides, endodontic guides, guides with 3D simulations for orthodontic surgery, and research in 3D printing and resin material. He has also done national and international presentations, conducted CVCT training workshops. He started his Cube 3D prints in 2023 as a exclusive SLA-based 3D printing company, and had been provided highly customized implant surgical guide solutions named DentiGuide ever since. Currently, along with his passion of oral medicine and radiology, he pursues innovative in digital dentistry and 3D printing application in dentistry. Over to you, Dr. Thomas. If I missed anything, you can add on, and then you can start your presentation. Yeah.
No. That was very, yeah. That's a great intro. So I'll just share my presentation. I am
Yes.
there. 1 minute.
Yeah, your slides are visible in slideshow. Perfect, perfect. Go ahead, Dr.
Yeah.
Nitin.
Yeah.
Yeah.
Okay. So good evening, everyone. Nice to see a lot of people here on a Sunday evening. When but it's Sunday is our most for most of us, Sunday is the only day we can rest and relax and stretch out. And it's great to see so many people coming out to speak on digital dentistry, digital implantology, smile design. It was a very good, nice lecture by Dr. Neeraj. So uh, it's a fun and exciting time in dentistry, I would say. And also, there are many people who are leaving the industry because they are telling there's no future. But there are another set of people who are just getting started by experimenting new things and bringing out new technologies, new innovations, new ways for patient care across India. And I think India is currently one of the forefronts in this because a lot of active experimentations research on 3D printing, whether it's milling, all kinds of new technologies are here. And whenever it's getting introduced in outside in India, we are one of the other main doctors. We are able to bring that technology here, and it's been really exciting to see such stuff. And I'm someone who's uh, very in touch with tech and computer from my childhood. So that's how I got interested in this. And when I got into my PG and when I studied CBCT and the tech and engineering side of it also, not just the radiology, biology aspect, of course, that's also important, but it goes hand in hand. So the industry is like, as everybody says, it's part artistry, it's part engineering, it's part this. We are a mixed bag of all kinds of skills, right? So my name is Dr. Nitin. I'm from Cochin originally, but my education has been in Bangalore for almost 10 years. I was in Bangalore. After that, I came to Cochin, worked under oral medicine radiologist, and now I've started my own small setup. So I'm sure before I was just seeing the speakers list, and most of the today's and yesterday's topics were on digital implantology, right? And it's already here. It's not the future. I wouldn't say it's not the future. If you go to any expo, any international events, it's the majority number of stalls are focused along on this aspect where implantology is becoming more predictable, the technologies are becoming more accessible. A lot of people are bringing out new set of diagnostic and therapeutic workflows on how to practice implantology. And it's very nice to see even in our country, a lot of, even if you go to any east, west, north, south, everywhere, people are trying out this and they are getting good results. And I see a lot of people are the interest has been growing. In short, that's what I would say. And I would tell that that's because the inevitable truth, right? Because in implantology, if you fail to plan, you are planning to fail. One or the other. You may hit or miss a few cases and try, like you may have a few successful cases, but sometimes without at least a basic planning, especially from a oral medicine point of view, CBCT planning is it's no more a debate on whether you should take a CBCT for an implant case. I think in today's world, in today's practice, we are a scientifically backed community. Whatever we do, even if it's a small restoration, it has to be calculated, pre-planned, and everything. I'm someone who believes in that. Okay, so this is a short presentation about. I'm not going to talk about why you need to do guided surgery because everybody knows that. I'm just trying to tell you how it is. Some cases it is inevitable, and why also my second half of the lecture should be like why sometimes things don't go according to plan, why there can be a failure, and how to correct all that. Okay, so if I sum up the main points, it'd be like the major factor why anybody wants a guide is a surgical guide is for precision. And there are cases in which we have to get precisely the implant placed in such a thin or aesthetically or functionally preferable position. So in just such cases, precision guides have been already proven. Like there are enough studies to show you that guided surgery enables millimeter level accuracy in placing implants. And the other, while you can count all these points, enhanced safety, faster recovery, and efficiency technology, I think the main points I would feel, because I've been practicing implantology and I'm also assisting training dentists for guided implantology. Whenever they ask for a guide, we usually go with them for their first case, to even if they are very skilled and very highly seasoned implantologists, there is a workflow for guided how to plan, how to do the surgery, there how to do take each instrumentations for each kind of cases, different types of that. So uh, the idea is on the day of surgery, as a dentist, you are tension free, you are completely prepared for what is coming, and you know what is going to happen, what is the end result. You are putting the end result in mind first, and you are working backwards. And for the patient, there's less chair sign, there's less post-operative complications. There are in few of our surgeries, patients were surprised that it's got over in such a short time. And when it's and of course surgeries are flapless, uh, it is sometimes really life-changing because we have had cases where patients were in warfarin and other blood clotting antiplatelet medications where flap raising a flap was really a big question. So in that case, we were able to help them out without raising flap. So and efficiency it improves as I think when as dentists it improves our efficiency, like what the previous speaker Dr. Neeraj was studying. It improves case acceptance when you're showing them three-dimensionally that this is what's going to happen, and this is where we are going to do, and this is what we are doing to ensure that level of precision it happens in your case. So the patient is also like times have changed. It's now cost was a factor of surgical guides, and that was one of the disadvantages many people said because guided surgery this is expensive. But the guides, everything now patients we have patients who come and ask sometimes like, is there option like this? And I have seen it in YouTube, I've seen it on Instagram. So is there option like this? Can we minimize the risk? So there's a lot of case acceptance happens. And as the dentist, our efficiency, we are not breaking our back and heads on to plan to do the case. And some cases, are really, really difficult. Some patients are also really, really difficult. So it all comes together when you're doing a right research. Technological integration, we uh, am I audible? Is there any issues with
Yeah,
this
you
thing?
are audible, Dr. Nitin.
Oh, yeah. Yeah. So, continuing. So, now, and we live in a time where 3D printers, the software, the materials, all have become affordable and accessible, right? Now, anybody can go order a 3D printer on Amazon. It's that easy. You will get it in 2 days, 3 days max. It's just that you have to update yourself. You have to train yourself. There is a small learning curve. There's no shortcut to that. But of course, only when you take that first step of getting into this and start doing surgeries will you understand the importance, and only then you will understand why it's becoming more innovative. So so this is a big word, right? Prosthetically driven implant. We've been hearing it for maybe 30, 40 years now. Everything has to be prosthetically driven, prosthetically driven. We have from different traditional workflows where we do a manual wax up and do a vacuum form and get a traditional guide. I don't know if you have seen those things where they make a vacuum form, then they put a hole in the center of that to get a prosthetically correct posture. So apart from that, we have come to a stage where we are even giving the 3D printed processes soon after the temporary processes soon after the uh, uh, and soon after the surgery. So procedurally driven implantology for me is just a fancy word of saying it's a reverse engineering process, right? It's basically reverse engineering. How the implants should be placed is driven by how the teeth are coming into functionally and aesthetically favorable position. And that plays a big role. That plays a big role in planning. That plays a big role in how we design the guides. How that's even everything. At each stage, we are focusing on how this final outcome is going to come and how we are going to tackle each situation. Very rarely we do get simple cases like single mode, single like anterior lead, anterior to often it is very I think especially in Indian population you can see where the bone is either when there is a lot of bone, patient is not ready to do the implants. When whichever patient is ready to do full mouth implants, there won't be any. So we are pulled between, stretched between all this. So I'm sure most of you who practice would have had this situation. So how do we make it more predictable? How do we make it customizable? So that's what I like to show this with example of two cases. The first case is an anterior missing tooth. That is 2-2. You can see the depression on that lateral area that the tooth was extracted long back in this patient, and you can also see the CBCT cross section on this left-hand side bottom. So yeah, I mean, it's not necessary that you can place a freehand implant here, but to get a screw retain restoration on this, now that's a challenge, right? Even though the usual protocol is raise the flap and angulate it more palatally and get the implant placed there. But here you can see the challenge is that one is the fossa, the deep fossa. There are many cases where when we do reporting for CCD, we see post-implant cases. Right? Easily could have avoided if it was planned before, where the implant is just shifting out for more buccally, or if it's getting exposed to paracy or to. So such kind of mistakes could be avoided, and it is no more. That's why I say it's no more an excuse to avoid planning at least. CBCT planning is mandatory if you are doing. For me, that's my view, but I'm sure most of you will agree because we need that kind of what do I say, researched and scientifically backed planning before we even touch the patient, right? That is the ethical part of it also. So in this case, there was, as you can see, there's constriction there, foramen implant. So to get screw retain restoration, which is more aesthetic, we went ahead and did a wax up, a digital wax up in this case. Here in this case, we made a small correction on the canine. As you can see, we corrected the mesial aspect of it so that to get a proper size crown there. So once we did the wax up, we calculated how this can be corrected and made the screw retain processes on this. You can see there is that much amount of bone. We didn't want to go for a ultra narrow platform implant that the doctor also didn't want for it. We were thinking either to go with a 16 mm or a 13 mm implant based on that. We planned for a 16 mm implants here and between the two roots and within the cortical plates. So with this, we were able to, this is the guide that we did, and this is the result. So such kind of cases, yes, again, that's what, again, we can try and go ahead and freehand, and we, maybe a few people will get it, few people, but I'm sure most people may miss it also because this is an area, the anterior, if you ask, many implantologists and everybody says that it's the anterior area is the most difficult areas is one of the areas to get a proper implant place and for a proper crown place. So that kind of planning and taking support from a guide and from a person who can design and plan and guide for you is a very important aspect here. And that was a simple case. Now I'll show you another case where it's a little more extensive planning was required. As you can see here, patient has a protrusive bite. So he had very few remaining maxillary teeth, and the ones which are already there are all carious or grossly treated and all that. and a lot of VD loss also. We needed to, as you can see here on the molars are also corrected. The bite plane is completely off. We had to correct all those things. Now, this was a very aged patient, around 70, 75 years. We were thinking how to best proceed with this. And the cross sections show that we had very little bone thickness also in the anterior region. So we did an initial wax up to see if we can get all the corrections done, and also to show a patient like how what we are planning and what is it. So it became evident that we need to do a certain amount of bone reduction also, because everything was becoming, the anterior bone was playing out labially, and the premolar canine bone areas where the bone were very knife edged. So it became evident that we need to do a little bit of bone reduction. So in this case, if it's not planned digitally, how do we decide how much bone should be reduced? At what plane should be the reduction be done? So all those calculations can be done digitally. It's not just arbitrarily you cut or you trim off bone 2 to 3 mm. Just raise up on a flap, and that is very arbitrarily we'll be planning them. Here we are exactly seeing where is the in CBCD, we'll be seeing exactly where the bone is and how much level, where, what plane and what angle should be cut. And we'll be making a bone level guide on this. So this is a case is already done. I'll show you the case photos also after this. In this case, we actually planned a bone reduction guide. So you can see even after reduction in this premolar canine areas, both regions, there was not that much bone. Usually when you do a bone reduction, you get little more wider area to place a wider implant. But in this case, except the anterior and the posterior, the width available at the crustal portions were very less. So uh, going going for a guided system became undebated. Right? We were pretty sure that we will need to add. And even if we place all 4 implants or 6 implants in the anterior, there were chances that 1 or 2 may fail. So as an additional backup, we even plan for the pterygoids in this case. So from this, we planned all on 6 implants, and this is osteotomy. This is called a stackable level guide. So I'm sure most of you have seen it by now. I've heard it of it now. Yeah, where initially we place a stack, a base guide which acts as a guide for your bone reduction. We reduce it in the same plane as the bone reduction guide. Then on top of that, we'll be placing a removable guide that comes as a stack, goes and fits in this base guide. That will act as the osteotomy guide. And once osteotomy is done, we'll remove that guide, and we have customized based on the wax up we have planned. We have made a temporary wax. In this case, so I'll just go to the case. So this is what we had planned. We have different guides for that. This is the first, from the bottom, this is the base level guide or the bone guide. And then we have an initial pilot guide, then the implant placement guides, and then we have a processes guide also. On the right, you'll see that is a pilot guide for the pterygoids. So we did as went ahead as planned and placed. We did a bone reduction. We did a pilot guide. This is what we get on that. So even the implant which we planned, the second quadrant to enter palatally, as you can see, it is exactly replicated here. And we didn't have any exposure of the implants anywhere else, like other than this, which was kind of expected because above this there was no bone. And we even could get the pterygoids in perfectly, and it was excellent stability was there. So to say, if you ask me, guided applications are mandatory in some type of cases, or at least in your starting out implantology, or if you are trying out something new. there are cases in which it's always better to do a guided surgery and a freehand. Whenever you have that option, it is better to do that. So especially the single implant anterior tooth spaces where there is tight spaces, and also in full mouth rehabilitations where you're doing a perfect all on 4 all on 6, and where you have no space for a backup implant or a where there is no other option for that other than a angled implants, tilted implants, or implants from remote anchorages from remote areas like zygoma, pterygoids, and all that. Also, in little more challenging cases where you have to do indirect sinus elevations in very little amount of residual amount of force. So, in those cases, we make a guide only for that. Make a guide to a drill depth 1 mm short of the sinus floor, exactly there, and then we do this thing. You even have guided kits for sinus elevations now, making it easier, more predictable, less traumatic. And also in cases where we are doing nerve bypass, as you can see on the top right, where we have done a nerve bypass. So in such cases, it is always advised, I mean, if possible, always go for a guided surgery. There are many people who are doing guided surgery now, many labs are doing guided surgery. So it is, like I said, it's becoming more accessible. Okay, why we should risk the patient's health or indentation of conditions because of our ignorance? That should be your question. There is an option, do go for it. I mean, even if you are a seasoned implantologist, you've been practicing a lot of years, imagine the amount of stress-free, and we all like to work in a stress-free environment. We don't want to, sit and think and worry in front of the patient that something goes wrong. Now, having said that, I know there is a lot of talk around guides where many guides have failed, right? So why does it fail? That also has to be explained as someone who's making guides on a daily basis. I've seen failures too. When I started guided, um, started doing guided cases as in designing and planning. And as someone who's been into CBCT for since my PG days and doing implant planning from those days, I've always wondered why guided surgery is not that mainstream yet. Okay, so in 2018, there were, in my place at least, there were absolutely no one who's actually doing it mainstream. Or I didn't know anyone to help to guide how to do a guide. And what are the challenges they face, and why is there a negativity around this guides? So these are the 5 points in which I could find uh, why it can fail. So starting from data collection, the way the CBCT is done makes a big change. That's something I think everybody misses out on. Just go take a CBCT and come. So, but what kind of CBCT? I mean, what FOV of CBCT, the clarity of the CBCT, the structures covered in that CBCT, how we, because the workflow involves stitching a intraoral scan or a CAS scan to a CBCT. So this integration has to be perfect. For that to be perfect, our records, our data, how we collect the CBCT, how we make the intraoral scan. Initially, I had few of my failures were due to just poor impression making or poor cast forwarding, errors in cast forwarding, errors in impression making. Then slowly, now because of the boom and widespread acceptance of intraoral scanners everywhere, that problem has come down. But still, even scanning, you may have a problem. Scanning is not done properly. There are dimensional errors in scans. That is true. Some of the cheaper scanners, if you don't calibrate them every now 15 days or 20 days, they can give you dimensional inaccuracies. So these are all things we have seen, and I have experienced in my line, my work here. Then the second comes in the planning. because in CBCT you need to look at all three axes and how the implant is, because you are placing a three-dimensional object into a three-dimensional patient. So it's not like planning it on an OPG and just making sure somehow it will come sure. There's no guesswork here. You have to know how you are entering, at which point you are entering, and which point you are implant is going to stop, at which angle, from all three axes. That includes mesial, distal, superior, inferior, and posterior. On all three axes, each implant has to be visualized clearly, communicated to the doctor, communicated between the among yourselves, your team. As you know, we should have clear planning, not just for the placement, even for the processes, right? Which submitment, how we are going to, how the school holds are access holds going to come, even if it's a multi-unit, where are the multi-unit access holds going to come, how we are going to tackle if it's a difficult position. All those planning should be done. So uh, for this kind of uh, I would say the majority of the work in doing a guide comes in this planning stage. That's where we focus. Our entire focus is on this planning stage. Everything else we still have a little bit more control. Because planning, if it goes wrong, the guide will not exactly replicate that. Whatever mistake error we do in the planning will exactly be replicated in the guide and in the patient also. So you have to be very careful. Then comes your 3D designing and printing areas. There are few things there also you have to look, like how the guide, what is the size of the guide you're going to pick, which all areas you're going, whether it's going to be a tooth bone guide, a tissue bone guide. If it's a tissue bone guide, how much support you will take from where, how much anchor pins you'll be placing, at what time, at where all do you place the anchor pins. That comes in the design. When it comes to printing also, which type of resin you're using, what is the shrinkage of that resin, what is the strength of that resin, what is the biocompatibility of that, because we make sure that we use a strictly biocompatible resin, whichever is available. We use Accident resins. So they're very biocompatible. They are now they've been shown class 0 biocompatibility thing. So uh, that is also important, right? Dimensional accuracy also gets affected if you choose the wrong printing, wrong resins. Then comes the guided and surgical skill. Now, what I mean by that is we all have skill. What I mean by that is when you're doing a guided surgery with a guided kit, there is a slightly different workflow in that. It's easier, but there is a learning curve. So like I said, there's no skipping that. You have to do in such and such places. Like some people may find it a little much like out of this thing. Like, why should we go do an additional drill here? Because in guided surgery, as you know, you are not getting the same kind of water irrigation as you're doing in a freehand surgery. So there are workarounds for that. How we tackle that, how we do that. So all those has to be incorporated. Because even if we plan everything, design everything, print everything properly, if you're doing the guided surgery wrong, if you heat up the bone too much, the implants are going to fail. So again, that will show that the person who's doing guided surgery will obviously question what's the point of doing guided surgery if ultimately the implant is failed, right? So all these areas are uh, well considered in implants. Yeah. Moving on. So I would say this is like a team effort, right? So like again, the previous doctor was telling, you can do everything on your own. In your clinic, you can sit and plan the implants, you can sit and do that. But your efficiency of attending cases, diagnosing, everything comes down when you are in strain. So I think implantology, especially, something which has to be uh, delegated to different team members within your institution, your clinic, because you need a proper lab support, you need a proper planning person, you need a proper person with a good surgical skill, because ultimately we are all working together for the benefit of the patient, right? Uh, it is about bringing them their smile back, or giving them their smile back, and giving them their happiness back. And when you do that, regardless of what instrumentation technology innovations you use, at the end of the day, if you can make the patient smile when they walk out of your clinic, that is your biggest marketing thing. I don't think when today people are running when people are active running by Instagram and all that, patient and their word of mouth marketing is really, really important. I think that is the number one for anyone. So to and next to teamwork, I would say you will know a little bit. You should know as a clinician about the different types of guides that are available. If you don't know, I'm just summing it out for you. There are tissue supported, there are completely tooth supported, there are tooth and tissue supported, and you have bone level guides. Each has its own application. Just because we can say we think we can do a case flapless doesn't mean we can directly go and do a flapless surgery. Sometimes we may need to raise a flap and place a guide on the bone, like a bone level guide. So that depends on the CBCT assessment, right? Even if you do everything properly and are planning a knife edge case for a tissue supported guide, sometimes the drill may slip here and there. Those kind of errors has to be planned before itself. Like where all can it fail? That's what we do a reverse thinking there also. Like how and where all can we avoid mistakes when making guides, designing guides, practicing guides. Uh, so these are the different types of guides. Studies have shown that tooth supported guides are the most durable, reliable ones. So whenever you have a provision to do a tooth supported guide, you can go for that. Otherwise, you can go for a tooth and tissue supported, and you can also use extra anchorages with the tissue stabilizing tools. But stackable guides are where you need to do bone reduction, where you need to change the patient's bite, change profile, um, change the vertical dimension. Those cases, you can go for a stackable guides. We do it for maxilla, mandible, both. And protocols, these are the strict protocols that we do follow. It is a fully digital workflow where we CBCT data and intraoral scan data. Nowadays, very few clinics send us the cast scans or the cast. So it's a good thing that we are moving completely digitally. And we do a we do a crown down implant, plan the guides, and then do this thing. So it seems like a simple workflow, but only when you do a few cases will you understand the challenges here and there in each step in this areas. And before doing a guide, like I said, like the records have to be proper. The CBCT actually properly taken. Sometimes the most common mistake I see when we're doing for a guided surgery is many people, there is only a single implant, a single tooth, or only in a quadrant. They focus CBCT only on that region, right? Like let's say 2, 3, 2, 4, 2, 5 is missing. They make sure they scan only that region. Yes, exposure wise it is less. But if you are planning for a guided surgery, it is sometimes difficult to just work with that few teeth that is remaining. So if you're doing an implant study, so the idea is to get an implant study and there are multiple teeth missing, few in the upper, few on the lower. So always to include the full arch in the CBCT scan. The cost and the radiation exposure are negligible, whether you do a quadrant and the full arch. Okay, so take it from me. We've done radiation studies based on that. So the smallest FOV is the least exposure, and the largest FOV is but the in between ones, the difference between them are very less. So always go for a full arch once. That helps us. Helps who are making the guide to plan and digitize us better, to get the records better. And intraoral scans, I would say get a decent intraoral scan. Anything like a shining scan, 3D, or which comes like around 4 lakhs and above. Yeah, it's time for people who do not yet dip their toes into digital dentistry. I think intraoral scan is their starting point. It's a must-have. I'm sure in many areas still coming up. We have a lot of vendors in our state. And for edentulous cases, there is something known as dual scan technique. That is the most accurate way to do this thing, especially if you're doing flapless cases, where you have where you need to do 2 scans, one with the denture and one the denture of with the patient and one with only the denture. So these are all different classes. So I'm not going into deep all this. So uh, the idea is to get the, like I said, the data correction advice. So with that, I would like to conclude it with, I would say the future is not coming, it's already here. Again, I'm very thankful to Dr. Noel and Iddcon for inviting me for this lecture. And I'd like to answer any questions you have.
Thanks, Dr. Nitin, for joining from Cochin and thrown light on how to we have the guided technology, why to inevitable in modern implant technology and practice. Anybody want to ask any question? They can ask directly to Nitin. Can unmute himself or herself and ask question here. Otherwise, you can email to him. Dr. Nitin, could you please? So cube3d cochin@gmail.com is the email ID, and his number is also displayed in the last slide. So we have the time constraint. Anybody want to ask question? Just unmute himself or herself and ask right away. Otherwise, we'll move to our next speaker. Thanks again, Dr. Nitin, for joining us, and we'll invite you again for our any future digital dentistry, any program related to digital dentistry. We are moving to our next speaker. With your permission, Dr. Nitin, should I
Sure,
move
sure,
to?
sure.
Yeah, yeah. Thanks, thanks for
Thank you, sir. Thank you. Yeah.
So our next speaker is Dr. Rohit. Dr. Rohit, are you there?
Yeah, I'm here.
Yes, yes. Yeah. So let me formally introduce Dr. Rohit. Dr. Rohit is head of the Department of Dentistry, Agarwal Hospital and Research Institute, Gwalior. He's a professor in Maharana Pratap College of Dentistry, Gwalior. He's over 15 years of experience in academic experience. Dr. Rohit Agarwal is a highly respected name in the field of dental implantology. He has been at the forefront of advancing dental care in central India, both as a clinician as well as educator. He has trained in implant dentistry across USA, Brazil, Dubai, and several other countries. He is the first dentist in Gwalior to initiate dental implant workshop, and he conducted numerous national and international workshop on dental implants. He has attended more than 50 national and international conferences, published more than 10 scientific papers in national and international journals, recognized as a mentor and a leader in promoting modern dental technique in India. Over to you, Dr. Rohit. If I missed anything, you can add on any relevant, maybe I have missed out in your
No, it's all
introduction.
perfect.
And then you can continue. Yeah. Though we are a bit late in our scheduled time, we are lagging in half an hour, but
No worries.
yeah, yeah. Over to you, Dr. Nitin.
Okay, yeah, I'll just share my screen.
Yes, yes. Yes. Your screen is visible. Yeah.
Yeah,
Perfect.
everybody can see me now.
Yeah, yeah, it's visible.
Okay, so I'll start my lecture. Good evening, everyone. So I'll keep my lecture very clinical. It will have a lot of photographs so that you don't get bored and sleepy. I know it's a Sunday weekend, So, but try to cope up. I'll keep everything clinical and it will have lot of photographs. There won't be any text in my lecture. Okay. So I'll be talking about the tilted implants, that how can tilted implants help you to load a case and to conduct your implant surgery in such a way so that patient gets the final prosthesis within a short span of time. So, because what the problem is nowadays is that patient wants everything quickly. Lot of NRI patients are also there, so they want the teeth in the lesser amount of time, and of course in lesser amount of money also. And none of the patients they want to undergo any kind of major surgery like grafting and all those things. I'm not saying those are contraindicated. I'm just saying what the patient wants and what other latest options are currently available in the dental implantology. That's what I'm trying to show you. Like this full arch case, as you can see here. So this full arch case, as you can see here, this was the case. We are rehabilitating the maxillary arch. Okay, from the 1-2 region up till 2-7. So this is how we went ahead with this case. We had placed 5 implants, and these 2 implants on the second quadrant, we tilted them. Purposely we tilted them because we want to skip the sinus lift procedure, because as you can see here, the vertical height of the residual bone is very less. So we didn't want to do any kind of sinus lift procedure. So we tilted this implant, engaging the sinus lining and also the nasal fossa. Same here, it is engaging the nasal fossa, the cortical margin of the nasal fossa and the crestal bone. So this is like a bicortical engagement and this is like a tricortical engagement. Okay. So with the help of this tilted implant, we can continue with the prosthesis. This is the step of jig trial. Okay, we are verifying the impression with the help of this open tray impression coping. So this is a metal trial. You can see we are doing the metal trial for the patient. We are checking if everything is sitting properly or not. So this is the metal trial on the OPG. We have used multi-unit abutment. Whenever you are doing tilted implantology, then you will have to use multi-unit abutments so that you can give a screw retain prosthesis and your path of insertion and removal is parallel. So you have to give a multi-unit abutments. These are multi-unit abutments. And finally, we are giving a DMLS PFM prosthesis. This is the BISC trial we are doing. We'll be checking all the occlusal errors and all those things. And this is the final smile of the patient. Luckily, on the day of delivering the final prosthesis, the patient was having his 70th birthday. So it was a very good day for me also. Patient was so happy. He said, "Sir, you gave me the best gift of my life." And it was early morning. So he said, even his wife also did not wish him. He came directly to my clinic. So that was a good day. So this is the final OPG of the patient. This is the PFM prosthesis. Okay, now this is a one more case. As you can see here, there is no bone only. There is no vertical height of remaining bone. So this is again, we did the indirect sinus lift here. This is an axial implant indirect sinus lift with bone grafting. In this case, if you see the OPG, it looks like the whole implant has gone inside the sinus. But actually, this is not inside the sinus. This is a palatal-nasal implant, where you place the implant in the palatal bone. Okay, so this is called palato-nasal implant, engaging the nasal cortex. So this is the final. We have taken the impression with the help of a scanner. So this is how you can see this is the position of the implants. This is the palato-nasal implant. This is the implant with indirect sinus lift. This is a straight axial implant. And this is the final prosthesis of the patient. Okay, you can see the final X-ray. This is the palato-nasal implant. This is the fit of the prosthesis. Okay, so this is a semen retained prosthesis with a PFM. I have multiple cases, so I'll keep on showing you as many as possible. So this is again a full arch case. This is the CBCT of the patient. You can see this is a compromised ridge is there on the lower right side also. Okay, and lower left side also. In this case, I preserved this 3/6 tooth, okay, for proprioception. Rest of the teeth, we had done the extraction followed by immediate implant placement. So this is the reformatted image. This is the reformatted OPG image. So you can see a lot of bone resorption is there. So after doing all the extraction, and we have done the crasteotomy to flatten the ridge, and this is how the implants were placed. These are the implants. This is the implant here. This is a all-in-4 case. We have tilted the implants in the premolar region bilaterally to increase the AP spread so that we get minimum amount of cantilever. So this is a tilted implant. You can see here, this is the tilted implant. This is the mental nerve coming out of mental foramen. You're supposed to skip the mental nerve. You're not supposed to encroach the mental nerve. This is in the final stages. You can see these are all the multi-unit abutment. 5 implants we had placed. I had done all-in-4 here, but I tried to place more implants because more is merrier. If you're doing full arch cases, we try to place as many implants as possible within the prosthetic limits so that there is no cantilever. You get maximum amount of AP spread. You get maximum number of support for the prosthesis so that you will get a very, very good long-term prognosis. So this is, we are taking the impression, full arch open tray impression with a splinted impression coping. This is the impression. This video was sent by the lab. See, you can see, this is this impression coping with lab analog is moving. So if this is moving, so that means you're supposed to retake your impression. Your impression coping should be very stable after taking the impression. This is the final cast of the patient. 5 implants we have placed. This tooth 3/6. I've saved the 3/6 tooth. So this is, you are doing a jig trial. Now we are going for the metal trial.
Good afternoon. I'm Dr. Rohit Agarwal from Gwalior, Madhya Pradesh. Here we are doing this one screw test. I've got this metal trying for this patient. We are giving a fixed PFM prosthesis for the lower edentulous region. Okay. So as you can see, this is a metal trine. I've placed it on this multi-unit abutment. So you can see now it is seating perfectly on all the abutments. Okay. This is, I have not placed the screw yet. Okay, so that means it is passive fit. There is no gap anywhere. See on the, we can see on the lingual side also. Lingual side also we can see. On the lingual side, you can see there are no gaps. Okay, it is fitting passively. Now,
so this is how you check the passivity of your metal trial. This is the final prosthesis of the patient, PFM. This is on the cast and this is the final prosthesis. This is kind of a tilted implant here. We have tilted this implant to skip the mental nerve as I showed you in the CBCT. And this is one more implant we have placed here. This is 3 years follow-up. Patient came back. Patient wanted implant teeth in the 4-7 and 3-7 region also. So this is the 3 years follow-up. Some amount of calculus is there, but otherwise it's all stable. This is again a full mouth case. You can see all-in-4 tilted implants to skip the bilateral sinus lift. Otherwise, you have to go for bilateral sinus lift. So this is an all-in-4 technique started by Dr. Paulo Molo. But in the lower arch, because we had ample amount of bone, so we followed the golden rule by Carl Misch. We placed axial implants. So this is again to correct the angulation. You are supposed to place the multi-unit abutments to correct the angulation. Again, open tray impression. This is again the this is the cast from the lab, which is available to do the jig trial to verify your impression. We are verifying the impression in the patient's mouth. So this is again above. This is the maxillary arch. This is the metal trial. This is the final prosthesis. Upper and lower final prosthesis. This is 2 years follow-up. You can see, you can appreciate the bone level. This is the all-in-4 in the maxillary arch. Again, this is one of the cases we did. So you can see to skip the sinus lift, we did the tilted implants tilted implant here also. This is like again all in four. Actually, in the beginning, I had placed two short implants, one here also and one here also. But this one failed during the prosthetic phase because it was a short implant, and this patient had a severely compromised ridge. Plus, the patient was a heavy tobacco chewer, and he had grade 3 OSMF also. So, a lot of complications were there. So one of the common complications that occurs while doing a tilted implantology during the prosthetic phase is that improper seating of the multi-unit abutment. You can see here in this IUPA, this multi-unit abutment is not seated completely. So after placing the multi-unit abutment, you have to verify it with your IUPA that all the multi-unit abutments are perfectly seated. Otherwise, that will lead to prosthetic complications in long run, like prosthetic screw loosening, screw fracture, and all those things. Again, one more full mouth case, extraction followed by immediate implant placement. You can see lower arch, we did the root submergence technique, and then we place axial implants, upper arch. Here there was severe bone loss, so we tilted this implant. Okay, but we were able to place sufficient number of implants, 1, 2, 3, 4, 7 in above and 6 in lower arch. So this is again with multi-unit abutment, metal trial lower, both are screw retained processes, PFM. And this is the final process of the patient, upper and lower. This is 8 months follow-up. So this is again one more case. This is how the patient came to me. See above, immediate extraction followed by implant placement. So here while during the extraction of 1/6, there was severe compromise of the bone. So we had to tilt the implant on the spot. See, you can see this is now again 5 by 13. The diameter is 5 and the length is 13. I've tilted this implant. Okay, because here the bone was severely compromised. After the extraction, there was hardly any bone left. So on the spot, I had to tilt the implant. But everywhere else where I was getting bone, I had placed axial implants. So again, PFM, upper and lower. So you can see this is the final smile of the patient. This is how the patient walked in. This is the CBCT, upper full arch. This we are doing a guided planning, guided surgery. This is the CBCT of the patient. The radiologist is doing the guided surgery planning. So this is the guide for the maxillary arch. So in this case, to skip this sinus lift, we have tilted this implant. Okay, so this is the final processes of the patient. Lower, we are given this. This is the PFM. This is again Emax crown. This is a screw retained monolithic zirconia. This is Emax tabletop. And this is your monolithic zirconia. Okay. This is FP3, upper arch, zirconia, screw retained. This is the final smile of the patient. This is the follow-up. Normally, I told you, I try to place more number of implants. So you see, this was an extra implant. Prosthetically, it was not required. So I keep it sleeping inside. It is like my safety net. In future, if one of the implants fail, so I don't have to worry. I don't have to worry. I have to just directly go for the second prosthesis. Okay. This is 6 months follow-up. This is again case of tilted implants. See these two, we did extraction followed by immediate implant placement. To skip this sinus lining, we tilted this implant. See, this is again by 16 mm length. So by tilting the implant, one more advantage is that you can place a longer implant. So by increasing the length of the implant, you are also increasing the BIC. BIC meaning bone to implant contact area. So this is the lower right side. There we placed axial implants. So this is the final process of the lower right side. This is the upper left side. You can see this is the multi-unit abutments. And we have given a screw retained prosthesis. This is the IOP. You can see this is the tilted implant. This is the sinus lining. We have skipped the sinus. See, this is one of the complicated cases that I did. I do a lot of cases on consultation in different cities also. So sorry for the quality of the X-ray because this is the photographs which I could take of the monitor. So I don't have the soft copy. So some of my slides will be like that only. So this is like a, you can see highly compromised ridge is there, hardly any bone here. So we went ahead with the tilted implants. This is the anterior tilted implant. This is the posterior pterygoid implant. And some confusion. Sorry. Wait a second. Yeah, this is the anterior tilted implant. This is the posterior tilted implant. So you can see here, we place the pterygoid implant in the posterior region and anterior, this is the tilted implant. This is again a full arch case. You can see upper and lower arch. So upper and lower end impression we have taken. This is the open tray impression. We are doing a jig trial. This is the BIS trial, where we check all the occlusion discrepancies. BIS trial being done in the patient's mouth. This is the final process of the patient. Upper and lower screw retained DMLS prosthesis. See, this is the final smile of the patient. And you can see here again, we have tilted the implants. I've tilted this implant bilaterally again to skip the sinus lining. So I've tilted this implant, these two implants. So that way you can skip the grafting procedure. And see, this is a bigger diameter implant. These both are 5 mm diameter, which is a very good diameter in the field of dental implantology. And in the lower side, we are able to place axial implants. So I had placed 7 straight implants. This is the final smile of the patient. This is one of the cases, complicated cases I did at consultation. You can see the sinus lining, bilateral sinus lining. So we did the tilted implant. See, one tilt here, one tilt here. These are again long implants, and we were able to skip the sinus bilaterally. This is the cast of the patient after taking the final impression. Again, screw retained prosthesis, no cantilever. See, you are not giving any cantilever. One of the advantage of doing, I told you before also, of doing tilted implantology is that you can avoid cantilever. You can increase the AP spread of the final prosthesis, thus decreasing the cantilever. Lower again, screw retained, and this is the SCRP. Prosthesis 2 are screw retained. These 2 are screw retained prosthesis. And this is your SCRP prosthesis, screw cement retained prosthesis. This is the final OPG of the patient. You can appreciate these are the tilted implants with multi-unit abutment to correct the angulation. These are again your straight implants. These are all freehand surgeries which I am showing you. One of the cases which I showed you of maxillary arch of zirconia, that was guided. Rest all these are freehand surgeries. Okay, again this is a case, again it was a compromised ridge. Lower arch open tray impression, jig trial. This is the final process of the patient. Final OPG, you can see, you have tilted. We have done the tilt, all in 4 with 2 small implants. See, I told you, I try to place a more number of implants to avoid cantilever as much as possible. So this is like all in 4 with 2 short implants, so that there is hardly any cantilever on this side. This is again this is a very interesting case. This patient had a knife edge ridge, very thin ridge in the maxilla. So patient was not that much financially sound also. So in the lower arch, there was severe bone resorption was there. So in the lower arch, we had planned for a overdenture, 3 implants supported overdenture, and upper we had planned for, again with the help of tilted implants, we had planned for a screw retained prosthesis. In the upper, because it was a knife edge ridge, so we had gone for a palatal implant placement. That is very important in the maxillary anterior. That you are always supposed to place your implants on the palatal side of the bone. Means on palatally, you are supposed to place the implant palatally, so that you get at least around 1.8 to 2 mm buccal bone. Because that much bone is required on the buccal side in the maxillary anterior region, which will not resorb. If the width of the bone is less than 2 mm buccally in the maxillary anterior region, then it will keep on resorbing apically. So you always place your implants palatally in the maxillary anterior region. So again, as you can see, we have placed 5 implants. Again, this is a tilted implant just near the sinus. because you want to increase your AP spread, anterior posterior spread of the process as much as possible, so that you can decrease the length of the cantilever as much as possible. So again, we have tilted these two implants and we were able to place the three implants in between. Again, we have used multi-unit abutments. This is a 45-degree multi-unit abutment to correct the angle of the implant. This is again, I told you before also, we are planning to give it three implants supported with a ball and socket attachment, a overdenture. So this is the intraoral pic of the patient. This is the multi-unit abutment. 1, 2, 3, 4, 5 multi-unit abutments have been used. And you can appreciate here that I place my implants palatally. You can see this is the soft tissue on the buccal aspect. All my implants, you can see here also, are placed buccally. So this is the final processes of the patient. This is with DMLS bar with composite teeth. If your crown height space means the interarch space is too high, like it is beyond 14 to 15 mm, and you want to give a fixed prosthesis, so then you have to go for something of a lighter material. Then you cannot give a PFM or zirconia because it becomes very heavy and they get lot of technical errors also. So then you have to go for something lighter processes, like a bar-based process, like a polymolo bridge or a titanium bar, or you can get a castable bar also. But castable bar again have lot of technical deficiencies. So nowadays it is not used anymore. I want to say it is like a more like a obsolete technique, because now you get a better processes and they are not that much costly also. So you can go for a DMLS bar, or you can go for the best is the titanium bar. If you can go for a mill titanium bar, that there's nothing better than that, because it is the strongest possible processes and it is very light also. So that is the best. So this is again a DMLS bar. This is a DMLS bar, not the mill titanium bar. DMLS bar with the composite teeth. These lab people also use a lot of composites. So this is very light in weight. Now you can appreciate very well how palatally my implants are placed. You can see now all 5 implants are palatally placed. So this is again, you can see now, this is not a PFM. This is a metal bar, DMLS bar with a composite teeth. That is why it is radiolucent. Okay. So lower we have given a overdenture of the patient. Oh, this is sorry, this my assistant did a mix up of this. Okay, this is that slide I told you. No, I'd play this. I was showing a case in the beginning which has a severe resorption. So this is the final radiograph of that patient. So I placed 2 multi-unit abutment, and now we are given the final prosthesis, PFM prosthesis. This is the final process of the patient with 6 months follow-up. We were able to give him teeth till 8, 6, 7, 8. Palatal placement. You can see palatal placement. Okay, skip the sinus lift and place tilted implants. One pterygoid and one anterior tilted implant. Again, full arch case. You can see this is all in 4 with 2 short implants placed. So it is like all in 6. But because of the tilt, I am skipping bilateral sinus lift, and I am also able to place long implants. Lower, because sufficient amount of bone is there. So I went ahead and placed 6 axial implants. So again, with the help of multi-unit abutment, you have to correct the angulation. This is the final smile of the patient. This is the final process of the patient, PFM, PFM. And this is the final X-ray of the patient, screw retained processes, final smile of the patient. This is again one of the interesting cases. I showed you, we went ahead and did the immediate extraction. You can see the extraction socket. Immediate extraction was done here. And then we are engaging the pterygoid. We are trying to place a pterygoid implant. This is your lens drill. This is your pterygoid implant. And now I will try to tilt here. I will place a tilted implant here, skipping this root. And this is your sinus lining in between here. So now you are drilling. This is your paralleling guide. You are analyzing everything on the IOPA. And this is your final tilted implant. Again, 16 mm. This is, I think, so it is 18 mm. And this is your mill titanium. Again, the crown height space was very high. So we went ahead with the lighter processes. Again, this is a mill titanium. anodized bar. That is why it is golden in color with composite teeth. I told you it is lighter in weight and very strong because this is milled titanium and there is no technical accuracy. Sorry, my mistake. I said there is no technical inaccuracy. It is 100% correct because this is made by milling process. It is not made by casting process. So this is a milled titanium with composite teeth, screw retained processes. Okay. You're always supposed to give a convex intaglio surface so that there is no food lodgement. Again, this is on, we did it digitally with the help of a scanner. So this is on the model. And okay. So this is that case. So this is one of the, again, interesting cases. Okay. When I show this case, I mostly tell people do not try at home because this case something I tried new. This case again was severely compromised. This case was done at the again at one of the consultation practice I did. So just a second. Yeah, sorry, some. Yeah, so one pterygoid implant here, and this is where I give the tilt. So here what I did, I went in the apical region of the root of the premolar and trying to engage the lateral wall of the nose. This is 22 millimeter long implant. This is 22 millimeter long implant. Okay. Patient did not have any problem in the adjacent tooth in the follow-up, no sensitivity, nothing. Okay. Again, we have placed a multi-unit abutment of 45 degree to correct the angulation. This is the posterior pterygoid implant. This is the final screw retained DMLS process. See, no cantilever. There's no cantilever, not even single cantilever. This is, you can see now, you can appreciate better in this final OPG. This is the sinus lining. It is just going near the adjacent to the sinus lining and engaging the lateral wall of the nose. So again, you get a bicortical engagement. This is lower side is a Ravana bridge. This is a failed processes. So I was called just to do this one. So obviously I told the dentist there that this should also be done. This is something very awkward. Again, a few more cases just to show the tilt. Again, tilted implant here. You are engaging the sinus lining. Again, bicortical engagement. This is again milled titanium bar because the crown height space was very high. So again, milled titanium bar with a composite teeth. Milled titanium bar with a composite teeth. This is the bar. This is a milled titanium bar. Same patient on the right side. Again, we are placing the pterygoid implant. This is the pterygoid implant of 16 mm. This is the anterior implant with a multi-unit abutment. And this is your palatal nasal implants. So these are three implants, 1, 2, and the anterior one. This is the final prosthesis. Again, this is again DMLS bar. This is not milled bar. This is DMLS bar with composite teeth. You can see this is the DMLS bar with a composite teeth. This is again screw retained prosthesis with a composite teeth because the crown height space was quite high. Again, one more case of the lower arch. This is all on 4, and we are able to place one more short implant. I told you I try to lessen my cantilever as much as possible. So again, all in 4. So this is around 16 mm. These are 16 mm implants, and these two are 18 mm length. So this is again the final processes of the patient, screw retained prosthesis. Only this much cantilever is there, but on the left side there is no cantilever. So this is the final process, final processes, final OPG of the patient, screw retained PFM on tilted implants. These are the multi-unit abutments. Correct the angulation. Again, one of the interesting cases. This is a grossly decayed 2-6. You can see there is periapical abscess also 2-6. There is almost breakage of the sinus lining. 2-7 also is grossly decayed, periapical radiolucency. So again, we had planned immediate extraction followed by palatonasal implant and one pterygoid implant. This is a palatonasal implant. This is a pterygoid implant. This is the cast of the patient. This is again milled titanium bar with composite teeth. This is the final process of the patient, pterygoid implant, and this is your palatonasal implant. This is the prosthesis of the patient. One more anterior case. This is again a full arch case which I did at consultation. I have to go a little bit faster. Sorry, apologies for that because I have a lot of cases. So I want as many as cases as possible. So this is again full arch case, upper and lower processes. Both are screw retained. So this is the final OPG. You can appreciate this is around 50-degree tilt. We're skipping the sinus lining here. This is just adjacent to the sinus. And this is again all in 4 2 tilted implant. And here I was able to place one short implant. So I told you to lessen my cantilever. I try to place shortened implants in the posterior aspect. Okay. Both are screw retained on multi-unit abutment. DMLS, PFM. DMLS, PFM. Just a second. So I guess I finished on time. So thank you so much. Yeah, I cope up.
Yes.
I finished my time exactly in the same session, in the same time limit.
Yeah, yeah. No, you have summed up and very nice presentations. So means Dr. Rohit, what are means the challenge means you faced actually in the prognosis of this tilted implant means because there might be biomechanical problem or peri-implant bone stress etc. So means so
The
have you
main thing is that with tilted implantology is that whenever you're planning to do a tilted implantology, then try to place as many implants as possible.
because this is a
Because
highly skilled job actually, yes.
no, but no, no but if you start practicing it, it becomes with the help of IOTA. See, obviously nowadays you have guided surgery. That is a great helping tool. But let me be very practical also. Not keeping the finance aside, let us not talk about the finance side. Availability is also a difficult issue for non-metro places. Like I practice in Gwalior. So if I want to do a guided surgery, I do guided surgery also. Then I have to counsel the patient that he has to wait for so much amount of time because CBCT is available here. But the guide will come by transportation from logistics. That will also take time.
Yes, of
So
course.
all those things takes time. So that is one issue is there. Okay, then in the guided thing, as I told you, everything is a learning curve. So with guided surgery, I do guided surgery also. With guided surgery is also is a learning curve because the person who is designing the guide on the other side and other side of the table, he and you should be on the same page. So that is there. Otherwise, if you're doing a freehand surgery with tilted implant, like this thing only, if I tell you this thing only, in this case only, if you're tilting and you are skipping your sinus lining, you can do chair side with the help of a IOPA. Keep on drilling and keep on analyzing on the spot with the help of IOPA. Take 8 IOPA, 10 IOPA. That is the best, like it is like real-time imaging. You are drilling and you are analyzing where your bar is going and where is your sinus lining is coming. So keep on analyzing. So I take multiple IOPs. There is no harm in taking an IOPA. Don't hesitate on that part. I will not take IOPA and all those things. And sometimes you become overconfident. Then that is a different thing. Otherwise, if you are taking an IOPA, IOPA can help you a lot. And in the lower arch, when you're doing a lower arch for the all and four, if you're not doing a guided surgery, then you are supposed to raise the full flap. That is the disadvantage. Obviously, it becomes more invasive because then you are supposed to analyze your mental nerve. You have to see them clinically
Clinical, yes, of course.
because you have to keep in mind that this mental foramen is there and you have to have a safety protocol of 5 mm because that loop is there.
Yes.
So you have to be anterior to that 5 mm.
You
So you cannot take a chance here if you are doing a freehand surgery. So you have to raise the flap. That is there. That invasiveness will be there. Otherwise, you have to go for guided surgery. There's no other option than that way. But IOP is a great help.
yes. So anybody want to ask any question related to tilted implant? The very nice. I mean, so the cases
Thank you.
which
Thank
I have seen
you.
is great and good. I mean, the tilted implant is giving Let's say that the constraint in smaller cities and all, you are doing this. You are
How?
based in Gwalior.
Yeah, I'm in Gwalior, Madhya Pradesh, and I do consultation in multiple other cities also. Like I go to Jhansi, Agra, and all those things, where there is no CBCT also.
Mm.
We get hardly OPGs there. So there though we cannot do only if guided and all those things, because otherwise it will take 1 or 2 months.
Of course.
I'm not discouraging anything, but I'm saying it is there. But the problem is that the availability, and patient does not want to wait. That is also one more thing. Practically also you have to see patient does not want to wait. Ki sir, you will start after 1 or 2 months.
You have to retain the patient
Yeah,
satisfaction.
that and the end of the story is that that we all are in private practice. The patient should be there. Then only we are able to place implants. If patient is not there, so there is no implantology.
We need patient to place implant.
Yes. Whether axial or tilted or whether guided, whatever you want to do, patient has to be there. So.
Okay. So with permission of Dr. Rohit, should we move to the next speaker? We are in a hurry so that we
Yeah, please. Thank you. Thank you so much.
Thanks a lot for giving your precious time and
Yeah. It was a great pleasure.
wonderful
Thank you.
faces and yeah.
Thank you.
So we are moving to our next speaker, Dr. Mahendra Patat. Dr. Mahendra, are you there?
Yes, very well. Am I audible?
Yeah, you are audible.
Yeah.
So let me introduce you formally.
Yeah.
And I have made you co-host, so you can able to share your slide as well. So it is my great honor and a privilege that I introduce Dr. Mahendra Patet, an esteemed oral diagnostician, distinguished maxillofacial radiologist, and extremely research in field of healthcare and science. Dr. Patet he has unwavering commitment to advancing dental science and his dedication to fostering groundbreaking research. Dr. Patat began his academic journey by completing his bachelor degree at the prestigious Government College, Mumbai. There are other speakers who are from the same college. Then he did his graduation in 2020, and then academic advancement with a PhD in dental science. This thirst for knowledge led him to undertake a specialized training, earning a fellow in Cornbone City with the London Academy of Dentistry, UK. Additionally, he holds an MBA in Hospital Management and Digital Health from the esteemed Empirical College of London, along with certification in clinical research and diploma in artificial intelligence and augmented reality. As a Pacific researcher, Patet holds 5 patents, 6 published books, more than 30 IPR copyright, and has contributed over 52 articles at 2 national and international journals. His research encompasses a diverse range of pioneering topics, including application of 3D vision using Cornbone CT, then groundbreaking contribution to diagnostic technology and clinical treatment. Dr. Patat's outstanding contribution has been recognized through numerous accolades, including Most Proactive Academician for the year 2015 by Guidance Delhi and the Research Excellence Award 2020. Dr. Mahendra Patet's multifaceted career as a researcher, educator, academician, and clinician serves as a true inspiration. His relevant commitment to advancing research and continuous pursuit of innovation has solidified his position as a leading figure in the field of dentistry. Please join me with welcoming Dr. Patat. Your slides are visible and you are audible, so you can start your presentation. Though we are some say 38 minutes late, but which happens in some technical glitch happens. That's why. So over to you, Dr. Mahendra, for your talk on leveraging AI tools for enhancing academic research, scientific exploration. Over to you.
Yeah, thank you so much, Doctor. Actually, I can say that whatever the clinicians and listeners are listening on their aspects, as far as clinical implementation of the ideas, let's take it to another level. Research and implementations of the clinical practices at different level by getting them as an acceptance at the researcher or global level by publishing as a paper. No doubt, this is not a cup of tea for everyone to publish the paper at their innovative ideas or their clinical research, but it is a definitely a handhold where the things will be worked out at globally. when you are presenting your cases or papers at a different level. So I'm just trying to make it more smoothly for what the research is and how we can work out on these aspects. So this is my suggestion, that if you are having some ideas of the research to be published, go ahead with this certain small AI tool which will help you in writing your ideas, which will convert it into a text and as an paper for the publication at different level. So coming to this, some definitions, what we always taken care of that ideas where the things should be worked out from our sides as some definition, because when it comes to the research, it's an been idea where how to go ahead with these. That is what the most of the times people are thinking of. But try to understand some definition on these aspects, so it will be easy for us to understand the detailing of the ideas, where you can work out on the things more clearly. The moment from the known to unknown, that is the one basic things that we should understand, where you are searching the knowledge. And as a definition, it is a systematic and scientific search for the pertaining and relevant information on the certain topics. So what you know, that is the known, but searching from something unknown, that is what the research is generally labeled. I'm just trying to make it a little more simple. As a definition part, the research is seeing what everybody else has seen and thinking what nobody has thought of. So this is just the simply Albert Einstein the definition, where you can suppose to see what the research is in search of something which has already been known with the advances. As a part of the types of the research, we do agree that there are different ways how to go ahead with that. So I just simply classified that research in a three aspects. That is application of the research of a particular study, then objectives of what you are doing as a clinical practice, or inquiry mode employed, where the you are doing in the detailing, finding the inquiry of your problem, where the sorted out the problem will be published in a direction. When it comes to the applications, there are very basic two things are available. That is a pure research and applied research. Depending on the perspective of these application, we can make categorize that. Something which is a pure and something which is a applied. So when it comes to the pure research, it's just the developing and testing the theories, and whatever the hypotheses are there which are intellectually challenging to the research. That means that something is hypothesized and which has already been testing theories are available, so you are going ahead with that, analyzing that how much it has been correctly quoted. That means it doesn't have the practical application as per now on the theory, but this involves the hypothesis which containing the abstract and specialized concept. That means you are trying testing the concept what hypothesis is having. So whatever the pure research is there, that is just in getting the knowledge and applications of that for the futurist idea. Then second comes with the applied. That applied research is undertaken as a social science, that is finding design to undertake the phenomenon, issues, changing the program or the situations. So these are just applicable at that situation. Second type of the research is objectives, and that carries the four objectives. That is the four types are available. That is a descriptive, correlation, explanatory, and exploratory. If you try to analyze these simple words, we'll go by one. Descriptive, you are trying to describe something which is at present. So describe what is prevalent and respect to the issue and the problem under the study. So whatever the study is there or issue is there, you are just trying to describe. And the descriptive research, there is no control over the variable. That means it is just the observer for that, the researcher, and he can only report the things what is happening. That means it is the after fact areas which describes mainly the social science and business research. So when it comes to that attitude of the students toward the quality teaching, this is the descriptive part. Then strategies put in place by the company to increase the workers' productivity. You are describing as a third person these ideas. Then the effect of living in a house with domestic violence. So description is a state of affair as it is exist at present. So you are just explaining what is that. Forget about the solution and problem on that, but you are describing it. This is the descriptive research. Second one is correlational. That means there is something discovering or establishing in existence of the relation or of association or interdependent between maybe two or more aspect of the situation. That is the effect of home environment on the education. A simplest example. So this is something you are trying to get it ideas. That means the relationship between the stressful living and incident of heart attack. Then the impact of technology on the language or impact of domestic violence on the adolescents. That means these are two, three areas where we are trying to analyze with each other. Third is explanatory. This is a simply attempt to clarify why and how there is a relation between the two aspects of a situation or a phenomenon. Here, not the one situation, but there are the two situation or phenomenon which try to explain how the home environment affect the children level of the academic achievement. That means here is not the environmental effect on the children or children's academic achievements due to environment, but you are just trying to explanatory format of that, how they are with each other. One more example, that how does the domestic violence impact the adolescents learner? Why do some schools adapt a program while others do not? Why does technology is facilitating learning? That means this is the multiple areas are involved which are trying to compare with each other by description and deriving that. The fourth type is exploratory. That means something is already been undertaken with the objectives or area are little known. You are trying to explore that area. That means to investigate the possibilities of undertaking a particular research study. This research has come to this level and you are going to explore that. Paracetamol orally is taken. Can we give it IV? Can we give it in a different way? So this is exploring that already been something has been researched. So these are the simply carried out, determine the feasibility, and you can have the feasibility with the pilot study because we already know this is something is research. So if we are taking that exploratory format, then you can go ahead with that. And third type is the inquiry mode, where the patient is yet inquiry by the qualitative and quantitative analysis. That is a structured approach that is quantity wise, and the unstructured approach that is quality wise. That quantity, when it comes to the quantity, it should be supported with some numerical format to quantify that. And quality, that will be depend on how much best things we can do out of the worst things. So first is the structured research, which is a quantitative research. That quantity studies often use the measures, values, sample size, and analyze the data with a statistical program. Obviously, we must be knowing that something numerical values are coming that needs to be analyzed with statistical program. Then a study classified as quantitative. If a researcher seeks to quantify the variation phenomenon and if the information is gathered using the quantitative variables, that means if the quantitative variables are there, you are numerizing that, you are comparing that, and the researcher trying to quantify that. That means the quantity of that areas can be modified. For that matter, also this can be taken care of. And second is the structured approach, where the inquiry is usually classified as a qualitative when the purpose is primarily to describe a situation, a phenomenon, a problem, where the information is gathered through the use of variables or measure on the qualitative measure scale. And if the analysis is done, they establish the variation in situation or problem without quantifying it. That means you are not going to quantify that, you are just going to in-depth knowledge of that particular area, focusing on a small population and probing and trying to get the deeper into give the problem. Simple example, COVID. You go in depth, focusing the population in the recent smaller area, trying to get the decent problem, and then you can implement whatever the area that has been focused on. So this is the way that we are trying to analyze the research. So in short, from the viewpoint of view, when applications are there, either pure or applied, you analyze the hypothesis, or you can go ahead in the applied format, or you can have the objectives which can be described in format. We can exploratory or correlational finding, or can be explanatory findings. Then again, how you are going to sort out the information? Is it a qualitative mind or quantitative mind way? So that is the way we are doing the questions. And again, of course, the quality of the reviewed research will be depend on the research of collecting, analyzing, and interpreting data. And certain facts are need to be taken. It should be logical, rigorous, systematic, valid, and verifiable. So it has to be taken in this aspect. When LRSB is taken care of, it will a good research where the quality of the research will be taken care of. And of course, the empirical way, it has to be taken care at the different level globally with the publication in the areas. So when we are doing any clinical areas or having some concepts which will be useful for the community way, better to go ahead with the publication for the new researchers with that will be implemented seamlessly to the ideas. There are a basic 8 step I would like to describe when you are going for this research purpose. The first step is formulation the problem, what exactly problem is there. Then conceptualize the design, what type of the research you are doing. Then clear data, select the sample and start writing the proposal. That means whatever the problems are there, ideas are there, there should be some research problem formulation. First step, formulating, design it. Third is try to collect the data, select the sample from your label, and then start the aspect of the research proposal. Meanwhile, you go for mean and methods. So this is the base where the 5 steps first will be taken care of. And the next 3 steps are something called collecting the data, processing the data, and writing the research report. When everything is in hand, you can go ahead with the publications and describing these particular conceptual areas or problem in this way. So we can always have the acceptance for these, and we are able to go ahead with that. So what is the use of these different areas? When you percolate to different types of the areas of the research, you take a care of these 8 steps, then you can have the always option how you are going ahead with the publications. So this is the simplest way. Either you can publish it as a research paper, you can publish it as a review paper, you can publish it as in a survey paper, or just deal with the simply case study. Definition wise, if you go ahead with that, this is not what we know routinely. So when it comes to the research paper, it is a new findings, contribute the new knowledge. It is obviously experimental, observational, computationals. Either it will be have the primary or secondary data. It is more narrow. For example, a novel deep learning model for the image classification. This is a research paper where the original ideas is taken care as in paper publications. When it comes to the review paper, which summarize and synthesize the existing literature, provide the overview of the knowledge, search of the literature in detail, analyze it, secondary data, try to check it out, broad covering area and many studies as a scope. And for example, a review of mechanical learning in the healthcare. You are just reviewing that what exactly is there, so you can go ahead with the same addition of the research. Survey paper, a particular problem is analyzed by gathering the data of the large areas, identify the patterns, then you can have the design, distribution, and survey data analysis. And primary data is responsible for that, having a wide scope of that. These are nothing but your survey type. Before starting anything or before going ahead, the survey of air adaptation in a small business. So this will be your research problem, which you are going to exploit it in the research formulations. Then there is something called as a case study. That means the details of this case study will be taken care of when we having the detail of the single case will be synchronized very well in this. Explore the understanding of complex issue, in-depth qualitative or obviously quantitative, or maybe the mixed analysis will be done. Primary data in depth will be taken care of, and it will be discussed narrowly and focusing on the specific case. So that is the scope of this. So case study is nothing but the some particular case will be discussed is different agendas from diagnostic part to the treatment option in depth will be described. Example is a case study of implementation in a hospital. How we are going to implement that. So these are the different ways or types where you can go ahead with recognizing what type of the research paper you are going to explain. So title, then generate the abstract, go for the graphical abstract if that, go in detail of writing the main content, conflict of interest has to be elaborated, ethical approval, author's contribution, acknowledgement who are involved in that, then go for the data availability, require the funding, write down that with the references, if supplementary files like figures or tables are there, go ahead with that. If idea is novel, quite known, go for the permission of that particular permitted areas or copyright that areas, then go for the in public availability by writing the covering letter to the journal. So this is the simplest way of explaining what practically we are doing, and we can go ahead with these ideas. But when it comes to the conceptualizing this and writing this, how you are going to write that, whatever the is there in mind and clinical implementation is there, how you are going to utilize that in, because we are not very much good in writing always or demonstrating that in the text. So the presentation are communications, as you know, these are just the tools where you can have that ideas to be present. So these are the tool I'm trying to show you, which will be convincing in a particular teaching also for the academic researcher and students. You can analyze the data, accelerate your research, you can have the explanation, insights, and a deeper understanding of the research article. So when you're thinking of to solve some problem as a research problem, you need to know what exactly is that. So we are going to search on the different ideas, different papers online with the Google Scholars or in the libraries also ideas taken care of. But it needs to be synchronized. It needs to be understand how this paper has been published and what is the core behind that. So we should have certain tools which explains you within a fraction where you need to know whatever the PDF is available, what is there in the PDF. Can we summarize that within a fraction of figure? Do we have some tool which highlight the text where the explanation and gap analysis will be done in that? Is there any tool which give the uploading the documents and just clearly exploring the understanding the content? You don't have the time to read that everything because you are working with a lot of things. Then we have the some tools where you can align the literature review, simplify the process, and you can just summarize very effectively whatever the research proposal is there. Some tools are there which provide the free paraphrasing service. Just simply rephrase that as the academic and professional being humanizations as not an AI tool. And given the something as spinning the text, replacing the words, you want to change the meaning in that, which has synonymous words in that, and review of the literature can be elaborated in their own language. Some tools are there which answer the query. You can find the relevant article to that and give the quick access of the information. And some tools that you can say the summarize the ideas, whatever the already been elaborated, concise in format, and explain that very much quickly. So I'll just go one by one. Where that is one is something called, as you must be knowing, that chatdoc.com. So this is chatdot, which will be having the implementation that it can be explain the things more clearly, and you can have the options of availability of these where you can explain the ideas more clearly when it comes to express the things more clearly as far as AI intelligence, and it responds very conventional matter. So you can just go ahead with implementation of that where the text or voice can be given and it will integrate with the online availability and voice areas. And you can give the ideas of describing this very clearly and what exactly you are trying to elaborate the things. And for academician, it's a virtual teaching assessment. And for student, it is the instant feedback, whether the queries are asked. So it is more, or you can say interactive learning module for the individual learning process, and is not only enhance the student engagement but also allow the more complex problem to be taken at in a very simple way. So formulating the data, manage the literature, handle the administrative tasks, then the dissemination of the research finding, generating the report, summarize the things, whatever the academic efforts are there, that will be synchronized in the right direction. So this is the way as it simply explain that when you're taking care of this, go and check it out how the chat board is there. I just chatdoc.com is there. So this chat doc, we can just go with the Googles and check it out which different documents are there. It's one or two topics I will just show you nicely, and you can have the options available. So this is chat GPT format, again ahead with the different forum. So you can just take it out whatever the folders you want to check it out. So there are maybe one research article you are having, you started with some problem and you got one online article. So you can just take that article and you just wanted to know, oh, this is similar to my research, so can I get some guideline on that? So just take a download of that particular article, preserve with you, and you can take that particular PDF file in your particular this chat doc areas. And this, see, within a fraction that particular PDF is getting downloaded on one side, and whatever there in this particular article, you can make it out. There are almost 10, 12 pages are there, but you may not have that much of time to read. So what this particular area of the chat area contain, so this is the something like walking on the cake of peace, where it will explain you what exactly is this. So when you come to this, ask me anything about the document, you can ask any question to these documents, what is this article is all about. So they'll just explain you what exactly this is the areas, and they will try to explain you what exactly this article is. So it will just start writing, this article is about the study in Pakistan, where the mathematical achievements of this particular study has been done, and these things. But if you don't want to know that, you just make it more shorter. You can just check it out that what exactly this abstract and this. Now idea is clear. Now this is something article is about that, and you want to know, okay, how much is the sample size for this. So now questions are more deepening. You are narrowing your thought. The sample size of studies 14,440 students of the 770 schools. So if something you are working out of that, you will get the ideas also. Then what is the methods or what is the methodology has been used? So this was your next question to this particular doc. So they will explain you what exactly this methodology is. This is the involvement, the survey, conducting type of survey of this area, this many, these achievements is there. So they will conceptually explains you what this methodology is there, and from where that particular pages they are explaining. Then if you still feel like what are the few findings about this, you want to know about this, don't have the time to read, just reading the headlines, you can able to understand that this is the something where the middle age students has been taken. These are the explained review of the general gap or gender gap in this area. So this is extremely cake walking areas, or cake walk on the cake is there, and you can get the background, variability, contribution factor, instruction, provision of resources, learning aids in the school. So whatever the actual groundwork has been done by the researcher, which is summarized and synchronized, and that is in front of you. So this is a beauty where you can check the summary of the hundreds of the article, and you can make it out from where it has been taken. Give you the reference of that particular article also. You can see there are 8-9 pages from where it has been synchronized. So it is not something searching online and giving you the idea. It is searching this particular article and explaining you the things, how they are going ahead with this particular format and how they are trying to elaborate the things. So this is the best way to check it out of any article, how you are going to go ahead with this article. Second is explain the paper. This is something where moreover explaining the areas where the clear and concise explanation of the specific section has been taken care of. So when I want to analyze the paper, I'm using the one ideas. When I'm trying to analyze the things, explain the paper. This is the academician research which will have that ideas where you can just explain the paper more correctly, go the ideas of the detail, check it out the things, read the research paper. It is completely free of cost. Click that ideas, get the concepts, and you can go ahead with whatever the concepts you want to clarify from this paper. So this is again a simplest way to analyze this. Then next comes something called as this particular page has been explained. Then we can go ahead with the next pages where you can make it out the ideas as a third app. That is something called as a humatia.com. This is something I really love because preparing the lecture and course material, this really helped me as a scientific background and healthcare research. So when it comes to the ideas, when it comes to the humata, so I just check it out these particular presentations where the humata is how we are going to explain to us. So the things are going ahead in a simplest way when they are explaining in a right directions, where the concepts are getting more clear when the things we are moving ahead. I think this things is not getting connected, but humata is something where you can explain the ideas more clearly and get the guidelines of the any research paper in a scientific way. Well, healthcare way can be taken care of very nicely. Then fourth is something called elicit.com. So this is something AI driven research area where the streamline the research process. That means already your idea is there. So literature review, data extraction, and hypothesis is generated very intellectually. So this is enhance the quickly the process of the research, and the researchers can identify the gap of the existing research, and you can definitely go ahead by generating the news ideas. So this is as simple as it is hand holding by a one simple task which will explains you how you are going ahead with the something which is has to be seen. So where illicit, when you go ahead with this particular area, she explain the research assistant as a research assistant. You can ask any questions to this, what exactly you are finding. And you can amaze to show that more than 1,175 millions of the papers are there. So whatever the research or research problem is there locally in your area, you can just make it out. Okay, what is the this contribution factor? Some of the areas of this. If you have your any research problem, you just put down that research problem here. It will help you in finding out what similar work has been done in the world. You just go ahead with the scrutinizing these papers and taking the abstract summary of the particular title, whatever the intervention of the particular paper is there. You can go ahead with the intervention and the outcome of that, any research gap in this particular area. Just have the filter PDF of that. You can filter with the ideas, with the areas of involvement, type of areas involvement, type of studies in there, how they are having the characteristics of this particular research paper. So you just ask it what there exactly is there at pertaining to your own research paper. So they will summarize that. That particular one abstract will be summarized in a one line. So that is, don't you think it is quite amazing to know that the summary, when it comes to contributing factor, that particular research paper, it will explain you the top 4 papers are like this, and these are giving the information of these. So this paper title is giving this abstract summary. This paper is working out of this area. This is having the this summary. This paper is, so we are just trying to analyze what inventions are there, what are the participants are there, what are the sample sizes there, or how many areas are involved, how many hypothesis has been clubbed in, how many research point of views are there. So all these are there in front of you with the short detailing of the journal, what is the indexing of the journal, what are the outcome measures. So this is the beauty of this particular set, which elicits you in the detailing of the whatever the research papers or research problem you are coming up. So it is as good as having the hand holding by the assistant researcher, which will help you in defining that. So this is something which I try to check it out where the artificial intelligence are there. I just try to check it out that with my ideas and my concepts, where these four research tools are really helpful for us in summarizing, analyzing, quantifying, and making a new landscape in that. The fifth one is a word tuner. This is word tuner read is something is insight quickly and explains you the detail in a very short time. So this is more, you can say, more of the stronger way of explaining. Just upload the PDF and it will explain the ideas. If you have the just the link is there or particular data is there, you just label that and you can able to analyze that particular file taken in this area, and it will just take the cursor on that and it will explain you what exactly it is this. So it will start talking to you whatever the summarical format and not format are generated. It will explain you, it will start talking to you. The cursor has been taken and it start explaining, and along with that it will give the references also. So this line has been taken from this idea and this is having the these references. If you want to elaborate that, that can be elaborated with these. You can do the copy pasting, you can do the refreshing, you can add that areas as per your research paper area. You can generate the new paper with implementation this idea. You can refresh that, you can add that, you can make in your own level of the literature on this. So this is the beauty where you can go ahead with this tuning your word areas. This is word tune reader. So you can upload that, see the details, whatever the PDFs are there, you can go ahead with this. Next, you are having the sixth one is Quill Bolt. This is now an additional for your Google Chrome also. It refine the manuscript, research paper, and for the academic content more precisely. So summarization, grammar corrections. So it will be a routinely what we are not that much keen on understanding that what is the clarity and coherence of the lecture or material or publications. I mean, this is the vast area is there. You just have the look at this which the Quillbolt is providing you. Paraphrasing is there, increase the fluency of that. Grammar checking is there. Again, the plagiarism is one part of the research which can be taken easily. Summarize it, citation is generated, translation is required. If you want to flow, it will help you in writing the flow also. So this is the things where the Quillbolt is really working out on that very fastly. Just check it out this. You take the areas, you can have the standard fluency, formal English, simple English, you can create that, you can expand that, you can shorten that area. So whatever you're writing and creating that has the everything in that. You can make the individual word selections and go for synonymous word with that. You can have the meaning of that each and every word to understand and make it more simplified. So this is the paraphrasing beauty where your research paper will be totally new with these ideas. Then the next is something called a spin board. It is also having the similar finding, but it is more a creative. It replaced by immediately and plagiarism free areas are generated. So this is the spin board, which I love really when the introduction part and discussion parts are there because it synchronized very well in this particular quill board. So when it comes to the in picture, you just take it out that spin bolt in these ideas, go ahead with this, whatever the word contents are there, that basic spin is there. You can just rewrite that as the free online link. Grammar check will be there and it is readily available with you. So go ahead with that. So once it was more than 732, it changes the 32 words for you and word count is taken care of. So this is one of the requirement of any researcher to put it in the right wording for the limitation of the word. So this is the article where the spin bolt is really helping us out. Then there is something called as a chat GPT, what we already know, but there is something called as chat GPT or GPT minus one. That means chat GPT is doing what you are wanted to know, and GPT minus one is giving you the other aspect. Someone is positive chat GPT. So GPT minus one is particularly making the complex area more accessible. It will rewrite it and in a clear and more correct manner. When the chat GPT is trying to analyze, that is more a robotic way. So submit your randomly replacing the word and just word has to be placed in this area. These areas words will be getting highlight, which are taking, just make it a, whatever the format is there, copy that format, put that in here. This paper is that, submit that, and you will come to know that these are the highlighting points which we need has been replaced or we need to change that. So this is the particular point, look into the accomplishment. So these are the beauty where it has been by himself has done the corrections and explain you this idea. Now it is your choice whether he has to accept this or again rewriting or paraphrasing this. So this is the one of the things what I love about this GPT minus one, which is going ahead with this chat GPT where the minus things can be taken care of. Then we have the next one, Ninth tool is ChatGPT, which already almost everybody is using. But make sure that what you want to know from this robotic or with intelligence, that your human intelligence is really mind-blowing when you are having the use of the generative AI with this taking care of the artificial intelligence. So I will not go in detail about that, what exactly is doing. And then last is paper digest one. So this is a unique feature where a tool which is plagiarism, expert evaluation, and enhance the legal quality all in one. So you don't have to go by one paper tools, but it is just the explaining the things more clearly. When you want to do the paraphrasing also, grammar corrections also. So that means whatever the areas you are giving, it will digest and the sample will be come out as a more beauty for you. And it is going ahead with the areas where you try to explain the things more clearly. So the ideas are elaborated in a more concise and elaborative format, and it will be more of the you can say corrective format where you don't have to work much on the ideas or language area, and you will able to digest that paper online and will scrutinize that what exactly outcome you will be having. So just short summary with explaining highlight points, that paper will be digested nicely and it will be explored and explained to you. So these are the things which come across, that these are the simple tools where the chat doc, which explains you the summarize the things, explain the paper, highlight it and taken care of, humanize something having the broad base of scientific and healthcare, elicit explains it, wonder tuner rate, word tuning and word count will be taken care of. Pillbolt and Spinbolt is definitely helpful when it has the research analysis with summarization and expert comments is mandatory. GPT minus is compared with Chat GPT. Paper Digest explain the site feast will be help in the citations of the areas of the particular point are there. So these are the simplest term what I came across in explaining the particular things. So others are also available. Maybe some of you know Grammarly, that Highway Editor or Zotero. These are the very famous in now postgraduate students. That is having the free available Zotero and Deep L Lighting. Then these are the things where you can go ahead with this. And when artificial and natural intelligence are struggling, there is in between from idea spark to high impact research. There is a AI where you have the basic platform. You can have your own platform where the efficiency, creativity, and depth of the scholarly output has been taken care of. Put your ideas, let the handholding of the scientists of the Nobel workers, and they will help you in the guiding these concepts more clearly. So this is something where the research paper is explained in on your own platform, where the organization, refreshing, meticulous, adherent to the actual sciences. So this is the ideas of learning center, the research methodology, your own critical thinking, and artificial implementation, artificial intelligence implementation will be there on that your own dashboard of your own findings, where the research thinking, review, problem, variables, hypothesis, research design, that everything will be of your own. As you are a researcher, this particular database is available for you, and you are synchronizing that with the internal and external areas, and you can modify these areas. So this is for your own server as an researcher. You don't have to rely on the different ideas or conceptualization. That so many things will be there. They have the different steps in that. Once you purchase in that, that is nothing but your Indian knowledge system, where the interdisciplinary research and the new futuristic research will be developed. Once you understand what research and how you are going to use these different steps, and it will be easy for you to make sure that the things will be worked out on your direction when the ideas are more clear with these spark to high impact research is available. When you do the research, these are the funding Ministry of Government of India under the able leadership guidance of our Prime Minister. These are the things available where you can get a lot of funds in working out on that. Because being a healthcare professional, we are just giving the service, but whatever the service are taking care at the different level, it's not the research, and research has the funding. So these are the different funding agencies available. You can approach them government wise, and these are the different startups where the different areas funding support will be taken care of. BIRAC instrumentations are the info, electronics is there, MSME, Government of India, digital area. So new platforms are available for all of us being the researcher, and you can always go ahead with these ideas where the startup things is there. So in nutshell, AI is just the magical parrot that learns to mimic the human thinking, help us solve the complex problems, find the treasures, whatever which are already buried, and even conserves like a seasonal sailor. So once upon a time, it has been said by the founder of the AI, who says that it is a new generation and it is smart. So once it has been said that AI is the new electricity. Indeed, it's illuminating our lives and powering our future. just like the electricity did more than a century ago. So this is here to stay. Now you have decided whether you want to update yourself and go ahead with this, or just elaborate that in a more direction. So this is what from my side as far as ideas are concerned for the artificial intelligence implementation. When it's come to the giving your ideas or guidelines, whatever the practical work, research findings work you are doing to make it available globally for the people. Thank you so much, Doctor.
Thanks, Dr. Mahendra, for sharing the tools and how to a researcher should prepare and search and analyze. So very life become a bit easy because when the real intelligence and artificial intelligence means collaborate together. So it's AI is a electricity, or you can say is a new wheel or a new electricity, because then it will make changes which we are in a we are doing in a centuries, we are doing in a decades actually. So we are moving very fast and all. Anybody want to ask any question? Any budding researcher want to ask? Connect Dr. Mahendra. He or she can connect. He has given everything. He has given you that where you can get the funding, how you can structure your research papers and all, and where you can collaborate, and also it's a very comprehensive presentation. You will also get this presentation recorded video. I'll share you everybody so you can get from there. Thanks, Dr. Mahendra, for sparing your time and all.
Yeah.
So anybody want to ask a question? Otherwise, we are moving to the next speaker because we are running short of time and we have to close this. So if anybody want to ask any question, they can email to us and we can forward it to Dr. Mahendra. Thanks, Dr. Mahendra.
Yeah, thank you,
Should we
Doctor.
move
Thank you
on to
so
our
much.
next and the last but not the least speaker, Dr. R. Ramia? Yeah, Doctor. We are moving to the next speaker then. So let me introduce Dr. Ramia. Dr. Ramia has a 17-year of experience in a career in oral pathology and microbiology. She received a gold medal in her postgraduate program in 2008 and received the Inspire Scholarship in 2010 for her PhD pursuit. Her research contribution include facilitating the validation of biomarkers for oral squamous cell carcinoma and oral premalignant disorders. She was the co-investigator on a DST-TIDE project to develop a neuroelectromodulator for xerostomia, resulting in 2 national level awards for his novelty. Her research also involved in quantifying human papillomavirus 1618 oral premalignant lesion in oral cancer, and a collaborative project with the National Center for Nanoscience and Nanotechnology, University of Madras, and a non-scale flexible hemostat funded by BIRAC, New Delhi. Then so far as his papers and publications are concerned, she has more than 300 publications with 4 textbooks and 20 national patents, 1 international patent for her credit. She has held key positions including research coordinator for the International Review Board, guest editor for SRM Journal for Dental Research, and nodal officer for the National Institutional Ranking Framework Committee in 2020. Currently, she is the Associate Dean, Extension Activity, Professor and Head of Oral Biology at Savita Dental College, and is the Director of Truant Academy. She is supervising 12 PhD students. She has received several awards for her academic excellence. She has delivered over 150 invited lectures till date. She is passionate about community well-being and renders services by giving subsidized treatment, and is keen in preventing disease management. So over to you, Dr. Ramia. If you want to add anything, you can add. And in your introduction, if we have missed anything, and you can start the presentation, though we are running late of 50 minutes, but it happens due to technical glitches and all. So we are here, you are you just summarize what we have already learned in a whole 2-day program. Over to you, Dr. Ramia.
Yeah, hope my slides are visible.
Yeah, it's visible.
Okay, so thank you, Dr. Nurul. Again, we've been traveling, I think, more than 4 years now. It's a pleasure to be a part of your conferences, so meticulously organized, and I'm very happy to tell that many of my students also have enrolled this time, and they were also very positive about the feedback about the quality of the topics which are being discussed in your forum. So quickly moving on to the last session, in one way, this is very exciting to be the last speaker in such a wonderfully curated conference on digital dentistry. And I'm here to present the augmented virtual reality immersive learning experiences in dentistry. So this topic I feel is very important to the young teachers over there and the students out there. So the world is very much digital. We know that there is a very big changeover and there is a lot of disruptive changes which has happened over time. And this is something which has made a very deep impact in the treatment aspects. We have been hearing multiple lectures and I've been seeing so many case reports and so on. But this lecture is about emphasizing how these have made a big impact on learning. And that is what is called as immersive learning. So what is immersive learning all about and what it has done? So immersive learning is an experiential training approach, whether it is going to be using virtual reality or whether it's going to be using augmented reality, whether it's going to be mixed reality. It is just going to keep the learners in a very interactive environment, unlike conventional system where interaction is there but very, very minimal. So the very, very interesting aspect which I would love to convey here as a one-line statement about immersive learning is that it has interaction and multi-sensory involvement. Multi-sensory involvement, if you are a teacher or a learner who is very keen about education, scaling up greater heights in education, you would understand what multi-sensory involvement is all about. Multi-sensory is when you're putting into many sensory aspects into learning. The more senses you add into your learning, retention becomes better. So being a teacher for past 17 years and having my own academy, multi-sensory approaches are the best. And once you integrate multi-sensory systems inside your teaching and learning process, you become a phenomenal person of knowledge. And that is what we are going to quickly learn about in perspective to the digital aspects which we are exposed in recent times. So a quick look in the difference between VR and AR. Yes, VR is going to just completely replace and it's going to entirely simulate the experience, whereas AR just enhances. So should we only rely on VR? No, AR is also important in certain aspects of learning. And this is very, very important. So to quickly understand what immersive learning does in dentistry, that is very, very important. As I already said in 2 words, interactive and multisensory. The next important things makes it the special features about immersive learning, specifically in dentistry, it's that it engages the learner deeper than conventional learning. And there is a very safe hands-on practice which can be given before even the student is given a typhoid to learn. And skill retention becomes better because, again, the word retention or the power of retention increases in multiple times when you involve multisensory aspects to it. And then confidence building, of course, that is again a very added feature which comes along with immersive learning. And the next interesting and most important thing is about being more precise, being more perfect. The more perfect you are, the more precise you are, you land up being super successful. It is just not being successful. The quality of work which you can render is something which speaks about who you are in whichever category you are. You may be a teacher, you may be a student, but the quality which you render is something which has to stand out of the crowd. And there comes being standardized always and being at least bringing your output to near perfection. So that is very easily achieved in immersive learning process. And then comes bridging theory and practice. So this is something which every aspect of learning should always have about. So in the small group learning, which we practice and we believe as an institution, and that is why our institution stands out from the rest. So during small group teaching, every 20 minutes we break, and then we put that concept into a practical aspect. So bridging theory and practice is very, very important, and that is where immersive learning is all about. So quick look into the timeline as how these have evolved over time, and where did it start and where are we now? So it started showing its colors, and it started showing its characteristics. It started coming out and popping out, and it started making a very big difference from early 1960s, and then it made a very big platform from 2000 onwards. So we are now 2.5 decades, and the last 5 years have been phenomenally great. So these immersive learning experiences in healthcare education is something very important. So the benefits of immersive learning have been really documented, and there are very important, very interesting statistics given in the literature all over, and it was mind-boggling to just even go through those data which is available in the literature. So having said that, the retention rates which comes along with immersive learning is around 78% when compared to 10% of just reading and 5% with lectures. So that's something alarming, and I would say fearsome also, because this is what has been reported, and this data is available for anyone to visualize. And then the most prestigious consultancy forum, the Waterhouse-Coopers data also emphasizes the role of immersive learning, and it has clearly stated that it is a 4 times more advantage what VR and AR gives into immersive learning than the conventional learning systems. So this is very important. And how are we going to integrate them in the dental curriculum and the patient care? We know that the dental curriculum was modified, and it is just waiting for the approval. But what we should understand is, I wish the dental curriculum is changed as early as possible. We still keep lingering on to a curriculum which was made as early in 2007. So it's going to be 20 years now, and there is a big delay. But council started the work of changing the curriculum 5 years before, and we were a part of the curriculum modification team. And there are very interesting aspects which have been integrated into the curriculum, and I'm just waiting to see the modified dental curriculums to see its light of the day, because sometimes it feels bad to see that NMC has got leaps and bounds before us. And Dental Council also started parallelly along with Medical Council, but Medical Council has gone before us, and it has integrated the latest curriculum, or the curriculum is changed, and there are so many interesting aspects. We are, again, believe me, the new curriculum is at par with all global standards. It has got very, very interesting immersive learning aspects to the curriculum. But the thing is, it has not been integrated yet. We are waiting for many approvals from the higher authorities. But it's all in place. It is ready to be launched. So why should it be done? It has to be done because we have to keep in sync with what is happening on a daily basis. We know that the world is changed through and through, and we have to keep up in pace. And it is very heartening to see that there have been so many papers, so many speakers talk about how digital dentistry has gone super advanced in India, and the case reports have been super impressive. But I would like to emphasize that they have to be put in learning and teaching as well. So this definitely enhances learning, and it also enhances skill acquisition. It is just not about skill acquisition. It deepens the skill acquisition. And we know that upskilling or upskilling and establishing your skills is something which will make you strong in this era of artificial intelligence. How much ever artificial intelligence keeps improving, the more skilled you are in terms of kinesthetic skills, you cannot be challenged at all. You will be you will be standing out of the crowd, and there is absolutely no fear at all. So in that aspect, except for some areas of dentistry, the skill-based sectors are not going to be shaken at all. But what I would like to emphasize at this point to the young minds over there is that you have to upgrade the skills, but at the same time, the skill sector-based domains are going to be unshaken by artificial intelligence. Only thing is you have to grow along with artificial intelligence. You will not be replaced by artificial intelligence. And then comes the competency-based education. That again, competency-based education is what has been really made in papers with the new curriculum. And I'm wishing to see that happen very, very fast. And you can also have very good patient communication, and remote learning and access obviously improves with all these improved stats and improved methods. To be more specific about augmented reality, what does it do in dentistry? We know that there are multiple apps which help in anatomical visualization. We have multiple softwares for anatomy learning integrated in our own library, where students can come and then they can slowly dissect layer by layer to see what is happening. So real-time visualization of the body without, of course, any formalin irritations to your mucosa. There is, without tears, you can just dissect layer by layer, and you can learn dissection. So there's so many interesting apps that we have integrated into the learning for immersive learning experiences of the students. And all these have been possible by, after the introduction of all these augmented reality glasses into the market. So they were taken into dentistry, and then applications into dentistry were made. Similar on the similar lines in virtual reality as well, Oculus Rift and HTC Vive were the ones which made a very big change in the VR domain. And that again made immersive learning experiences leap even more bounds. It made it, I would say, 1,000 times more. And that is something amazing. You should just feel that haptic simulator work, and you should experience how good it is. Sometimes whenever I happen to pass on the Vertice laboratory in the labs which we have, the Vertice simulators, it's so tempting to sit and work and then feel the use of those advanced machinery which we have in our institution. And again, applications of these AR and VR, it is just not about anatomy visualization. For every simulated procedure, for every procedure which you're going to do in dentistry, you can do it in the virtual reality software, practice it, and then do it in your typhodonts, and then move on to patient models. By doing this way, the level of precision becomes it's really on a very, very high levels of precision and perfection we achieve by doing this. And it is just not about achieving precision. We also make it very interactive. And this is the laboratory which is there in our institution. So this is called as Versa. It is one of our one of the state-of-the-art facility which we have at our institution. So these 5 units are haptic simulation units. So haptic simulation are very high-ended virtual reality machinery, where there is exact feel of the tangible feel. You should come and feel to believe what these haptic simulators can do to you and to the students. So it is a very, very interesting feature which we offer to the students. And this makes a very big advantages. So it is just not restricted to our students. We allow students from outside institutions to come, observe, and experience all these domains. We have every month, there is 1 or 2 colleges which come and do student observership programs. And it is just not about dissection, anatomy, restoration. It also plays a very big role in treatment planning in restorative dentistry options. This is again another interesting view of the same laboratory taken with different imaging and different views and different magnifications. So this is again the Versa lab from slightly behind. You can see the typhodons. So why do we have typhodons again in the same laboratory? You can see the haptic simulators lined up in the front and then the typhos at the back. So what the students do is they get trained in the haptic simulators thoroughly. They have metrics to clear that level, and then they come to the prototype where they work on extracted teeth for all the other procedures. By doing this, what they achieve is again, they are experiencing the highest degree of immersive learning. And this gives them immersive and realistic environment itself, and the realistic degree which they are experiencing is something uncomparable, exactly similar to the real world environment is what haptic simulators give. And we see them how they enjoy doing this. And then we also understand that you can do any time, repeat any times. It doesn't matter at all. You can keep repeating, even if you do mistakes, you keep repeating multiple times before you go on to typhodonts. You know that once you work on the typhodont, even though it is an extracted teeth, there is a chance that you will have to utilize more resources. You may make mistakes, and all that is significantly reduced once you practice in your haptic simulation, and then you move on to the conventional system of doing it in the extracted teeth. And again, as a teacher, this is super interesting, and it makes teaching also very, very interesting. And of course, learning also becomes very, very interesting. I just saw 3 or 4 speakers speak about implant placement, about the augmented reality. I'm not going into the details. So we have very good navigation systems, very advanced softwares in our institution, which are used for implant placement. And we have a standalone implant dentistry department, which has placed around 25,000 plus implants till date, and which is something I would say the highest, not only in India, highest in the globe. And we have very good sponsors from all implant dentistry departments. And implant dentistry department is always crowded with patients because they know that they get the world's best treatment with all these advanced systems with precision and care. And at the same time, it is at a very subsidized cost. And the same applies for our the tessellation center, which turns out very advanced augmented reality CAD/CAM prosthodontics. And these again are a very big hit. And every one of our technicians are trained in-house with all these. And we literally do not do every impression is digitally scanned, and it is all CAD/CAM design. So the conventional system is almost nullified, and we do only CAD/CAM crowns and prostheses. But as I keep listing out all the instrumentation facility based on the high-end digital equipments, we also should understand that they definitely involve high setup and maintenance cost. But is it worth it? I would say every penny invested in doing this immersive learning tools is worth it. And this is something, if there is some college management committee over here, or if somebody is listening, please understand that all these investments would definitely reap lots of benefit to your institution, and every penny of that investment would definitely pay back. Believe me, it will happen. And the other big challenge is the maintenance cost. The moment you start investing in infrastructure, the next biggest challenge which comes is maintenance. And but now we know that as we keep discussing with the suppliers and the vendors, most of them are imported. We very clearly make agreements so that the maintenance is also taken care of properly. Even then, there are sometimes very big challenges where they have to come down from abroad. And if they are in a very challenging environment and they can't book the flight tickets and they can't come and do the maintenance, it's a big challenge. But most of the times we try to manage, and we try to address the gap to close down any defects which happen during running of all these. And the most important thing is the challenges related to VR and AR is the tactile realism, which is limited. This happens with the low cost ones, but haptic simulation beats it all, and it is almost close to 100% near simulation experience to live patient experience. That is what VertEZ gives to us. And the other important thing, which usually the fear of conventional minds over there, is that are we over-reliant on simulation? Please believe every student at our institution, we have around 3,000 patient walk-ins per day. So it is just not, we're not going to entirely rely on simulation, never. So simulation is only for early learning, training, learning it in perfection with precision, and then move on to the conventional systems, then move on to the clinical sites. And the number of the quota which they have is huge. Huge, I would say 20 times more than even a government college. So it is not entirely reliant on simulation. Real world situations also are equally given importance, and real world exposure, nothing like real world exposure. So that also has to be balanced. It is just not entirely relying on simulation. You will have to have a balance of both these advantages which has come out, and at the same time never forget what conventional systems has to offer to us. And with this, a quick data comparison of what it means between conventional and versus immersive learning in dentistry, we can quickly see that conventional learning has its limitations. Immersive learning is very, very advanced. It is definitely more advantageous. But again, I would, as a teacher, I've seen conventional learning and I've seen immersive learning as well. I do both, and I strike a balance between both. So that is always the best. So the take-home message for today's topic is that it is definitely revolutionizing dental education, making it more interactive and immersive. I would say the best word which you have to remember is multi-sensory. That is what immersive learning offers. And these technologies not only enhance clinical skills, the confidence level is something which is very important, which as teachers, we are responsible to inculcate that in the young minds. So that's very important. And it is also very important to cater to the Gen Z right now. They are very impatient. So such tools of immersive learning makes them more interested and makes them cooperate in learning as well. So they become excited and they also utilize this and they are super excited. So to cater to the needs of an impatient Gen Z crowd. And again, this is not a negative statement. We know that you are all super fast and we need to keep pace to keep in track with your super fast minds. And embracing augmented reality and virtual reality is definitely needed. But again, not to forget and place emphasis on conventional learning as well. Keep a balance, strike a balance, and that would make a very big teaching and learning experience. Thank you, Dr. Nurul. I'm very, very grateful for giving me this opportunity. And this time, to all the viewers there, this time I volunteered to do this topic because digital dentistry is sometimes very rare. And I really appreciate Dr. Nurul for bringing in this topic as a theme for the entire conference. This doesn't happen always because most of the times it's only part of a conference theme and not the entire theme. I really appreciate Dr. Nurul for bringing in such a interesting topic, and that is why I volunteered. I asked him whether I can give a topic to present, and he immediately agreed, and I thank you very much for giving me the opportunity again. Thank you so much, and I'm open for questions.
So any question, any audience, anybody want to ask any question, they can ask. But you know, in chat, Dr. Ramya, there are people are appreciating the topic as well as the presentation, and it's a very, you know, at the end, you know, it's a very nice, topic which you have covered. So it's a privilege that you are, with us and presenting with the topic which you have mentioned. So anybody want to ask any question? Otherwise, since we have already late and our speakers have, the weekend, everybody has some program and all. So we'll just in a quick, we'll give the vote of thanks to all our speakers who present tomorrow, means yesterday, today, and other organizing committee, as well as those who are in a back end team. So anybody want to ask question? So let me give my vote of thanks, and then I'll because there are 22 participants in the meeting room, so we'll interact with them. We'll just take their suggestions and all. So first of all, we are thankful to all our speakers, organizers. In organizing committee, we have Dr. Uruj Desai. She is organizing secretary. I'm thankful to Dr. T.P. Chaturvedi, who is a professor from Banaras Hindu University, Varanasi. Then we have the speakers from day one, Dr. Rujuta Patil, Dr. Aparna Dave, Dr. Uruj Desai, Dr. Sanjay Jain, Dr. Shaban Khan, Dr. Ratin Das, Dr. Anupriya L, and Dr. Anam Rahman from Al-Amin Dental College. Then we have 5 jury members who joined in the morning, and there are 10 presentations for faculty as well as students. So we have Dr. Trevil Prera, Dr. Nishant Kumar, Dr. Gulam Sharwa Hasmi, Dr. Aparna Davi, and Dr. Rohit Agarwal, who judged the papers presented by those faculties as well as students. Then we are thankful to Dr. Shanin Farishta. She has spoken on laser. Then Dr. Anisha Parmar, biomimetic dentistry. She has presented. Then a very stalwart senior implantologist, Dr. Sejin Chandran, Dr. Harshvardhan Arya, Dr. Sankalp Mittal, Dr. Puneet Batra, who is from Manav Rachna University, Faridabad, Dr. Abdul Hamid Attar, Dr. Abhay Lamba, Dr. Neeraj Rohida, Dr. Nitin Thomas, Dr. Rohit Agarwal, Dr. Mahendra Patet, and last but not least, Dr. Ramya R. We have Dr. Pulin Saluja. She is not available. She is supposed to talk last, but she is not available. So with this note, we have the marketing team headed by engineer Apsar. We have the designing team headed by Israfil Khan. The Larval Technology is our partner, the management strategy, who helped us in designing this program and designing the website and all. So these are our back-end team. I have thankful to my designer Khalid. He designed the brochure, and he come out with a very good brochure and all. And our telecalling team is also there, who is keep calling, and the registration team as well. So with this note, I just would like to engage the people who are there in the meeting room. If they want to add any suggestions, their advice, we can use it, and we'll do it again next year with more vigor, more innovative topics. And we'll go across the globe. This time we try to reach speakers from Dubai and UK. Somehow we get the confirmation, but ultimately due to time constraint, we are not able to join in. So next year onwards, we'll try to get some good global speakers on board. So anybody want to give any suggestions, they can unmute and give the suggestions. Otherwise, we'll sign off the day with the place that will come again next year. The same International Digital Dentistry Congress. This is our Madden. So Digital Iddcon 2.0 will be more engaging. We would have 3-day discussions. We'll do Friday, Saturday, Sunday. Next year, anytime in a month of July only. I'm just asking any suggestions, any feedback, because you have, you are the, guiding source, and you will just guide us how to make it more engaging, more friendly and all. Anybody want to unmute and share his experience? How the last, the Saturday and today, the Sunday, how, we did our, the presentations and all. Okay. So there is no any suggestions. You can write us on osiddcon@gmail.com. There is a support@iddcon.com. There's a 2 email ID through which you can share your feedback, suggestions, advice. and so that we can improve when we'll do it again in 2026. So thanks all. Thanks for your machine learning joining, giving your precious time and all. So with this note, I want to add on. Dr. Aparna, you are there. Would you like to add anything? Otherwise, I'll thank you
No,
so much.
actually, thank you for a good conference. You really had very good speakers. It was a nice experience, and at least I look forward for another conference. Yeah, am I audible?
Okay, so with this note, let me conclude for the day. We are signing off, and we'll connect again with the same topic next year with more speakers, innovative topics and all. So thanks all for giving your precious time and making this IDDCon 2.1.0 a successful event. Thank you all.